Check, 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 check.
Check. Ladies and gentlemen, distinguished guests and esteemed colleagues and dear delegates, good morning and welcome to the National Seminar on Systematic Review and Meta-Analysis Nursing Perspective. It is an honor to have you all here. The moment we have been waiting for us has arrived. Our first presentation will be delivered by Dr. Sharda Ramesh, Principal of VMCon. Allow me the pleasure of providing a brief overview of our esteemed constitutions. Dr. Sharda Ramesh is a doctorate in Faculty of Nursing from Sri Ramachandra University, Chennai, and an alumnus of College of Nursing, CMCH Vellore, has 37 years of experience that includes various cadres of nursing service, education and research, both in India and abroad, University of Wisconsin, USA, invited for faculty exchange and has presented various sessions for graduate nurses in 2006. She has traveled extensively to many countries on invitation as keynote speaker. Ministry of Health Kuwait has invited on the occasion of their Golden Jubilee celebration as a keynote speaker to the International Conference 2012 and as mentor for their School Health Program 2009. She has to accredit many research publications including 72 Scoopers, UGC Care List publications, 6 books and chapters written for nursing with top-notch publishers. She is invited editor cum book reviewer for TNAI, national and international journals. She is invited as resource person for the GNM Revised Syllabus Orientation Program, an expert member for Tamil Nadu Nurses and Midwife Council to review the Tamil Nadu State Mental Health Policy Draft 2018 and National Health Policy Draft 2015 by TNAI. She has recently honored and invited as a keynote speaker for the Scientific Text Conference 2023 in Dubai. One of the resource person for the e-learning module for TN available on the website of TNRMC in hematology course, written chapters in TNRMC for textbooks on community health nursing and nursing education, possess extempore dialoguing competence both in Tamil and English, so was invited by various television channels at Chennai for special speech on different occasions. Has headed forums of nursing, nutrition and dietetics, police training academy, PhD workshop, hospital nurse administrator forums, NGO schools, teacher training academy, daycare schools and yoga for schools and nursing colleges. Holds crucial positions in various research and advisory committees, board of studies, former Senate member for TN Dr. MGR University, external expert member, academic council, human ethics committee, university library committee member, university research advisory member in various reputed university and senior advisor for nursing regulations for the UP state government in association with John Hopkins Program for International Education in Obstetrics and Gynecology, was one of the international invited panel expert members during 2013-2016 of Buta Nu Delta Inc., an international Philippines Nurses Society. Has been conferred various prestigious awards like Sigma Theta Tau Award 2008, Academic Excellence and Outstanding Contribution to Research Award from ICCR 2013, Best Principal Award, Best Women Award, Best Administrator Award 2019, and Best Nursing Educator Award from TNAI. Recently, she was awarded as Distinguished Director, Gurukul Academic Awards 2022 by JS University, VMRF Women in Healthcare Leadership Award 2003, Best Nursing Teacher Award 2023 from the Nursing Teachers Association India, affiliated to Commonwealth Nurses Midwife Federation, London. She has organized many international, national conferences, seminars and webinars, organized more than 300 health camps on various occasions. She is a recognized guide and thesis evaluator for many university, trained ad hoc inspector for Indian Nursing Council, trained peer team assessor for NAC Government of India. This 4 minutes is not enough to tell what she has done for the 4 decades. Now, let's welcome Dr. Sharda Ramesh to blast on our topic.
A warm good morning to one and all here. Good morning, most honorable Dr. Vishnu Bhatt, sir. I am very small in introducing this topic when an expert is here, but nevertheless the topic is given to me and we are looking at a buffer of time and hence we have gone into it. I think we have to switch off those lights. Okay. So the topic systematic review, usually this topic is not very much dealt with in nursing. It is not dealt much in, I think you have to switch off those lights. These ones, yeah. Otherwise it's very light color also. So here we are looking at systematic review. Qualitative research, quantitative research, all of us have studied number of times. Even the students know that we are looking at projects and dissertations and we are working on it. But systematic review is the current trend. These are two entities. One is systematic review, where you are collecting all the other research data on one particular subject. For example, you are looking at pain or pain management or pain care nurses are giving. So across published and unpublished data, just to give you a preview, unpublished data, every research you are collecting, a panel of experts sit and collect all these data on pain care management done or pain care given by nurses across the world. And it includes both published and unpublished thing. So the core keyword is pain care management in nursing. So you are sitting and collecting all the data and looking at what are the strategies the nurses across the world had done on pain management, how they have relieved pain for, say, suppose it's a post-op pain. There again you are going to define that. Then you are defining very clearly post-op pain care management by nurses across the nations, across the world or international like that. So then you are collecting all the data on what all the strategies they have done. So that makes a very good evidence stating that, say suppose across the world, hypothetically, I'm saying, suppose across the world, all the nurses have done some, some Reiki therapy or some complementary therapy, and they found that there is some good effect on pain relief among the post-op patients. Then this systematic review states that nurses looks at post-op pain management care as Reiki therapy, and it is very effective also. So that makes a very good evidence because it is tried in all the nations, almost every study, including unpublished data you are taking and looking at it. Whereas meta-analysis is basically a statistical accumulation or a pricing of this particular data, or it could be anything else. So that is the two difference. So this systematic review, how it is helpful, then that's the whole, this whole day is going to be going up and down on this particular topic. Just to give you a prelude of what this, because many students are also here, I can see, and you will think that what is this systematic review? Systemic review, you all know, assessment, nursing assessment, when you do, cardiac or lung profile or something, you are doing some assessment, say some gastroenterology, then you do all the measures of assessment to say how that system is working or not working. This is a systematic, the word itself is very clear, it's very systematically done. That is why it is not done very much, we are not recommending it for the novice researchers because it's very difficult for you to maneuver it and get the points. But it is done by the panel of experts and it's very good for bring out your evidences. So now what I have told you is here. Okay, overview of a particular research question. As I told you, what is a particular research question? Just now I told you pain care management or by nurses. Okay, if that is your question, that is your research question. What do nurses do across the world to relieve the post-op pain of, say, orthopedic surgeries? Now, that's very painful, right? Bone surgeries are very painful. So how do you relieve that pain? So that is what here we are looking at. Identifies, selects, evaluates and synthesizes all quality research evidence relevant to that question in order to answer it. As I told you, in a very one-liner I said, okay, your pain care management across the world you are looking at, you are collecting all the nurses' data. World la engella nurse enna pain care post-op pain, orthopedic pain. Again, we are mentioning that key word is there. So orthopedic surgeries, major surgeries, say suppose there also you can define road traffic accidents or something like that. you know, then you are coming out with some evidence. It is a summary of medical literature basically. நீங்கள் பண்ணுற ஒவ்வொரு ரிசர்ச்சும் நான் பண்ணுற ஒரு இட்ஸ் அ மெடிக்கல் லிட்ரேச்சர். இட் ஆட்ஸ் நாலேஜ் டு யோர், இட் ஆட்ஸ் credibility to your professional care and intervention. So that is what here we are looking at, and uses explicit and reproducible methods to systematically search. Very explicit. You don't hide or do anything. அவங்க அங்கே என்ன கொடுத்தாங்களோ அதை தான் நீங்கள் சிந்தசைஸ் பண்ணுறீங்க. whereas when we do our study, we try and do some adaptation and flex it. Karthika, we need some silence. Systematically and critically appraise and synthesize on specific issue. Specific issue, I already told you the example. So with that prelude, you can look into the whole day, the sessions, how the experts are going to take it. Now, what often it is written by a panel of experts. It's very difficult for, as I told you, a novice researcher to look into it, because you'll have to do lot of review, even for your dissertation, thesis, review of literature, 5 years within, உங்களுக்கு சொல்றதுக்கே கஷ்டம். I've seen that. We understand the thesis work or the dissertation. We also have gone through that rigorous thing, review of literature. So can you imagine, across the world, ஒரு pain care management, post-op, அந்த ஒரு word orthopedic மட்டும் எடுத்து பார்க்கறதுன்றது, it's lot of, expertise is needed to collect that data. And it is very useful for policy makers on decision making. As I told you, at the end of this study, say suppose, example, I'm just telling example, I have not done this, I'm just saying, across the world, many nurses have done some therapeutic touch to relieve the pain. I know all of you know what a therapeutic touch. Actually, anga touche kadiyadu. Do you know that? There's a sort of a hypnotic thing that you will above little, and the magnetic field ku mele dhaan kai vechi you'll have to do, and you got to train yourself for that. Reiki and all does that, right? So you are identifying that across the world nurses have done this. Okay, so that is what you are looking at. So once you have done that, and the research says that this particular research question answers that across nations nurses are doing this, then you are going to do a policy making on that. அப்படி ஒரு இடத்துல வந்தது தான் ஆயுஷ் எல்லாம். ஏன் இப்போ யோகா சொல்கிறாங்கன்னா, நிறைய ரிசர்ச்சஸ் அவங்க பண்ணி இண்டிவிஜுவல் ரிசர்ச்சர்ஸும் பண்ணாங்க, நிறைய சிஸ்டமேட்டிக் ரிவ்யூஸும் வந்தது. தென் தே ரியலைஸ், ஓகே, யோகா டெஃபினெட்லி, ஸ்கை எல்லாம், சுதர்ஷன் கிரியா யோகாலாம் நிறைய, இஃப் யூ கோ அண்ட் search the literature, lot many things have been done. That is why they are saying even in Nimmans they are practicing sky, Sudarshan Kriya Yoga. The psychiatric students must be knowing that. So that is how. So it is very useful for you to bring in such interventions and treatments as a policy maker you can bring in, and it is sort of an evidence-based medicine. You are not just saying out of the blue, just with one study. You are looking at 360-degree dimension, yella country, yella nations, published, unpublished. Usually published data numbode they are experts, especially in Scoopers or UGC care numbode avanga romba high profile researcher ah irupanga. Ana unpublished data aliyum sometimes it gives lot of value, right? avanga chinna researcher pannirpanga, aduvume useful ah irukum. So that is how it is going, and the hierarchy of evidence is got here, and most reliable evidence with less bias, because you are not doing any research and saying this is the one. Someone else has done it. You are taking and filtering and going ahead to get this topic here. Okay, so pyramid of evidence in research. Now how do you go with that? Background information, expert opinion you are getting here, case control study, case series, reports adu adutha level, then cohort studies, RCTs. Usually நம்ம சொல்றது RCTs are the golden standard test. All of you know it's very difficult to do the RCT. அதுலேருந்தும் எடுக்கிறீங்க. தென் கிரிட்டிக்கலி அப்ரைஸ்டு டாபிக்ஸ் அண்ட் ஆர்டிகல்ஸ். இனிஷியலி 2001 and 2லாம் யோகா வரும்போது that lot of critically appraising things were happening. Which yoga is better? இப்போ everyone is saying yoga is better. அதுலேயும் meditation or it's certain things like Sudarshan, now one of our students is going to do some huge therapy and things like that. So now they have come into a compartmentalization, but initially it was critically. Even nurses, when they did, they were asking why nurses are doing this. Why nurses are looking at Reiki? Why in maternity care also? They were looking at why they are looking at aqua therapy, no? They go get into the swimming pool, dolphin deliveries. I've seen in US, they along with the dolphin, they are swimming in the swimming pool till the maximum pain and the cervical dilatation happens, and then immediately they are taken out and happens a normal delivery. So that is a critically acclaimed. Initially they were thinking, why dolphin? என்னதுக்கு தண்ணியில் போய் உட்காரணும், என்னதுக்கு ஒரு அந்த ஏரோபிக் பாலில் உட்காந்து ஒரு டெலிவரி பண்ணணும், பர்திங் சேர்ஸ் யூ ஆல் ஹவ் சீன், என்னதுக்கு பண்ணணும்? ஸோ ஆல் தீஸ் வேர் critically acclaimed earlier. Now because of all these researchers coming up, now they have accepted it, these are good ones. Instead of taking the mother and putting her on a lithotomy, 10-12 days she will have a pain on her thigh, because these are the women IT professionals or sedentary workers. நிறைய பேர் அந்த டெலிவரியில் எக்ஸ்பீரியன்ஸ் பண்ணியிருப்பீங்க. டிவிடி கூட வந்துடும், ஸ்டாக்கின்ஸ் எல்லாம் போட்டுட்டு வேணும் அது இது பண்ண. ஸோ பர்திங் சேர்ன்னும் போது ரொம்ப ஈஸியாக இருக்குது. ஸோ தீஸ் ஆர் த திங்ஸ். ஸோ தென் சிஸ்டமேட்டிக் ரிவ்யூ. ஸோ த குவாலிட்டி ஆஃப் எவிடன்ஸ் ஹியர் இஸ் பிக்ட் அப் ஃப்ரம் ஆல் தீஸ் திங்ஸ் அண்ட் டேக்கன் இன் டு அ research. So here you can see, I'm sorry. So here your published evidences, unpublished மேலே பார்க்குறீங்க. இது ஒரு ஃபில்டர் மாதிரி. நம்ம டீ வடிகட்டுறோம் இல்லையா, இஞ்சி போடுறீங்க, என்னென்னதோ போடுறீங்க, இடிச்சு போட்டு கீழே வர்றது எப்படி வருது அந்த டீ? அது மாதிரி இஞ்சி போட்டால் இஞ்சி வரும் இல்லை, ஸ்மெல் ஆஃப் ஜிஞ்சர், அதரக் சாய், நல்லா இருக்குது, right? So that is what in systematic review we are doing. We are taking published, unpublished data, putting all together, நல்லா sift பண்ணுறோம். என்னத்துக்கு? பெயின் கேர் மேனேஜ்மெண்ட், நர்சஸ், orthopedics, அதெல்லாம் வச்சு we are looking at, and then your findings are very very clear and stating, and it is saying that there is a lot of evidence that this Reiki care is good for relieving pain or whatever. So that is exactly what we are doing at a systematic review. So then what is the author's job here? நீங்கள் கேட்பீங்க, மேம் நாங்கள்லாம் கஷ்டப்பட்டு டேட்டா கலெக்ஷன் பண்ணுறோம், இப்படி ஒரு ஸ்டடியை கொடுத்தா நான் டேபிள்லேயே முடிச்சுட்டு போயிருப்பேன்ல, என்னத்துக்கு எங்களை கொண்டு போய் ஐஆர்பிலையும் அதுலேயும் இதுலேயும் உட்கார வைக்கிறீங்க? Many of you must be having that question right now in your mind, but this is a much more difficult task. So here what you do is, initially மேலே பார்த்தீங்கன்னா, is the light working here? No, it's not working here. Yeah, it is there. Identify the issue and determine the questions. Yeah, thank you. Thank you. So, identify the issue and determine the question. Just now I said post-op pain, orthopedic pain, and in the patient, all those things. Then write a plan for review. Number pandra mari, and the protocol has to be written here also. There is no doubt about it. Search for studies. You have to collect, sit and do lot of reviews, sit and do. நீங்கள் நினைப்பீங்க டேட்டா கலெக்ஷன் இப்போ நான் கொஞ்சம் ஓபி அடிக்கலாம், ஸ்டூடெண்ட்ஸுக்கு சொல்கிறேன், டேட்டா கலெக்ஷன் கொஞ்சம் வெளியிலலாம் போய் சுற்றிட்டு வரலாம், ஃப்ரெஷ் ஏர், இதில் ஒன்றுமே பண்ண முடியாது. ஆல் த டைம் யூ ஹேவ் டு சிட் அண்ட் சர்ச் ஃபார் ரிவ்யூஸ். ஸோ ஸ்விஃப்ட் அண்ட் செலக்ட் த ஸ்டடீஸ். உங்கள் டாப்பிக்கு தகுந்த மாதிரி, ரிசர்ச் கொஷனுக்கு தகுந்த மாதிரி யூ காட் டு செலக்ட் இட், and then extract the data from studies. And the recommendation of the study enna solludu, what have they concluded, have they accepted the hypothesis or they have rejected the hypothesis? All these things you will look at, and then you assess the quality of the studies also. Who is telling that? You know, whether it is coming from the highest person or it is just an unpublished data, and how much credibility it carries, all that you will look into and combine the data, the synthesis of your statistics. That is what is meta-analysis. You understand? And the statistical analysis பண்றது தான் meta-analysis. Discuss and conclude the overall finding. Not just one word la சொல்லிட்டேன், ஆமா data, almost you have taken some 1000 or 1500 studies, and everyone is saying, every nurse is saying therapeutic touch or a Reiki management of pain is very good, intervention is very good. So then you are doing a review and disseminating the findings, saying to the world, the scientific world, that this is the better thing for nurses. அப்படி வந்தது தான் neonatal cap. I don't know how many of you know. Sir is the expert here. Neonatal cap initially was designed by a nurse, neonatal nurse. Then she said, why naka the body weight, if you compare, it is the largest proportion in the infant, the newborn, right? So she felt that if hypothermia has to be relieved from the newborn, then first cover the topi potu utrunga papakku. So that is how the nurses, so that time they didn't do a systematic review, but nevertheless after so many studies we identified that yeah, hypothermia is relieved. Adikadam, as the baby is born, we say put the cap for the baby, so that we could relieve lot of hypothermia now. Kangaroo mother care, that again was brought in by nurses only. So there also you have a weightage. So lot many people have done it, lot many reviews had been done, and so many expert nursing have been doing it. Then ultimately they said this, if you have to give a maternal care, give a kangaroo mother care, so that the bonding is good, the breastfeeding is good, the baby is off the hypothermia, the baby gets lot of love and affection and all those stuffs. So this is how you are doing as an author. So what are the challenges faced during a systematic review? Please tell me the time, so that I should not exceed the time. Too many studies to search. That is the biggest thing. அதுதான் நான் சொன்னேன்ல, யூஸ்வலாக நம்ம நினைப்போம், ஐயோ பேசாத இதே மாதிரி ஒரு ஸ்டடி, நீங்கள் எல்லாம் எம்எஸ்சிஸ் ஆர் ஹியர், தே மைட் பி திங்கிங் பேசாத இப்படி ஒரு ஸ்டடி இந்த மேடம் கொடுக்காது, என்னதை எங்களை கொண்டு டேட்டா கலெக்ஷன், கோ ஹியர், கோ தேர், கெட் த செட்டிங் பெர்மிஷன், கோ டு ஏவிஎம்சி, ரன் அண்ட் ஆஸ்க் ஜஸ்டின் மேடம், ஆல் தீஸ் திங்ஸ் we are telling. So why it is, but it is very difficult if you can see. And there could be publication bias. Only studies with significant findings are published in Scopus and good journal if you take probably. But if you take other journals, it may be a faked data also. We do not know. So based on that, you cannot come to a conclusion. That becomes a challenge also for the authors to come with the result. Inconsistencies in findings because of flaws in study conduct or random errors. As I told you, inconsistency. In some studies, I don't know, it depends on the methodology that particular place they have done. So when you do that and you are taking that and saying that is the best way, it becomes very difficult and it is not correct. That is the biggest challenge. அதாவது இது உண்மையா பொய்யா, இந்த டபுள் ஆக்ஷன் எம்ஜிஆர் மாதிரி, ஓகே, நல்ல ஒரு எம்ஜிஆர் இருப்பார், வில்லன் ஒரு எம்ஜிஆர் இருப்பார், ஓகே. இப்போ இது ரெண்டு பேரும் ஒரே வேஷம் போட்டு போகும்போது இது யார், எந்த நல்ல எம்ஜிஆரா கெட்ட எம்ஜிஆரா? தட் இஸ் த கொஸ்டின் லையிங் வித் அஸ். ஸோ தட் இஸ் வாட் எக்ஸாக்ட்லி ஹேப்பனிங் இன் தி this thing. That becomes a random error in the research. So we are looking at that as a biggest challenge. So how to conduct a systematic review? Protocol, as I already we have dealt that. Again, to review that in this thing, you can do a protocol development. Of course, the expertise should be there, your IRB, IEC, everything. Database searches should be there. And someone is going to talk on Cochrane search, literature search, all that they're going to tell, tell us how to do the review. யூஸ்வலாக நம்ம ரிவ்யூ ஏதோ நம்ம VMRF டிஜிட்டல் லைப்ரரி போகிறதுக்கே கஷ்டமாக இருக்குது. தட் ஆல்சோ வி ஆர் நாட் சீயிங் அ ஃபுட்ஃபால் தே, அட்லீஸ்ட் ஆன்லைன் டிஜிட்டல் ஃபுட்ஃபால்ஸ் வி ஆர் நாட் சீயிங் தே. ஸோ திஸ் இஸ் அகேன் யூ ஆர் டூயிங். அண்ட் ஃபஸ்ட் லெவல் ஸ்க்ரீனிங் பேஸ்ட் ஆன் த டைட்டில். எப்போவுமே நம்ம என்ன பண்ணுவோம், டைட்டில் வச்சு பார்த்துட்டு வீல் டேக் தட் போஸ்ட் ஆஃப் பெயின். ஆனால் வென் யூ கோ இன் டு த ஃபுல் டெக்ஸ்ட், many of you must have realized that, those of you who are doing, when you enter the research, உள்ள full text போகும்போது totally வேற மாதிரி இருக்கும் picture. So now what happens to this particular author, she or he has to read the whole thing, complete படிச்சிட்டு தான் then you can take it, and that takes lot of your time, right? Lot of your time. And then final screening based on the full text. Then this full text should satisfy all your whatever laid protocol. Then only that becomes one study. So that is what we are looking at. Come, please sit. Good morning, welcome. So list of included studies, again all the studies, wherever, international, national, everything you are looking at. Linking of multiple publications as single study. Publication நிறைய இடத்துல பண்ணிருப்பாங்க. Salome இஃபெக்ட்னு சொல்கிறாங்கல்ல, ஒரு ஸ்டடியை எடுத்து வெட்டி வெட்டி ஒன்று டிஸ்கிரிப்டிவாக போட்டிருக்கோம், ஒன்று குவாலிட்டேட்டிவ் போட்டிருக்கோம், ஒன்று குவான்டிடேட்டிவ், ஒரே ஸ்டடி தான் இருக்கும், ஒரே ஆத்தர் தான் இருக்கும். ஸோ that becomes this thing. You will have to extract it, data extraction and critical appraisal, and then you are looking at a qualitative report or a quantitative report, and then you are making it as a thing. Now, steps in conducting a systematic review: formulate a review question. As I told you, post-op pain, orthopedic pain in the nursing care and the nursing care management, and it could be you are defining as a Reiki or therapeutic touch or a normal this thing, and what are the assessment they have done, visual analog scale or any other scale, numerical scale or whatever. Interpreting the evidences, so collect all the study, interpret the evidences, and tell the world that whether Reiki is good or not, whether they have achieved the success in managing the pain in the post-operative period. Assessment of bias in included studies, you have to filter it, you have to filter it. Then updating the review, then identification of relevant studies, that's very important. If you have to look into relevant study, then you have to read the full text. Don't just go with the abstract. Abstract could be misleading. Core keywords எல்லாம் இருக்கும், அது நீங்கள் ஈஸியாக கம்ப்யூட்டரில் ஃபில்டர் பண்ண முடியும். As you even the mail we see, just say you want post-op-னாக்கா இல்லை registrar mail-னா கடன்னு வந்துடும். But that could be a CC to register, that could be a different thing. So like that, when you are doing taking the extraction of data, it becomes very difficult. Then you have to do a meta-analysis of the statistical findings of each study, and then come out with a synthesis of data, collate it, and then write up the review. So these are the steps in conducting your systematic review. Then what are the advantages? It gives you explicit methods which limit the bias. It gives you very nice, beautifully it will tell across the world this has been done, and it's very good to take it. Draws reliable and accurate conclusions based on your, yes, how many minutes? Already done now. Okay, I'm finishing it. Okay. And very useful decision making tool, already I told you. Based on that you can do best form of evidence and generation of new hypothesis. From then on someone can say Reiki reduces post-op orthopedic pain or post-op cardiac pain, cardiac surgery pains. You can compare it. So you can develop lot of hypothesis in that and increases the precision of the results. Limitations of systematic review, as I told you, location and selection of studies. International சொன்னா கென்யாக்கும் இங்கேக்கும் demographic variables are different. How can you say that whatever worked in Kenya population will work for Indian population? That becomes a totally different thing. Heterogeneity, it's like one khichdi, okay, everything is put in that. Is it good or bad? That has to be answered. Then loss of information on important outcomes. Sometimes that study would have told so many limitations, so many things, but we are only taking those findings and say okay, they have accepted the hypothesis, or Reiki is a good method. They could have given some other aspects also in that study. Inappropriate subgroup analysis, that again depends on it is a human error or researcher's error, that has to be controlled here. The meta-analysis, I'll quickly go through that. It is a statistical analysis, as I told you, a large collection of analysis results from the individual studies you are taking, and for the purpose of interpreting the particular finding. Post-op pain, nursing care management, something like that. So there are so many in the meta-analysis, cumulative, that I think the future speakers are going to talk the whole day. You have cumulative, you have retrospective, you have prospective meta-analysis. And types of analysis, I'm just leaving it because someone else is going to take, I guess. Just for you to analyze, look at it in two different things, secondary and primary analysis, and you can do the other aspects of subgroup analysis. You can also look into sensitivity analysis and main objective and pooled estimate of effect size. Now, the quality assessment in the meta-analysis, overview of this again someone is going to take for you today. Prisma checklist is there, Amster tool is there. These are the three commonest ways. It's all available in the this thing you can look at. So there are checklists for studies. I'll just leave it with the organizers. the study design. It is dictated as to how, what the direction is given to us already, how you will do it. Suppose you are looking at a case report, then you will have to look at a guideline of care. Now what is care? Consensus based on clinical reporting guidelines development. So that is a abbreviation given to you. So each one has got one thing, as you can see here. STROB, strengthening, if you are looking at an observational study, strengthening the reporting of observational studies in epidemiology, this is available again. And if you are looking at analytical study, STROB again is done, and RCT, it's consolidated standards for reporting trials. You have, everything is dictated, everything is formulated, so you cannot just deviate out of this, you will have to follow that. It depends on what sort of studies you are going to select for this systematic review, and the guidelines are already laid, so you will be fixing yourself in that guidelines and searching the data, review the literature for these, based on these guidelines. Suppose you are looking at a RCT, you are doing a consolidated standards for reporting trials, that is how the tools are there. You will, based on that, you will collect the data and filter the data and disseminate the knowledge to everyone. So these are some of the things. NCT means, the non-RCT means trend is there, systematic review and meta-analysis, PRISMA, as I told you, preferred reporting items for systematic review meta-analysis is there. Diagnostic test accuracy means you have QADAS and STAR, quality of diagnostic accuracy standards, standards for reporting diagnostic accuracy studies are there. Interventions for quality and safety care, you have SQUIRE. You have economic evaluation and health interventions, you have CHEERS. So CHEERS says consolidated health economic evaluation reporting standards. It's all laid already. You got to go with that. And qualitative study, you have correct. That is consolidated criteria for reporting qualitative research questions. So this is how you have few guidelines. My topic here is to give you an overview of the systematic review, and also we have a hidden agenda of managing the time in the morning for the registrants. So I am there as a guinea pig entering into the thing. I hope I have given you the prelude for this whole day of national conference. We have handpicked the experts from across the nation, AIMS and Symbiosis and Mahe Manipal. All the experts are coming, and I hope from Ramachandra, I hope you all will enjoy. Of course, our own dear Dr. Vishnu Bhatt is here. I hope you will be staying tuned for this whole day and capture the ideas of this systematic review. I thank the organizers for giving me the opportunity. I should thank Dr. Sangeeta, who laid the foundation for this conference. And with that, I say a big thanks for all of you. Thank you.
I extend my gratitude to you, ma'am, for your thought-provoking presentation. Practice does not make perfect. Only perfect practice makes perfect. It's time to know about the perfectionist Dr. Vishnu Bhatt. Sir stands as a revered figure in the field of pediatrics and neonatology, currently serving as an advisor in medical research and professor at Aurobindo Medical College and Hospital, Pondicherry. With an illustration career spanning more than 4 decades, Dr. Bhatt has dedicated himself to the training and mentorship of undergraduates, postgraduates, and postdoctoral scholars.
Can I start?
So, one second. Postdoctoral scholars in pediatrics and neonatology. His scholarly contributions are extensive, encompassing 390 scientific papers and 71 chapters in acclaimed medical texts. His H index is 38 and I-10 index is 92. Citation is about 4,950 and reads is more than 1 lakh. Notably, he has edited seminal works on topics such as protein energy malnutrition, NICU protocols at JIPMER, and NNF protocols in perinatology, Dr. Bhatt's academic impact is further underscored by his role as associate editor for the Indian Journal of Pediatrics and his active involvement in reviewing articles for numerous national and international medical journals. Throughout his career, Dr. Bhatt has been honored with the plethora of awards that highlights his exceptional contributions to medical research and education. These accolades include Best Intern Awards, multiple Best Scientific Paper Awards from the esteemed bodies like JIPMER Scientific Society and Indian Academy of Pediatrics, and oration from prestigious forums such as National Neonatology Forum and JIPMER Scientific Society. His outstanding achievements have been recognized with scientific honors, including Lifetime Achievement Awards from the Pondicherry chapter of the Indian Medical Association and Medical Education Unit, India, as well as the Dr. Rita Sood Memorial Oration. Dr. Bhatt's dedications to advancing medical education is evidenced by his role as a key figure in medical education awards and conferences, including ICON 2023. In addition to his academic prowess, Dr. Bhatt has been recipient of prestigious fellowship, including the Fellowship of Indian Academy of Pediatrics and WHO fellowships in basic MCH care in Nepal and Thailand, and neonatology at the University of Illinois, Chicago. His illustration career and profound impact on the field of pediatrics and neonatology continue to inspire and shape future of medical research and education globally. So with this short note of introduction, I invite Dr. Vishnu Bhatt sir to take over the session.
Good morning. Thank you for the long introduction. I thought I may not have to speak at the end because Madam has given a lot of introduction followed by introduction of me, and there is very left for me to add. So my main task is to tell you how to develop questions for a systematic review. Review articles are very important because it gives you a consolidated idea about whatever happening in the field. So you may have a narrative review or a scooping review, or it may be a systematic review. So today's program is mainly concentrating on systematic review. Move on. Madam has already told the evidences level. So if you read journals or go to the website, you will find lot of articles in the basis like editorial, expert opinion, case reports. But as you go higher up, the number of articles may be less, but the evidence is much and more. So systematic review has kept at the top because it is based on the analysis of various publications. Although RCT will give a lot of evidence, systematic review not only gives one RCT, multiple RCT based subject which will be analyzed and written. So when you do systematic review, you should have relatively good quality papers should be there, evidence should be there in good number, and also it should be less heterogeneous. Whatever you are choosing should match with the objective or the research question. Now I will talk a little bit about scoping review because many people write scoping review articles, but the evidence from a scoping review is much less when compared to systematic review. Here we do not have a very specific research question. You take the subtopic, then you go through many articles, analyze them, make your own impression. That also gives a lot of information, but it is not systematically analyzed, unlike a systematic review. Here the research idea or the question is very, very broad. You do not have very specific inclusion exclusion criteria, unlike a systematic review. And when you read many articles and write, it gives an idea about whatever knowledge exists in the field and also allows you to think what more need to be done. Here there is no formal quality assessment. It will identify the gaps and the knowledge which exists, and it allows you to think what more investigation need to be done in that field. So if you compare the systematic review and scooping review, the systematic review has got, as Madam has said, definitive research question. You have inclusion exclusion criteria. You analyze the quality of the paper, then you consolidate. Unlike scooping review, which does not have a very specific research question, you have an idea on which you collect data, you analyze, compile, and then present, giving your own summary and ideas. I am going a little fast because Madam has covered many of the issues which I need to be covered. So in a systematic review is conducted according to a clearly stated scientific research methods, and it is designed in such a way the inherent bias and errors will be eliminated. So large amount of data will be there published in various journals. Nobody can read each one of them because in a time is very short. That's why the systematic review helps us in understanding the topic much better, because the person goes through each one, analyzes and submits. Usually a systematic review will not be done by one person, 2 or 3 people will do, because the bias and the thinking can be, if there is a difference of opinion, it can be adjusted, unlike a scooping review which may be done individually. So all this data which is available, we will collect, analyze depending upon the condition which you want to do research. So there should be a clearly stated title and objective. The first thing is that what is the problem, what you want to analyze. So you should think about the topic. Then you should make a comprehensive strategy. Which are the publication you will use for analysis? Unpublished, published, both can be combined, and you should have explicit criteria for analysis, which has been to be discussed between your group and then finalize. And when you make the questions and the research idea, it should be in the PICO format. What is this PICO format? Anybody? Wonderful, wonderful. So you should include what population you want to include. It may be a study related to nursing, it may be related to physiotherapy, it may be related to some testing of some equipment or medication, anything. So you should have in which group you are going to study, whether you want to study young population, old population, or hospital patient. So the population has to be described, and every this thing there should be an intervention. What actually you are going to test? There will always be a comparison group. One group will give whatever you are testing, other group will not be given. So that has to be specified. And finally, what happens? So each article which you are reading should be having this way analyzed, so that you can get a consolidated idea. So there should be a clear presentation for analysis and the methodological quality, because each publication qualitatively may be different. So we need to sit together and analyze qualitatively, and if you exclude some of the studies, from the list, then you have to say why you are excluding. Maybe that the data may be a duplication, or the data may not of interest what you are looking for, or there may be some shortcomings in the methodology. So that has to be clearly stated. So first and foremost, once you get the title, you need to develop a research question and you have to develop a hypothesis. What actually you are going to test. Are you all with me? So you have to clearly say what is the population you are going to include, what is the intervention you want to study, what are the outcomes which you will look for, and whether the study design is appropriate. So each study has to go through assessment. The inclusion exclusion criteria has to be discussed, as I already said. Then you finalize which are the studies you will include, which you will not include within your group. Then you do the literature search. So you may go through various websites and look for the articles for the systematic review. Earlier these websites and were not available, so people have to go to library, look at the PubMed or data sources, then open the journals, then you have to go through. But now it has become much simpler because everything is available online. There could be some bias when you analyze. One may be data-based bias because there are many databases, Embase, Scopus, PubMed, like that. All articles may not be available in all. Some may be included, some may not be included. There may be Google Scholar also may be there. So you have to go through various databases to get your articles. There could be publication bias because many journals publish positive result. They may not publish negative result. But negative result is also equally important like positive result because then it will get balanced. So those things also has to be looked into. Language bias may be there. Mostly we look at the English language. But there could be articles published in other languages like German, French, Russian. So sometimes there may be important information published in another journals that could also affect your systematic review. Citation bias may be another thing. So you have to carefully go through your databases, the inclusion exclusion criteria, so they can be avoided. Once you go through the various journals, then the data has to be extracted. So to extract the data, you have to make a format in which, based on your research question, you will extract the data. Once you collect the data, then you have to analyze the data because each study may be different. There could be missing data which need to be looked into. Quality assessment, another important thing we have to do because all articles may not be having equal quality, but they should have reasonable quality when you include in your systematic review. So there are various methods of assessing. Although randomized controlled trials are supposed to be at the highest level of evidence, but even there could be problems may be there. It may not be properly randomized. You may not have looked into whether there is blinding has been done. Because bias could be there even in a RCT. So those has to be looked into. There are many quality assessment scales are there. One of them is Jadad's score. So you may use in any qualitative assessment scoring can be used. As in your group, you decide how to assess the quality of that. In Jadad score, there are 3 points which you take. One is randomization. So if the study has been randomized, then you give 1 point. if the randomization method is not properly described, you do not give any point there, but if it is properly described, you will get one more point. For each group, you may get 2 points. Suppose the randomization described is inappropriate, you reduce 1 point. So, maximum for randomization, you will get 2 points. Now, blinding. If double blinding has been done, you will give 1 point. If it is clearly described, you will give 1 more point. So, you will get 2 points. If you do not, the blinding is not appropriate, then you reduce the point. Suppose you also describe the withdrawal criteria, you will get 1 point. So, the maximum you will get is 5 points depending upon that. Then each study you put a score and see where it falls, and you decide in your group what score above which you will take the study, what score below which you will not include in your study. Now, once you collect the data and assess the quality, the data synthesis has to be done from the pooled data. Now, each data may be very variable, there may be confusion. So, you have to analyze individually and then include the data. It is also important you register all systematic review under Prospero. Prospero is a website in which you need to have registered. Now, good journals will not accept systematic review unless you register. Registration cannot be done retrospectively. So, once you make a decision for a systematic review, once you format your questions, inclusion, exclusion criteria, and you make a protocol, it has to be registered with the Prospero. Since 2011, this website is available. It is a free website where you need to register. You need to give the background information. Although the site is free, all the data has to be filled up by you. So, why we are registering? Because same topics may be systematic review done by many people, which may not be really needed. So, duplication can be avoided, and people will know if you are want to do a systematic review, how many other people are doing on the same topic. So, Prisma is the preferred reporting items for systematic review and meta-analysis. So, in your systematic review, you have to put a flow chart, how many articles you have seen, how many articles you have excluded, why you have excluded, and finally, how many you have gone through full article, how many you included in your systematic review, and if you have done a meta-analysis, that also can be added. So, these flow chart should be available in all systematic review to understand how many articles you have gone through and how many excluded, how many included, what you have analyzed. So, in Prospero, it is a web-based registration, free registration. People can search freely if you want to see what all systematic reviews registered, just like any other registration. Because in a clinical trial, we are Clinical Trial Registry of India, CTRIV registers, similar to that. And you have to put all data yourself, and you can change or you can add, subtract from the website. What are the systematic review which you can include in Prospero or register in Prospero? All systematic reviews related to human health condition can be registered. But if you have a narrative review, scoping review, or review of reviews, that cannot be registered. It should be a original systematic review which need to be received. If you have completed your review, as I said, retrospective registration not possible, and registration should take place once you get the idea. So, you have to get idea in your mind what topic you want to do a systematic review. You have to make a research question, what you are looking for. You have to develop a hypothesis, because basically it's like any other research, but you are not actively doing a lab research. You are doing a research of already done research, and that is published. So these are the steps which will include formulating a research question, and you have to make the inclusion exclusion criteria. Then you make a protocol, register with the Prospero, literature search you do, quality assessment you do, data extraction, analyze the data, look for the level of evidence, then consolidate your whatever you analyzed, and then you present in the journal. So finally you make a publication. Systematic review may be with meta-analysis, without meta-analysis. If you do a meta-analysis, it's a statistical evaluation of the data which is collected from other publications. It is not necessary all systematic review should have meta-analysis, but if it involves statistics, then you call it as meta-analysis. So thank you very much for your hearing. Any doubts or clarification, you are allowed. We have left few minutes left. So anything you want to ask? How many research articles you want to include? It depends upon the topic, because if it is a new topic, the articles may be less. If it is a topic which has been extensively studied, it may be very large. And when you initially do, you may get some 200, 250 articles. But once you go through their abstract, you may realize that some of the articles not directly related to what you are looking for. Then you download the articles and go through. So these articles you have to read. So finally you may end up with 10, 15, 20, depending upon the topic. There is no hard and fast rule how many articles should be there. It depends upon the topic. No, some journals may publish even without a registration. Registration, as I said, is like a clinical trial register. Suppose a clinical trial you do, you expect it to be registered with the Clinical Trial Registry of India, CTRI. But even if you don't register, sometimes some journals may accept for publication. But no good journal will accept if you are not registered. So Prospero registration makes it open. Others can go through it, others can give you feedback, but the changing in your web registration will be done only by the person who has registered. So it tells everybody, yes, Dr. Sangeeta is doing a systematic review in Pondicherry on this topic. So it will be there. So others know. Suppose it is many people have already done, you may not have to do a systematic review on that topic. What already been done also will be there. What is registered also will be there. Any other?
Thank you, sir. Sir, I came across with one study which shows that systematic review of the systematic reviews. Can we go with that? Can we do like that?
This is a very difficult question to answer, but may be done, because systematic reviews, suppose there are 10 systematic reviews. Rather than go individually doing, you can review of that and see, because everything is done by human beings. There could be always a mistake, there could be a problem. So if you can identify some problem, you can say that what are the drawbacks in each study, you can have your own publication. One of the main advantage of systematic review is that you need not to sit in the lab and do research work. You need not have to go to community. You need not have to collect patients. Everything people have done. And another important thing, you need not have to get ethics committee clearance also. Because it is already published data, it's available in the public domain. You are only analyzing and writing. So you can make a lot of publications if you know how to do systematic review and meta-analysis. Now every university is looking for publications because you are grading, your registration, everything will be based on your research and publication. If you make a lot of systematic reviews, your H index will go up. You will have more recognition because review articles will be viewed by many people because it gives a consolidated idea on that topic. And they will cite in their articles. So you will have more citation, more reading, more publicity if you do systematic review without going to ethics committee, without going to patients, without you should have some time, some peace of mind, you should learn how to do. So that way this workshop may be very useful to all those who are sitting here. So any other? I think you are all listening carefully. Hope that you had a breakfast in the morning. So wish you all the best.
Thank you, sir, for your insightful and thought-provoking presentation. Now I request Dr. Sasi, Vice Principal VM Con, to honor Dr. Vishnu Bhatt, Advisor Medical Research Professor of Pediatrics and Neonatology, AVMCNH, Puducherry. Thank you, ma'am. Thank you, sir. Dear delegates and participants, we will now break for tea. Kindly return promptly in 15 minutes so that we can resume and complete our sessions on schedule. Those who have not registered for the conference, please do so during the break. Those who are there to do proper presentation, kindly intimate the registration team. Analysis Nursing Perspective. It is an honor to have you all here. Reflecting on the importance of our work, I recall the words by Carl Pearson. The best that most of us can hope to achieve is to be right about something, to know the true value of some quantity, or to understand some phenomenon accurately. Systematic reviews and meta-analysis epitomize the pursuit of accuracy and truth, guiding us towards evidence-based nursing practices that enhance patient care. Please allow me to extend a respectful invitation to our esteemed dignitaries to take their seats on the dais.
Thank you for joining us. Let's embark on a day of insightful discussion and valuable learning. Ladies and gentlemen, Tamil is not just a language. It is our culture, emblem, and our symbol of heritage. As we commence this significant event, let us honor our roots and traditions. I kindly request everyone to raise for the invocation song Tamil Thalvalthu. Let us stand together and pay tribute to our heritage.
வாழ்வினில் செம்மையை செய்பவள் நீயே, மாண்புகள் நீயே, என் தமிழ் தாயே, வீழ்வாறு வீழாது காப்பவள் நீயே, வீரனின் வீரமும் வெற்றியும் நீயே, தாண்டிடு நிலையினில் உனை விடுப்பேனோ, தமிழ் என் நாளும் தலை குனிவேனோ, சூழ்ந்தின்பம் நல்கிடும் பைந்தமிழன்னாய் தோன்றுடல் நீ உயிர் நான் மறப்பேனோ, செந்தமிழே உயிரே நருந்தேனே, செயலினை மூச்சினை உனக்களித்தேனே, நைந்தாயனில் நைந்து போகுமென் வாழ்வு, நன்னிலை உனக்கெனில் எனக்கும் தானே, முந்திய நாளினில் அறிவுமில்லாது மொய்த்தனன் மனிதராம் புதுப்புனல் மீது செந்தாமரை காடு பூத்தது போல செழித்த என் தமிழே ஒளியே வாழி, செழித்த என் தமிழே ஒளியே வாழி, செழித்த என் தமிழே ஒளியே வாழி.
Thank you for joining us in honoring our mother Tamil. Please take your seats as we proceed with the day's program. Tamasoma Jyotir Kamaya, lead us from darkness to light. The lighting of a lamp signifies more than just the dispelling of darkness. It embodies peace, prosperity, and the promise of success. Let us illuminate this gathering with divine grace. I now invite our esteemed dignitaries to light the Kuttuvilakku.
Thank you, one and all. We are honored to have you all here with us today. People will forget what you said, forget what you do. People will never forget the way you made them feel through your welcome. I call upon Mrs. Maheshwari, Assistant Professor, Department of Nursing Foundation, to welcome the gathering.
A very good morning to one and all present here. With the spring in my step, anticipation in my heart, and with the academics on my heart, I welcome you all for this gathering. I am highly honored and privileged to have been given the opportunity to address everyone with a welcome note on this special occasion. On behalf of our Department Community Health Nursing, Vinayaka Mission College of Nursing, I welcome you all, the dignitaries on and off the dais, and the resource persons from various places, and all the delegates from various institutions for this national seminar on systematic review and meta-analysis nursing perspective. First and foremost, I would like to extend a hearty welcome to our esteemed chief guest, Madam Dr. S.J. Nalini, Professor and Principal, Head Unit of Nursing Research, Shihar Deemed University, Chennai, who has been known for her exceptional contribution to nursing society. We feel highly honored to have you, ma'am, with us as a chief guest. We welcome you, ma'am. I request our beloved Principal, Madam, to welcome our chief guest, ma'am, with a token of love. Thank you, ma'am. A special welcome goes to our Sir Dr. Vishnubhat, Advisor Medical Research, Professor of Pediatric and Neonatology, AVMCH Puducherry. I welcome you, sir. Your leadership and dedication to the academic community has been an instrumental in our success. May I request our beloved Principal, ma'am, to welcome sir. I extend my special welcome to Dean Sir Dr. Rakesh Shekhar for his endless support in all our endeavors. In his absence, I'll welcome you, sir. A special welcome goes to Dr. Mahalakshmi ma'am, Dean HPE, who plays a crucial role in guiding our institution towards an excellence. Your vision and commitment to an educational initiative continue to shape our future. We welcome you, ma'am. May I request our Principal Madam to welcome Dean ma'am. Thank you, ma'am. I feel highly privileged and honored to welcome our Director of Medical Research, Dr. Sharman Singh, sir, who has been joining with us soon. Your guidance and expertise has been invaluable in driving our research endeavors forward. I welcome you, sir, in your absence. I extend my sincere welcome to our Medical Superintendent, Dr. Satish Kora Kuruvilla, sir, and also Residential Medical Director, Dr. Ashwin, sir. Sir will be joining with us soon. I welcome you, sir, in your absence. I also, it gives me an immense pleasure to welcome Dr. Lakshmi Ramamurthy, ma'am, TNMC Observer, who's been present with us today, and we will welcome you, ma'am. I request our Principal, Madam, to welcome Observer, Madam. I feel immense pleasure in welcoming a notable person who has untiring energy, visionary leadership and quality, always makes sure about perfection in all the works which we carry out every day. I welcome our beloved Principal Madam, Dr. Sharada Ramesh for this occasion. We welcome you, ma'am. May I request Dr. Sasi ma'am, Vice Principal, to welcome our Principal Madam. Thank you, ma'am. It's my ardent pleasure to welcome Dr. Sasi, Vice Principal, who supports us constantly. We welcome you, ma'am. I request Dr. Sangeeta, ma'am, Research Coordinator, to welcome our Vice Principal, madam. Thank you, ma'am. At this juncture, I also take an opportunity to thank all the heads of the institution, of various academic institutions, and the hospital across Puducherry region for sparing their staffs and students to make this seminar and remarkable event. I extend my warm welcome to the IT support people for their constant support throughout our program, and ceaseless flow of thanks goes from my heart to everyone, those stand before this and making this occasion a special one. I welcome all the teaching and notching faculty of our VMCon for this occasion. Once again, I welcome you all.
Thank you, ma'am, for your heartwarming and glittering gratification. As we gather here today, I'm reminded of a profound quote by Peter Drucker: "If you can't measure it, you can't improve it." This sentiment underscores the essence of our seminar on systematic review and meta-analysis, where rigorous evaluation and synthesis of data lead to informed decision and advancement in nursing practice. It is my privilege to invite the core academician of Vinayaga Missions College of Nursing, Dr. Sharada Ramesh, to illuminate the theme of today's seminar.
Most respected Dr. Vishnu Bhatt sir, Dr. Mahalakshmi ma'am, our respected faculty and students from other institutions who had honored our invitation and sent their delegates here to our very own campus of AVMC. I would like to place my sincere thanks to all the efforts that was put by everyone of our team. The program started as a seed when research coordinator Dr. Sangeeta wanted to have this. In between, she couldn't take off because of few reasons. And so more the merrier, I always think. Sangeeta on one end, she started the seed, and the other end, Maheshwari took off, and Prabhakaran and Maheshwari were able to carry the task seamlessly. I should place my sincere appreciation to all of them for bringing this day into an eventful one and reality one. With that note, this is already I have spoke on systematic review by the introduction session that I've had. Initially, we wanted everyone, all the resources to come, the hand-picked resources. Of course, with my good association with many other colleges, we could pick someone from Mahe Manipal, from AIMS, from Symbiosis, and from our own, Tamil Nadu Ramchandra University. All these experts, stalwarts in nursing, I should say, who are doing a very good job in research. I only have this thing on the delegates. please take the good out of it, because such sessions don't happen every night. It's very difficult for everyone to organize that, and more so it was during COVID. Nobody saw no one. So we were all invisible. But we have a platform here, and I should say that this is going to give you a good insight on the research. This is organized by the Community Health Nursing and the research coordinator of our Vinayaka Mission College of Nursing. With that note, I would like to place my sincere thanks to our management, the Board of Management, our Chief Patrons, our Chancellor Sir, Madam Chancellor, and Board of Management member, Mr. Suresh Samuel Sir. All of them were all, I have approached their office and never they have said no for anything till now. The back-to-back programs we are having. Last week we had a finishing school program for all the exiting batches. We had almost 5.5 days long session, 42 speakers, and today we are having another 7. All these things are just to give an input on the nursing, and the same thing is happening here on this day. And I would like to place on records my sincere, this looks like a vote of thanks, but I have to tell Dr. Mahalakshmi ma'am. But for her, we will not be here on this stage right now for various reasons. Madam knows that. So this is the kind of a networking and this thing. This in itself is very systematic. All our things are very systematic. So systematic research is not going to be very hard for people like us to do. So with that note, I would like to sincerely thank my team, VMCon team, who have always been there for me. Anything I do, yesterday till 7 o'clock they were here, today also. So I thank that also. And our beloved Dr. Vishnu Bhatt sir, anything sir is always there for research, especially anything on research, any doubts, to get our DHR registered. I've gone, approached our Dr. Vishnu Bhatt sir, but for him DHR order wouldn't have come, because we had a lot of nitty-gritties to get it placed. And today I should proudly say, after AVMC, Nursing College has got the DHR, and we are doing the IEC for the Allied Health Sciences, SRBS, Physio, all these candidates are pushed to us. So that way I should say, because GCP was very difficult for us to take through the ICMR, sir had guided with this vast experience, and I am very thankful for sir for always being there in our publications, and very cool also. You wouldn't see a person this cool in research. That's my observation, sir. Very cool, sir. It's okay, you do like this, okay, you do like that. அந்த மாதிரி ஒரு கான்ஃபிடென்ஸ் நம்மளுக்கு கிடைக்கவே கிடைக்காது ஆக்சுவலாக. ரொம்ப கூலாக இருப்பார். ஐ ஆல்ரெடி டிக்ளைன் ஒன் ரிவ்யூ மெட்டீரியல் பிகாஸ் ஆஃப் வாண்ட் ஆஃப் டைம். சார் செட் ஓகே, யூ சஜஸ்ட் சம் ஆல்டர்னேட் திங்ஸ். ஸோ தட் சார்ட் ஆஃப், அதுக்கு இன்னும் நான் மெயிலே போடல. ஐ எம் திங்கிங் ஹூம் டு டெல். ஸோ வெரி, அண்ட் டு பப்ளிஷ் ஒன் ஆர்டிக்கல், I had students pushed it to me. Finally, I had taken over, and sir said, no, you do like this, you do. He made the correction. Hard copy எடுத்து எனக்கு கரெக்ஷன் பண்ணி எனக்கு அனுப்பி விட்டார். Then it published in our own AVMC journal, SAJHS, and it is already there in the edition. So that sort of a hand holding from an expert researcher is hard to find these days. When people are jealous, when people are egoistic, we have a very humble and a very nice person with us. Thank you, sir, for being there always with us. And Dr. Mahalakshmi ma'am, I have no words to express my appreciation and acknowledgement for what madam does for us. So many things is there. So with all these things, the Board of Management, of course, their input, their budget, nowhere they have asked me what you are doing with the budget. Last week we had asked for some 1.5 to 2 lakhs. This week for this seminar, nowhere. Whatever I've asked, sanctioned. Bless it, God be with it always, and thank you for that. And dear delegates, enjoy the whole day, stay tuned. You have stalwarts in nursing coming and presenting the systematic review, and I'm sure you will get the best out of this day. I should also place on records my sincere thanks to the Tamil Nadu Nurses and Midwives Council Registrar Madam, sending an observer from the top-notch institution JIPMER, who is here, Dr. Lakshmi Ramamurthy with us. The whole day she's going to evaluate as well our conduct of seminar. So thank you so much for giving me this. Unfolding the theme as such I don't have, because stalwarts are going to say. So I'm just leaving that with the experts. Thank you so much.
Please join me in thanking Dr. Sharda Ramesh ma'am for her insightful unfolding of today's seminar theme. A true leader has the confidence to stand alone, the courage to make tough decisions, and comparison to listen the needs of others. He does not set out to be a leader, but becomes one of the equality of his action and intent. It is my distinct privilege to invite the great leader, Dr. Vishnu Bhatt, to grace us with his distinguished presidential address.
Dr. Nalini, the chief guest for the day, Dr. Mahalakshmi, our Dean, Health Profession Education, Dr. Sharda Ramesh, the principal, Dr. Shashi, vice principal, Dr. Sangeeta, our research coordinator, and our honored representative from Tamil Nadu Nursing Council, Dr. Lakshmi, who is still working with us in JIPMA. It is nice to be here. I was on leave for some time. Then the first thing after returning is attending this program. So destiny is something different. I think I became present because other people did not come. So what you think, what God thinks, what really happens is something different. But this program is very, very important because I was coordinating with the research for some time here. People do research, but they don't publish. So I tell my students, if you don't publish your research, the research dies along with you. So there is nobody to see what you have done. Each person, individual, is different. What one sees, others cannot see. So it's a bit nice to express whatever you have seen, put it in some printed format so people can see and read what you have done. Many times our research may not be of high quality, it does not matter. When you start anything, it cannot be at a very high level. You cannot publish in the Lancet or New England Journal straight away. So you publish in small journals, learn how to publish, what editor and the reviewer looks for, and improve your way of writing. If you write a good paper, if your study is good, any journal will accept it. And do not think of always money part, because the university and the college is also giving money if you publish in index journals. But there are so many journals which are publishing free, which have got very high impact factor. So make a good quality research, publish. Morning I was telling them, systematic review is very, very important because you don't require patient, you do not require lab, only requires your brain and little time and sit, because you are doing research on others' research. You are not doing anything on sitting in the lab or taking patients. And you can publish as many as possible depending upon the time availability and your interest. And all systematic reviews will have high impact factor because many people will read systematic. When they are referring, they will quote your articles. So that is how it is important. Not only that, you also learn when you are doing a systematic review, because you will be reading others' article. You know what's happening in other part of the world, what they have looked, what they have not looked, what you can look, all those ideas will come. So I wish that you make best use of this program, and whoever has attended, at least publish one systematic review by year end. I wish you all the best.
Thank you, sir. Really, you're inspiring us with your power of knowledge. Aristotle quoted, "Excellence is never an accident. It is the result of high intention, sincere effort, intelligent direction, skillful execution, and the vision to see obstacles as opportunities. I feel privileged to share a glimpse of Dr. S.J. Jalini's remarkable journey, a testament to her unwavering commitment, profound expertise, and transformative impact in the field of nursing. Dr. S.J. Nalini currently holds the esteemed position of Professor and Principal Head at the Institute of Nursing Research with Sri Ramachandra Faculty of Nursing, part of Sri Ramachandra Institute of Higher Education and Research, DU. She earned a BSc Nursing in 1992 and MSc Nursing in 2002 from Tamil Nadu Dr. MGR Medical University, followed by a PhD in Nursing in 2011 from Sri Ramachandra University. Her professional journey includes roles as a staff nurse and charge nurse at Apollo and King Fahd Hospital, Jeddah, Saudi Arabia. She has ascended from novice to expert, serving as a clinical instructor, assistant professor, reader, professor, vice principal, and principal at Sri Ramachandra Faculty of Nursing. Dr. Nalini has been actively involved as a presenter, resource person, organizer, panelist, guest speaker, and chief guest at numerous national and international conferences, contributing around 200 presentations. She has received numerous best paper awards from prestigious institutions such as the 9 PGMA Chandigarh, Sri Ramachandra University, SRM College of Nursing, National Nursing Research Society of India, MGM Institute of Health Sciences, among others. Her awards include the Basure Award in 2016 at the Palliative Care Congress in Glasgow, UK, and the Inspiring Research Ambassador and the Best Teaching Team Excellence Award in 2021. Dr. Nalini is an external committee member for various board of studies and university, and she has guided and conducted numerous projects. Her extensive publication record in national and international journal reflects her commitment to advancing nursing education and research. 3 minutes cannot do justice to summarize her 3 decades of service in the field of nursing. With great honor, I now invite Dr. S.J. Nalini to deliver the chief guest address. We welcome you, ma'am.
That was a big systematic review paper. Thank you for the introduction. Honorable Dean of Health Professionals Education, Dr. Mahalakshmi, Dr. Vishnu Bhatt, the Advisor for Publications and Research, Dr. Sharada Ramesh, Principal and Professor of Arupade Vida College of Nursing, Dr. Shashi, the Vice Principal, Dr. Sangeeta, the Research Coordinator, Dr. Lakshmi Ramamurthy from JIBMER, my friend, and all the other faculty members, students. I bring the warm greetings to each one of you from Sri Ramachandra Institute of Higher Education and Research. I'm honored to be here to inaugurate this systematic review and meta-analysis conference, a one-day conference over here. So happy to be here for the day. You know, all of us know that research is very, very important and publications are 2 important markers, is it not? Today, the quality of institutions are judged by research and publications and innovations you make. A lot of money is being spent by so many organizations on research, new devices, new medications, new protocols, new procedures, improvisations. All this is done through research. Why is that we do all those things? Very simple. Quality care. That's the norm. So as nurses, we are into providing the best of quality care that is cost effective. Not only cost effective, it doesn't bring any adverse effects for the patients, and most important, which is acceptable by the patients. So for that, you need the concept called as systematic reviews. I think you know how important these systematic reviews are. Normally, this Kuti stories always catch up faster. So I have a small Kuti story to tell you with a history that goes back. Late in 1900s, there was one researcher in Auckland, New Zealand, which is part of New Zealand. Now he was doing research related to preterm, and he started with the work on rats, the sheep actually. It all started with the work on sheep. He was more interested, why is that preterm labor is more? So he thought something that triggers this preterm labor has to be brought down, and he felt that it is better to give some medication that is effective. So he chose corticosteroids to induce to the sheep, which is pregnant sheep, so that he, brings down the preterm labor effects. That was his thought. But then ultimately, when he saw the results, he found that there was no reduction in the preterm labor, but all the sheep who were delivered premature, they were able to sustain with life. They were able to prolong, they didn't die. So that gave him some thought, where he associated with his friend now, who's a pediatrician. His name is Ross Hovey. So they both started to work on the human factor now. So from animals they shifted to human research. And this research among more than 200 women with preterm labor, they started to give corticosteroids. It worked tremendously. It really brought down the amount of premature death among children, the newborn. Life was better, maturity was good, all those things happened. These two were very enthusiastic and they published this paper to Lancet. Lancet rejected. See the quorum. And the reason why it was rejected was Lancet said it lacks the general interest, so we are not publishing. So ultimately it got published in Pediatric Journal, and from the time it started, everybody started to use slower and slower the use of corticosteroids. It took about 2 decades of time for one systematic review to get published on corticosteroids, which made the world to see the importance of corticosteroids. Today, we know that in obstetric units, this medicine is very, very important for preterm mothers who are in preterm labor. And all the mothers do get this if they are in preterm labor. We know that. But you see the amount of time it took for people to think about the importance of this drug. So it tells you that systematic reviews are required for clinical decision making. In case these things were taken up bit earlier, it would have saved lots and lives of preterm infants, is it not? So that is where we have to serve us telling how important publications are. So we have to never ever let our research to sleep. It has to get published. The more and more research we do, the more and more publications we do will help us to go in for productive systematic reviews in future. Again, I just want to make a very point blank statement here. Most of the time, when we do our review of literature, we just try to match up with here and bits and pieces of literatures that we search, and then we come to conclusions very easily. It's time we do a systematic review, a systematic methodological way of reviewing the literature, and then find out the gaps so that we understand the concept better. So I think Arubade Veedu College of Nursing has taken a right choice of making this systematic review concept over here. I still remember when Ramchandra took up the initiative 3 years back. We just started within this college, within the nursing college alone. Today we are into the 3rd session of the systematic review, and we have got guests from multiple healthcare professions. So we have medicine people, dentistry people, scholars, scholars from allied health, and so many of them have joined. And sometimes we had to say, no, the entry is over. We are putting a full stop for the entry for the systematic review. So days are there. This is just a small step you have started, and there is leaps and bounds. It is there for you to grow, because systematic review is not under the purview of nursing alone. It is for the entire healthcare professionals. I think we should be happy enough and proud enough that we have started this initiative here, and wish you all the best to take over and push it forward again and again for more people to enter and to reap the benefits of systematic review. I congratulate the entire team under the leadership of Dr. Sharda Ramesh, the entire learned scholars over here for bringing about this important conference, and wish you all the best for many more in future. Thanks a lot.
Thank you so much, ma'am, for your words that have illuminated our understanding and inspired us with your wisdom. Now I request Dr. Sharda Ramesh, ma'am, Principal VM Con, to Dr. Nalini ma'am. The mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, the great teacher inspires and becomes a mentor. Before welcoming the great mentor, let we have a short glimpse about Dr. Mahalakshmi, Dean HPE, AVMCH, Puducherry. Dr. V.N. Mahalakshmi holds a robust academic background and the distinction of being a Harvard Massey Scholar. Along with the WHO certificate in hospital management, she is currently pursuing FAMR and serves as the Dean of Health Profession Education and a Professor of Pediatric Surgery at AVMC in Puducherry. Additionally, she holds the position of Dean of Faculty for Interdisciplinary Studies at VMRF DU. She has also planned and organized more than 160 faculty development programs, received 5 Best Paper Awards at national and international medical education conferences. Her contribution extends to the realm of publications, including 15 research papers, 12 monographs and book chapters, along with holding 12 IPR copyrights. Recently, ma'am has received a prestigious award for her noble contribution towards Jiva Raksha. Now I request Dr. Mahalakshmi V.N., Dean HPE AVMCH, to felicitate the gathering.
Good morning. Greetings to all the dignitaries on the dais as well as people seated over there. Madam, after your Kutti story, I thought I'll just go a step back and then say a little bit about the evolution of humankind. So if you look at the history of mankind, there are a few things which has shaped up how humankind has turned out to be what it is today. The first and foremost were we were crudes living in caves, right, in forests, competing with animals for one egg, one drop of thing coming up. So fire was the first thing which shaped up the human potential. It served as a weapon, it helped them to cook food, it actually pushed them into the path of this. Then came weapons, stone weapons, then they started using metals, then agriculture, then industry, then the age of information came. And information is no longer ubiquitous. Now it has become so common, it's available just with one click of your Google Chrome button. So information is no longer the premier commodity. And the premier commodity now we have is attention of people, right? So they did a very nice study. They tried to find out how long people can sit in a meeting without looking at their phone or trying to check their messages. Is there any guess? It's 1.5 minutes. 1.5 minutes is the time. So if you don't look at your phone for 1.5 minutes when somebody is speaking, that means they are doing a very good job holding your attention. So why did I say this? Because information doubling time, if you look at it, how long it takes for the available information on some subject to double. So if you take from the evolution of from the time in which history has been documented, it took almost 14 centuries for information to get some shape, right? And then from 14th century to 19th century, in about 6 centuries, 600 years. First it took 1400 years, then it took only 600 years for the next doubling to take place, where so many small universities were established across the world, and the person who had knowledge was considered as guru and that is how it went. From the time 19th century, 1901 started, information doubling took about 60 to 70 years, right? The amount of literature which was there took 70 years almost. From 70, it became 25 years. So by the turn of 20th century, in 2000, it was taking almost 25 years for information to double. But with information gadgets and technology growing at such a rapid pace, currently it takes only 73 days for information to double. So whatever literature we are teaching today, if you are taking recent advances class, 73 days later there is a new advancement which is coming up. So the search has become so ubiquitous. If I search acute appendicitis today, I'll get more than 2 lakh hits in Google Chrome. If I just put it in ChatGPT, treatment of acute appendicitis, ChatGPT is giving. So information is no longer the currency. Authenticity of information is the currency. So that is where all these digested forms. No, I can't read 2 lakh articles on acute appendicitis to treat a patient. And what I get from ChatGPT may not be completely reliable. So how do we go about getting it? We need pre-digested information which is authentic. So that is where all these clinical practice guidelines, systematic reviews, meta-analysis, scoping reviews, all this have a very significant role. By reading one article, I'm kind of assimilating the knowledge which went into making that one article possible by a researcher who has spent reading at least hundreds of articles. So that is where it is very important. If you can write a good systematic review, if you can identify a good systematic review, it becomes much easier for us to establish clinical practice guidelines and go with that. So that is where, so information is no longer the currency, attention is the currency. And one of the ways in which you can get attention is to produce a digest of recent acceptable information in the form of systematic reviews. So I hope you get that the message across, the theme behind this particular conference and workshop. And first we will be in a position to identify good reviews. The second, we will be in a position to create good reviews. I hope this workshop fulfills its objectives. I wish you all a happy learning. Thank you.
Many thanks to you, ma'am, for presence and also for your heartfelt felicitation. Many thanks to you, ma'am, for gracing us with your presence and also for your heartfelt felicitation. Now I request Dr. Sharda Ramesh to honor Dr. Mahalakshmi, Dean HPE, AVMC and H. Thank you, ma'am. Teachers plants the seeds of knowledge that last a lifetime. Now, I welcome a teacher who has made many successful nursing trees throughout her nursing career, Dr. Lakshmi Ramamurthy, College of Nursing, JIPMA, and our TNMC observer to felicitate the gathering.
Respected, it's okay, fine. Respected dignitaries on and off the dais, a very good morning to all. Actually, it was a surprise. TNMC have asked me to observe this one-day conference, one-day seminar, national seminar on systematic review and meta-analysis. I congratulate the team, Madam Sharda Ramesh, also the chief guest for accepting invitation, and also Madam has a wonderful session here. Also, I congratulate all the participants for your active participation. I'm wishing you all the best. Okay.
Thank you so much, ma'am. Now I request Dr. Sharda Ramesh, Principal VM Con, to honor our TNMC observer, Dr. Lakshmi Ramamurthy, ma'am.
Gratitude is not only the greatest of virtue, it is the fairest blossoms which springs from souls. Herewith, I would like to welcome Mrs. Guna, tutor, Department of Community Health Nursing, to propose the vote of thanks on behalf of VMCon.
Good morning all. I deem it a great privilege to propose the vote of thanks on his memorable occasions. Let me start by giving glory to Almighty God with the blessings of Chancellor and Madam Chancellor of Vinayaga Missions Research Foundation for making today's occasion a resounding success even in their absence. First and foremost, I thank our chief guest, Dr. S. Nalini Ma'am, Professor and Principal Sri H. Chennai, who despite her busy schedule has found time to grace these occasions. I thank you, Ma'am. I would like to take this opportunity to express my hearty thanks to our Dean, Dr. Rakesh Srigal, AVMCH Puducherry, even in their absence. My heartfelt thanks to Dr. Vishnu Bhatt Sir, Advisor, Medical Research. Thank you, sir. I would also like to extend my deepest gratitude to Dr. Mahalakshmi Ma'am, the Dean HB AVMCH Puducherry, who felicited these occasions. I thank you, Ma'am. I take this opportunity to extend our sincere thanks to Dr. Sarman Singh Sir, Director of Medical Research, AVMCH Puducherry, even in their absence. I thank you, sir. It's my great pleasure and privilege to express my heartfelt and sincere thanks to Dr. Sharada Ramesh Ma'am, Principal VMCon, for the constant guidance and timely help and highly constructive suggestions in each stage of our process. Thank you, ma'am. And I thank Dr. Lakshmi Ramakrishnan, ma'am, TNMC Observer, for these occasions. I thank you, ma'am. I also wish to convey my gratitude to our Vice Principal cum IQC Coordinator, Dr. V. Shashi, ma'am, for her encouragement and support and being a trendsetter. Thank you, ma'am. I would like to thank our organizing Secretary, Mrs. Maheshwari, ma'am, Assistant Professor VMCon, for helping us in all the aspect of grace these functions. Thank you, ma'am. I would like to thank Dr. Sangeeta, ma'am, Research Coordinator, VMCon Puducherry, in this presence. Thank you, ma'am. I would like to thank all the delegates from various colleges who have come all the way to enlighten these occasions. I find no words to acknowledge all our committee in charge and its members for their tireless work towards the success of this seminar. I express my sincere and special thanks to Audiovisual Department of AVMCH Puducherry, Mr. Sundaraman Sir and his colleagues. I also extend my thanks to Transport in charge and housekeeping peoples. Once again, I thank you all for creating this special occasion. Thank you.
Thank you, ma'am. Please allow me to extend a respectful invitation to our esteemed dignitaries to take their seats off the dais. We are moving ahead with our next hybrid presentation. The greatest person is not necessarily the one who does great things. She is the one who gets the people to do the greatest things. It gives me immense pleasure to introduce the greatest personality, Professor Bepi S. Nayak. Madam currently holds the position of Professor and Head of the Department of Child Health Nursing and PhD Coordinator at Manipal College of Nursing, Manipal Academy of Higher Education. Professor Bepi embarked on an academic journey with a BSc in Nursing from Bangalore University, followed by achieving a MSc, MPhil and PhD degrees from Manipal Academy of Higher Education, Manipal. Professor Bepi has organized and led more than 25 capacity building workshops. She has developed and executed several certificate courses in critical care areas such as evidence-based practice, advanced leadership and management, and neonatal nursing. In addition to her pivotal role as professor and head, including IQAC institutional coordinator, she has also initiated strategic collaborations such as the MOU with Melbourne University, Sweden, fostering academic and research synergies on international level. Professor Bepi is a trailblazer in nursing academia, serving as the chief founder editor of the Manipal Journal of Nursing and Health Science, the official journal of Manipal College of Nursing. She has also contributed extensively to shaping nursing education policies and standard as an external member of internal quality assurance cells at prestigious institutions such as Usha Institute of Nursing Sciences, Mangaluru. Professor Baby has been honored with multiple awards, including the Best Published Research Article from Manipal College of Nursing on several occasions, the Distinguished Alumni Award, and the Most Accomplished Faculty Award. Her dedication to research excellence is underscored by her role as principal investigator and co-investigator for numerous research projects funded by the ICMR. Professor Baby's scholarly contribution extend beyond publication, with nearly 80 research articles published in reputed national and international journals. She has also shared her expertise as a resource person at more than 50 national and international conferences, seminars, workshops, and webinars. Further, Professor Baby has made significant contribution to continuing professional development through virtual continuing nursing education sessions conducted at Al Salem International Hospital, Kuwait. We are honored to have a distinguished scholar among us today. Please join me in welcoming Professor Baby S. Nayak to share her insights with us. We welcome you, ma'am.
Very good morning to all those who have joined on site, and I thank the organizers for giving me this opportunity to be the resource person, and really I should be grateful because permitting me to join you people online, which I really expect. So let us start with the session. And shall I share the screen? If I'm audible?
You're audible,
Hope I'm
ma'am.
audible?
You're audible, ma'am. You're audible,
Yes.
ma'am.
Shall I share the screen?
Yes, ma'am. Yes, ma'am.
I think it is coming. Disabled participant screen sharing. Can you please allow me to share the screen?
Sure, ma'am. 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 Ma'am, we have enabled you to share, ma'am. We have enabled you to share, ma'am. We have enabled you to share, ma'am. We have enabled you to share, ma'am.
Yes, I'm trying to share. Yes, I can see now. It's hope it is visible. Hope the screen is visible.
Yes, ma'am. Yes, ma'am.
Yeah.
Yes, ma'am.
So, very good morning. I'm sure that since morning you had a sessions on what is importance of systematic review, and also you would have had a first step of systematic review. So today the task given to me is on systematic review protocol. That is, I will be just highlighting on what are the important components that we may need to include in writing a systematic review protocol. As it has been already told that it's a very important component, it's a systematic review. So I'll be discussing under introduction, component, resources, guidelines, and registration of the systematic review protocol. So brief about why systematic review. So this was the question which I had in my mind when I started learning this systematic review in 2012. Even much before my first PhD student I could enroll, we have started working, and I am really grateful to Dr. Sri Kumaran Nair, who is in the Department of Statistics, JIPMER, who was here. He encouraged me and motivated me to learn about systematic review. And from there onwards, we had started training, conducting, and also collaborating with many of the international universities for organizing this systematic review. As one of the work of our systematic review, it is utilization of systematic review in evidence in formulating India's National Health Program guidelines between 2007 and 2021. This is one of the article which where we have highlighted what is the importance of systematic review. And in this, during this work, it's a part of our Spark project, which we have done in collaboration with University College London. So during this time, we have found, of course, our national health programs have been, they have used different guidelines, or they have used Cochrane systematic review, or they even had some of the systematic review which was done in India, or at least they have included different experts in developing these guidelines. I think my screen got unshared. Yes. So with this brief introduction, it is let me start with this. So it is a systematic review protocol. It is like how we prepare a protocol for research study. Systematic review also is a vigorous process. It is not just search in one or two databases, and it depends again if we want to have a plan idea of what is existing evidence on that particular topic and then go ahead with our PhD study, then it is okay, maybe 2 or 3 databases. But if it is really going to help us with the policy development or developing evidence-based guidelines, we need to really think of how exhaustive we are in searching for the evidences and evaluating and including those evidences in our review. So that's why the protocol plan, which describes how authors will manage the review process. So it also outlines the process for identifying, assessing, and summarizing the studies. Then it is also an interactive process. Systematic review is not a single person activity. It is to be done by the team. There need to have 2 review members, that is the review experts, and preferably from the library science. If not, the person who is familiar with all these databases can be the part of it. And then we need to also have a subject expert, methodological expert, statistician, and also need to have an advisory group who will help us or guide us in continuation whether those evidences are really relevant for our particular field. So then why systematic review protocols? We have 2, that is it is to, by writing the systematic review, we will know what is available evidences. Like we can read and understand the background of what is already known in this particular area. Then also help us to formulate a focus question, that is the review question. Without having a clear-cut review questions, we cannot proceed with the systematic review. Then we can also decide about the search strategy. What are the databases that we are having with us, or what databases we can get access and how we can go ahead. And then we can describe inclusion and exclusion studies, and also think about the data to collect and decide the methods to analyze the collected data. I think all these it will be explained detail, and I'm sure inclusion and exclusion criteria has been discussed during the how to formulate a review question. So the components of a systematic review protocol, there need to have a clear background, and review question should be there. There should be objective and methods. In the methods, we need to clearly explain what this review, search methods for identification of studies, details of search strategies, data extraction, analysis, and synthesis. How are we going to do this? Then discussion and protocol registration, then abbreviations, additional files, and then conflict of interest and acknowledgement and references. So these should be the ideal component of a systematic review, and depends if you are just registering in the Prospero, we don't want to publish it. Yes, whatever the required components in the Prospero we can consider, where there is acknowledgement and additional files as a supplement search strategy we can add, but other things may not be required. So depends on, again, if you are going to publish, it again depends on the journal which they publish. If it is a Cochrane protocol, it has got their own template, and we may need to go according to that. But in case of other journals also and other sources also, will going ahead, like we have Campbell, we have JBI, we have 3IE. So there are so many sources are available. So we can think of any template, but when we start a systematic review while writing a protocol, we need to have a clear background, and review question should be there. There should be objective, and there should be method section. We should be very clear what are we going to do. So this is one of the protocol which was published by us as a part of our ICMR funded project. It is efficacy of mHealth intervention for improving maternal and neonatal outcomes among pregnant women with hypertensive disorders. It is a protocol for systematic review. It is published in JMIR protocol. So in this, what we have done is we have some of the examples I will give from this. So coming to this background, we need to describe the condition or the background of the intervention which is under review. And in the background also we need to describe about rationale for the review and explain the importance of the review question. Include the statistical evidence of what is already known about this, like are there any RCTs have been conducted, are there any non-RCTs, are there any intervention studies that have been conducted, and what is the known prevalence of all these, or what is the known effect of all these intervention. That statistical component need to be clearly spelled out under the background. Then define the interventions clearly. We need to say which intervention we are going to. If suppose this mHealth intervention, so we have to clearly say about what are the mHealth intervention that we are going to explain, and how this intervention help us in bringing out the output, what is the outcome in the study. So intervention and their components here will help the reader gain a better understanding what exactly the reviewer has included in their review. Okay, so this also we need to give the include the supporting references to the existing and ongoing primary research and reviews, which we may try to identify through CGRI registrations or maybe through some sources which we know. And then the any other existing reviews are there which we may get through Cochrane, which we may get through different publication, which may get through Epistemenikos. So there are different sources where we can identify the these sources, so that has to be clearly written in this. Then point out any inconsistencies, methodological strength and weakness, and evidence gaps that remains, that makes us to go ahead with this systematic review, and how this could inform practice or policy decision. So then this is example like of our systematic review protocol. So here we have not gone for a detail like Cochrane systematic review. We just put up as a background, giving the highlighting all the what is the importance of doing this review. Whereas it's an example from a Cochrane protocol. You can see here under the Cochrane you need to discuss the description of the condition, they also need explain about what is the description of the intervention and also how it is important to do this review. This component we need to clearly explain under the introduction section when it comes to the Cochrane. Actually, Cochrane systematic review, it is it depends on the need base. Cochrane will formulate the group and they will give the advertisement, and if it is required or interested people can express their interest in joining the team, and they will assign with the different team which has been already done, depends on the expertise what you have. So there is a difference. It's actually Cochrane systematic reviews are the need-based. Campbell also, it is the need-based systematic reviews. So next one is review question. So we need to, as I have told very clearly, review questions. Architecture of a focus question. So it should be like population, intention, comparison, outcome. We need to clearly say who are the population or who is the patient. Is it patient with, like in our present condition, it is pregnancy related complication, GDM or other complications. And then intervention is mHealth intervention. Comparison, some questions we may have comparison of standard care, some may be placebo, some may have other methods of intervention, or we may not have comparison group at all. Then outcome, what we exactly want to, like it may be maternal outcome or the neonatal outcome. Again, we may need to specify which are the areas of outcome that we are going to consider in our review. Then objectives. Objectives should be very clear and it should be specific. So it should cover both interventions and or exposures and the population of interest and the type of outcome. So objective should be consistent with the review title. This is one example to assess the effect or benefits and harms of ultra early surgery for hip fracture in adults. So here the population is adults with hip fracture, and it is intervention is early, ultra early ambulation, ultra early surgery, and it is comparison is early surgery, and the outcome is benefits or harms. So in that way, we need to be very clearly, based on the review question, we need to formulate the objectives for that. Coming to the methods, the purpose of the method section of a protocol is to describe how the review will be conducted. So we have to mention which methodological guidelines are followed, whether we are going to follow Cochrane, whether we are going to follow PRISMA, whether we are going to follow JBI. So which depends on what we want. There is no specific, but unless the funding agency, those who are requesting for conducting the, or they are sponsoring for the systematic review, they say you follow these guidelines. Yes, otherwise we can follow any guidelines, depends on what we feel it is more comfortable for us. So criteria for considering the studies, we may need to consider the type of studies. If it is an intervention type of systematic review, we may need to think of RCTs, non-RCTs, quasi-experimental study, before after design, crossover design, or if it is observational type of systematic reviews, then we may need to think of cross-sectional studies. We may need to see observation study, prevalence study, descriptive studies, cohort studies. So depends on what is the purpose of our systematic review. We may need to think of type of studies. Then type of participants, it is population, but we need to clearly spell out inclusion and exclusion criteria. So in the inclusion criteria, we need to say who are our participants. Are they children? Are they adult with certain condition? What type of condition we are going to exclude? So that clarity should be there under type of participant. Type of intervention, again, we need to see. Now, mHealth intervention, where we have tried to include all the mHealth, like mobile-based, web-based, then SMS. So all this, anything which say that these are the mHealth intervention. Those type of intervention we have included. And then type of outcome, exactly what we want to bring out the findings. It's like maternal outcome, neonatal outcome, or is it the type of surgery, is it the length of stay of the patient in the hospital, or whatever it is, depends on our need of identifying the data. So depends on that, we need to clearly write in our protocol what are the different types of studies we are going to use, type of participants we are going to use. So all this should be very clear. Then the search strategy. In the search strategy, we need to put up what databases and sources will be searched, what will be the time period. It's a what databases, I'll be coming back again, like we may have electronic databases, or maybe we may need to go for Grey literature search, all those. Then what will be the time period? Time period, are we going to include the studies, those who are published from last 10 years? Or are we going to include the studies, all the studies, those who are existing? Or like say from 2000 onwards? That's again, we need to, that is depends on what is the purpose of our review. Then what search terms and keywords are that what we are going to use? What are the search terms that we are going to use? It should be very specific to PICO. It's for population. If it is children, what are the different search terms? It may be controlled vocabulary like mesh term, M3 or CINAHL subheadings. What are we going to use? Or just a plain keywords that we are going to use in the, or we are going to search for synonyms of these keywords and are we going to include. So all these need to be clearly, and ideally it is during the protocol stage itself, it is we need to prepare a search strategy, search string, and just try to put up in the at least one database and search and see whether we will be able to get any studies relevant to this and as per our filters or the restriction what we imposed. Then will there be language restriction? Sometimes some of the reviewers, they argue that there should not be any language restriction as many translators are available. But if most of the times we may think that only the English language that we are going to include, then how will conference abstract be handled? How are we going to handle the conference abstracts? Whatever the abstract what we get, maybe some of them may be published through Scopus, or some of these abstracts we may get through proceedings of the conferences. So all those we need to clearly spell out. Then will unpublished data be sought? Like thesis databases like ProQuest, dissertation databases, or maybe like our different libraries are we going to approach and get the data from there? And the more important one is who will run the searches? That should be, as we know the methodology, two reviewers need to do the search simultaneously. So we have to decide who are the two people, those who are going to do the search. That should be independent search. Then only we can say it is a systematic review. Then electronic databases, we may have this Cochrane, we have Medline, can be accessed through PubMed, or Medline can be accessed through Ovid. The only difference is Ovid is a paid one, PubMed is available in most of the, like it is free. Only thing, the articles which are not open access articles will not be able to access, like get the full text of those PubMed. But Ovid is paid, we have to subscribe. At the same time, the articles appears early in Ovid compared to PubMed. Then we may think of Science Direct, Scopus, Embase, CINAHL. CINAHL is again nursing and health, allied health related. Most of the journals are indexed in this. Then PsycInfo, it is mainly for mental health related topics. Then Web of Science and ProQuest. So these are the different, we need to decide what based on availability of these databases. So if our library has 3 databases, yes, we can limit to 3. If we have 4, if we have 5, so how many databases we have, but it should be at least minimum 2 to 3 databases that should be done as an electronic. And electronic database search is very easy. It is less time consuming provided we have access to that. Then trial search we may also need to do, that we may need to put up Cochrane Central register of control trial central. It is available in the Cochrane website. Then like each country wise there are trial registries available, and for India we may think of going for Clinical Trial Registry of India, CTRI. So we can search, think of searching that, as well as we can also think of searching Shodh Ganga, where the dissertations are available. Then we also need to limit in terms of grey literature, conference proceedings, unpublished thesis and dissertation. Then hand searching of non-index journals. Non-index journals, either we may search through hard copies or we may need to online hand searching if those journals are not indexed in our Scopus, Web of Science, any of these. But there are some good journals are available which are not indexed in any databases, but they publish good articles. They are not the predatory journals. So then in those journals we can try to search. Then citation searching, it is citation like once already article has been published, we may look into the reference list of those articles and go back. It is a backward searching what we say. So we may go back to those searching, and then we can do the citation searching. And then health organizations like we have Ministry of Health and Family Welfare websites where we may look into the different data what is available and the articles what is published. Again, that depends on the need of our systematic review. Then systematic review databases also we may need to look into whether the same systematic review, if it has been already done, there is no use of having this carrying out this systematic review. Like Campbell collaboration, we can see Cochrane database libraries, we can see DOFER, that is database of promoting health effectiveness review. Then Epicenter, where evidence for policy and practice information, all this is the one which we also had some kind of collaboration with our that is under USGIL. And then Joanna Briggs, that is JBI Institute, and 3IE. 3IE is the one which talks about more about agriculture and nutrition, malnutrition related type of studies. Whereas Campbell will, now recent days, Campbell also has started taking up something with related to health, but not directly with the health. Campbell collaboration will have this all social science, so there's criminology, so those kind of systematic review, and also recent days like how the climate change and those type of review we can find even in the Campbell collaboration. Then what is the process? How are we going to do the data collection? Usually selection of studies takes place in 3 steps. So that should be clearly specified. So first step is identifying articles using search strategy. Then select the titles if appropriate and relevant. In the step 2, abstract review by author 1 and 2, and then consensus regarding the inclusion of studies. And the third step is independently review the article by 2 reviewers, and if disagreement, consensus by the 3rd reviewer, and final decision to include the study. Then the next one is, once it is done, data management. So in that data extraction, where we have to decide who and how many reviewers will extract the data, Is it one reviewer will extract the data and other one will cross check on a random basis, or is it two reviewers will extract the data independently? If you are exporting the articles to the RHINE software, screening also has to be done by two reviewers independently. Then what data will be extracted? What data again? Like we may need to include the study IDs, the author, setting, then what type of research design, what is the sample, sampling technique, sample size, what is the intervention, how long the intervention was delivered, and then what is the outcome of that study. So this much data, and we may also need to include, if we are planning to do the meta-analysis, specific statistics also need to be extracted. So then what data extraction forms are we going to use? We can, for intervention studies, we can use Cochrane form. It is around 19 page. But if we feel that we don't want it is too lengthy, then we can develop our own data extraction forms, and then how the validity of the data extraction forms will be done. We may be doing the earlier, like before the complete data extraction, piloting of this data extraction form can be done by on 3 or 4 studies and see whether the data, what the form prepared is okay. If not, we can modify it. Then how will the reviewers resolve the disagreement? Who will be the third person who we can give the suggestion? Whether it is a methodological expert or maybe statistician or the subject expert in the team, that we need to decide. Will data be checked for accuracy? Whether the third reviewer will check for the accuracy of what the data has been extracted, and missing data. How do we handle the missing data? So are we going to go back to the author, or are we going to exclude that study? If we feel that it's more than 50% of data or not relevant data is available, then we may need to exclude. But that process should be put up in the protocol section. Then assessment of the study quality, that again we need to decide who and how many reviewers will assess the study quality. Is it by one reviewer? What instruments or scale will be used for quality assessment? If it is intervention studies, very well we can use ROB2 of Cochrane. If it is not Cochrane study, then there may be, like there is a Jadad scale is there for intervention. There is CASP is there. There are different scales are available. If it is non-intervention study, the non-RCT, quasi-experimental studies, there is a Robbins 2 scale is available. So all this we have to think of when JBI scales are available. Then will a numeric quality score be measured? Are we going to take up the scoring and grade that poor quality, high quality, moderate quality, or are we just going to put up the whether it is acceptable or not acceptable? That we need to decide. Then how will the reviewers resolve the disagreement? How will they resolve? Are we going to go back to the statistician and or with the methodological expert and say, especially the ROB2, it has got so many areas to be considered, allocation, then blinding, then assessment of the outcome measurement. So there are so many areas to be. So then it will be like when we read the article once, it may be very confusing. So we need to be thorough with what is ROB2 before doing. So that's how we need to decide who is the person who will do the study quality. Person who has some knowledge about RCT or non-RCT only should be assigned to do the quality check. Then data analysis. Again, we need to decide what software will be used for data analysis. Like there are so many softwares now, even Jamovi also we can do the meta-analysis. Then how will heterogeneity be evaluated? When, what percentage or what level of heterogeneity you will include in the, or you will exclude in the study. Then if meta-analysis is done, are we going to use random effect model, or are we going to use the fixed effect model? Then will sensitivity analysis will be done and publication by us. Are we going to draw the funnel graph or funnel plot? And how are we going to do this? This much information should be available under data analysis section. Then other components, if we are publishing, then we need to put up the discussion section. We need to also decide about the protocol registration. If the systematic review to be accepted by the publisher, it is ideal to go for protocol registration. If you don't register, then the acceptance by the publishers will be a little bit delayed, because they say that it has not followed a standard. Then abbreviations, additional files, conflict of interest, acknowledgement and references, all these should be put up. It is very much required when we are going to publish a protocol. So then guidelines, we can follow Cochrane, or we can follow PRISMA guidelines, or most guidelines, this can be followed only mainly for the observational studies. Then, or maybe we can go for CRD, that is Center for Reviews and Dissemination, AHRQ, that is Agency for Healthcare Research and Quality. They also have the JBI Campbell collaboration, JBI Joanna Briggs Institute guidelines. So we need to specify any of these guidelines which we are going to follow in our review. Then this is where we can get the guidelines. If you go to the Equator Network, you can see the PRISMA, CONSORT, STROBE, all these guidelines are available. You can look into this and follow those guidelines. This is about mainly PRISMA, where we need to put up the PRISMA checklist, PRISMA flow chart, PRISMA statement, all this we can. That is mainly go for the Equator Network. You will get all this information. Then in the protocol registration, we need to have rational background, potential contribution of the review to the clinical decision making. Then also, is there enough relevant literature to merit a systematic review or meta-analysis of the studies? Then inclusion, exclusion criteria, PICOs of interest, that is population intervention comparison outcome, and also studies to be considered. And then sources you will use to search the literature, search and syntax if possible. Then screening methods, what we are going to do, data extraction method, methods to assess for bias and contact details. These are the components that is required when we are doing the protocol registration under Prospero. So Prospero, we can do the protocol registration. So Prospero is International Prospective Register of Systematic Review, where we can register, or we can also look for what are the already registered systematic reviews and whether those systematic reviews have been completed. This is again Cochrane database of systematic reviews, where you can see Cochrane reviews and protocols under Cochrane database. So now I'll just show you one sample of the protocol. So this is the protocol which I was saying about our JMIR research protocol. Under this is the efficacy of mHealth intervention for improving maternal and neonatal outcome among pregnant women with hypertensive disorders. It's a protocol for a systematic review. So you can see this, it's abstract. The abstract has background, objective, methods, results, conclusion, and Prospero registration. Then keywords, then the introduction. We have not put up separately like Cochrane what is required. And then we have then the aim of the study. Then we have the methods, that overview. We follow the PRISMA Pre, guidelines, and also it is registered in the Prospero. Studies eligibility criteria, we have inclusion and exclusion criteria for according to the study, sample, intervention, and outcome. Outcome in terms of maternal mortality, maternal morbidity, perinatal death, neonatal morbidities, knowledge of the disease and its management, health behavior, and early identification of warning signs. And then it is English language, and between January 2000 to January 2023, and all settings across the globe. This is our inclusion criteria, and this is exclusion criteria. Then search method, we have search, it is getting ready for publication. So PubMed, Medline, ProQuest, CINAHL, Scopus, Web of Science, and Central by 2 independent reviewers. We have specified TP and AD, that is their short name. Then medical subject headings, terms and subject headings and keywords will be searched electronically, and we have given that in the appendix of the search strategy. Searching for other sources like Clinical Trial Registry of India, and WHO International Clinical Trial Registry platform. Then data management, where we have put up like selection of studies, how we will do, and then data extraction, how we will do, quality assessment, how and who will do, data synthesis, and how we will assess, assessment of heterogeneity and bias reporting, subgroup analysis, and ethical consideration, as there is no need to have a ethical approval, as we are going to take up only the published. Then the results, here it is only it is the requirement as per the journal, and then discussion about this is the discussion section, limitation, conclusion, acknowledgement, data availability, author's contribution, conflict of interest, and then the references, then the abbreviation. So this is what we have here in this JMIR. And at the same time, I think I will just show you one. This is Cochrane systematic review protocol. You can see there is a slight difference. So this is protocol in this abstract, that's objective. And then there is a background description of the condition. So it is description of the intervention, how this intervention might work, and also why it is important to do this review. So these are the 4 components to come up in the background. And then there is objective, then the methodology, like criteria for considering studies for this review, like type of study, type of participant, type of intervention, type of outcome measure, here primary outcome, then there is secondary outcome, then hierarchy of outcome measure they have put, search methods for identification of studies, electronic searches, searching for other resources, then data collection and analysis, selection of study, data extraction and management, and then assessment of risk of bias in included studies, then measurement of treatment effect, analysis, unit of analysis, if there is any issues, then dealing with missing data, assessment of heterogeneity, assessment of reporting bias and data synthesis, then subgroup analysis like gender-wise, age-wise, pre-operative, comorbidity-wise, so how they are going to do, they have specified, then sensitivity analysis, then summary of the findings and assessment of certainty of evidence. So this is the Cochrane systematic review protocol. So that is how we may need to look into. It depends on how we want to go ahead with our systematic review. We decide what is the purpose of the systematic review, and then based on in that way. And Cochrane will have only interventional type of systematic review. They do not have any observational studies. And review manager we cannot use for intervention studies. There are many like Stata, Jamovi, all this we can use for observational studies. So that is, these are the different references, and thank you so much.
Thank you, ma'am, for your insightful presentation.
Any doubts or would like to add some points? I could see Dr. Nalini on the dais and many other eminent personalities. So anyone would like to add something, may please contribute. Hello?
Is there any question? No doubts, ma'am.
Any doubts or anything to be contributed?
No doubts, ma'am. Thank you, ma'am, for your insightful presentation.
If no doubts, thank you so much.
Thank you, ma'am. Excellency is doing extraordinary thing. Extraordinarily well to have an excellent ending. I feel extraordinarily happy to say about such an excellent personality, Dr. Shejila, currently
Any
serves.
doubts?
No, ma'am. No doubts. Thank you, ma'am. Thank you so much.
Any technical issues there?
Ma'am, can you hear us?
Yeah, we can hear you.
Yes,
Now
ma'am.
we can hear you.
No, delegates does not have any doubts, ma'am. Thank you so much for your presentation. Ma'am, ma'am, we are moving on to next
I think some
presentation,
echo.
ma'am. Ma'am, ma'am, can you hear us?
Yeah, I can hear, but some echoing is there.
Yes, ma'am, we are moving to a next presentation, ma'am.
Hello? Yeah. There's no suggestions? Okay. Okay, fine. Thank you.
Excellency is doing extraordinary things, extraordinary well to have an excellent ending. I feel extraordinarily happy to say about such an excellent personality, Dr. Shejila, currently serves as a professor in Department of Medical Surgical Nursing at the College of Nursing Sciences, Dayananda Sagar University. She holds a BSc Nursing from Mahatma Gandhi University, Kottayam, Kerala, and MSc Nursing in Medical Surgical Nursing from Rajiv Gandhi University of Health Sciences, Bangalore, and completed her PhD in nursing from Manipal College of Nursing, Manipal Academy of Higher Education. In addition to her formal education, Dr. Shejila has pursued specialized certification, including certificate courses in simulation, health sciences, education technology, and KUHS quality assurance system from Kerala University of Health Sciences, and a certificate in bioethics and biostatistics, research methodology, and epidemiology from Manipal Academy of Higher Education. She is currently pursuing a FAMR fellowship at Mahe FAMR University. Dr. Shajila brings a wealth of teaching experience to her role, having held positions such as professor, vice principal, associate professor, lecturer, and assistant professor in various prestigious institutions. Her research contributions are notable, having completed 5 research projects and currently involved in 4 ongoing projects, including one funded project by DHR. She has guided approximately 14 research projects for both undergraduate and postgraduate students and secured nearly 8 research grants and travel grants at national and international levels. Her scholarly output includes publishing 7 articles in Scopus Index Journal, 4 in other index journal, with 2 papers currently under review in Scopus Index Journal. She has presented 6 papers in international conferences and 4 in national conferences, and served as a resource person for numerous international and national conferences, workshops, and seminars. Dr. Shajila has also organized several international and national conferences, workshops, and seminars, and actively participates in academic conferences and seminars worldwide. Dr. Shajila is a respected member of various professional organizations, including Sigma Theta Tau, International Nursing Society, Union for International Cancer Control, International Society of Nurses in Cancer Care, Oncology Nursing Association of India, Nursing Research Society of India, and Critical Care Nursing Society of India. She has received several awards and recognition, including the Institute of Nursing Scholar Research Excellence Award in the year 2021, Best Teacher Award from Kerala University of Health Science in 2020, and Best Paper Award by Manipal College of Nursing, Manipal University in 2018. Her commitment to advancing nursing education and research, coupled with her extensive academic qualifications and research experience, underscores Dr. Shajila's leadership in the field of nursing. Please join in me welcoming Dr. Shajila for her enlightening presentation. Welcome you, ma'am.
Hello, good afternoon to all.
Good afternoon, ma'am.
Can I start?
Yes, ma'am, you can start.
Can I start the session?
Yes, ma'am, can you hear us?
Yeah, yes, I'm able to hear you.
Yes, ma'am, you can start now.
Can I start the session?
Yes, ma'am, you can start, ma'am.
Can I start?
Yes, ma'am. You can start the session, ma'am.
Hello, can you hear me?
Yes, ma'am, we can hear you.
Okay, thank you. So good afternoon to all. I'll be taking the session on systematic review and Cochrane review. So from in the morning class itself, you might have the sessions has explained what is a systematic review. So still I would like to say that it is a rigorous and organized method to synthesize the evidence from multiple studies on a particular research question or a topic. Review is to identify, appraise and summarize the available evidence which is relevant to a particular question, and it is in a transparent and replicable manner. So usually the systematic review will aim to provide a comprehensive overview of the academic literature which is concerning a particular research question or a topic. So we have seen in many of the books and other things and all, the hierarchy of evidence. You know that the strongest evidence will be from systematic review and meta-analysis. Then what are the features of a high quality systematic review? So as per Higgins, in 2011, he has outlined some of the features of a high quality systematic review. So a high quality systematic review should have a clearly stated objective, and it should have a predefined eligibility criteria. So already Baby Madam has already talked about the how to prepare the protocol of a systematic review. So in that she might have discussed the objectives of a systematic review, what are the eligibility criteria to be done for selecting the studies, and so that is coming under that. So each systematic review should have the high quality systematic review should be having a good stated objective as well as a well-defined eligibility criteria for conducting the study. Then it should have a reproducible methodology. So somebody should reproduce it or it should be replicated later. Then systematic search which attempt to identify all the studies that one or meeting the eligibility criteria. So a good systematic review, the search strategy and all should be defined in such a way that it can identify all the possible studies to be included in the systematic review. Then assessment of the validity of findings should be included in the study. So when we are finding out the findings or result of the study, how we are going to check the validity of the studies or results what we are getting. Then systematic presentation and synthesis of characteristics which has been got in the particular review. So how we are going to systematically present and synthesize the evidences which are being obtained from a systematic review also tells the quality of a high quality systematic review. Then these are the steps what we have to be followed in a systematic review. So first one is identifying or framing the research question. Then second one is planning for a systematic review, that is creating a systematic review protocol itself. Then following after the systematic review protocol, developing and registering it, we can go for actual search for the studies. So in searching the studies, we have to select appropriate studies. We have to extract the data from the particular study. Then what all things we have obtained from the result, that has to be assessed for the quality of studies. So what all studies we are obtaining through a systematic search should be validated for its quality. Then combine the data. Either we have to see that what kind of outcome we are getting. Based on that, we have to simply synthesize, or we have to make some description, or based on the type of data we are obtaining, we have to go for a meta-analysis also. Then again discuss, we have to compare what all things we have obtained with the other studies, and a conclusion should be also made of the overall studies. And finally the data has to be published or to be disseminated to the public. So these are the steps coming under a systematic review. So the first thing itself is mainly there are three procedures. One is planning of the systematic review, then conducting a systematic review, and publishing the systematic review. So we know that a well begun is half done. So initially when you are planning for the systematic review itself, you have to make a proper protocol. So if you have doing or preparing a good protocol by discussing with your colleagues or with the team itself, will be reducing half of your work. So that first one is under the planning of systematic review, formulation of a team, developing a proper research question or objective, developing a good protocol, and registering the protocol is coming. Then the next step will be actual conduction of the systematic review. So what will be coming? So before planning the systematic review itself, we should understand why we are doing a systematic review, whether to address a gap in literature or provide an evidence on a specific topic or a specific research question. Then we have to do a preliminary search before starting of a systematic. We may have some topics or research questions in mind. So what we have to do is, before doing that particular starting of the systematic review itself, we have to have some initial searches. So why we have to do the initial search is to ensure that no repetition or no repetition of the topic should be said. Somebody might have done the systematic review recently, so there is no need of doing a systematic review again if it is not more than 10 years or 5 years or something like that. Then determine the need for a review itself. You have to see that why you are doing a review, and if you are properly planning or doing an initial search itself, you can know that what all are the articles are to be included in your review also. So do an initial search before starting the systematic review itself. Then when planning for a systematic review, what all things you have to be noticed. So while starting a systematic review, you have to see that if any already existing researches or topics are there in your topic, you have to see the date of update, how many years back. So maybe sometimes the same area somebody might have done the systematic review being done some 5-10 years back, or maybe if it is done within 3 years. If it is being done within a recent period, there is no need for doing a systematic review again. Then you also have to see if such a study is existing, whether it is well conducted, steps of a systematic review, whether it is a high quality one. Then method should reflect the specific criteria of interest of your topic. You have to see the methodology what they have been following. Then again, see that whether there is any gap in population, intervention or outcome which has not been addressed. You have some systematic review ideas in your mind. You have to see that if it is being already done by something, whether they have made it, whether they have done it properly, whether the specific criteria of interest of the topic has been met, methodology was correct. Still, whether there is any lack of clarity in this population, intervention, outcome, so which is not being there in that particular review. If you are seeing that there is gap existing, that it might have been done 10 or 15 years back, means you can definitely do for a replicate the study. Then if it is doesn't having following a proper methodology also, you can conduct a systematic review. Or if it is having lot of gap in literature also, you can decide on going for a systematic review on that particular topic. Then again, formulation a team. So formulation of a team is very essential for doing a systematic review. So we need a team of people to identify the studies, selection, data extraction, and rating the quality of the studies also. So minimum you should have a 2 independent reviewers should be reviewing and extracting the data to reduce the biases or errors. So the team should include a general or a person who knows the general systematic review methodology. Then you can add a librarian in your team. Then there should be expertise, such as those who have expertise in statistical. If you are going for some meta-analysis and all, you can have an expert from the statistical field. Or if you are going for an economic analysis, you have an expert from that field. Then knowledge of those who having knowledge of the topic area, your specialty area which you are doing, the one expert should be from there also. So these people are the team that should be included in a systematic review. Then developing a systematic review protocol. Already Baby Madam has explained that one. So when you are preparing a systematic review protocol, you have to follow the PRISMA guidelines. PRISMA P guideline has to be followed. That is exclusively for it is a checklist for what all things we have done in the systematic review protocol. So PRISMA reporting P guidelines. So it is containing around 17 items that has to be ready, so that you will be following the steps in a systematic review protocol. Then registering the protocol. So Madam has already might have discussed about this. After preparing the protocol, we have to register the protocol in Cochrane library site, in Prospero. If you are planning to do a systematic review according to the John Briggs Institute things, you can register it in the John Briggs or in the OSF also. OSF means Open Science Framework. So you can register in that site also. Cochrane, Prospero, JBI or OSF. Each particular these registries will be having their own methodology. So you see that Cochrane methodology is little bit different. Overall the systematic review steps are same, but the tools which are being used in the different this Cochrane is following their own methodology, and JBI has their own methodology also. So you have to see that which site you are registering. According to that you prepare the protocol. Then most of these sites, the registration is free and open to anybody who is conducting the systematic review. So registering the protocol is also important. Then formulating the research question, that also in the morning session it has been taken. So PICOT's format should be followed for framing a particular systematic review research question. So it should have population, intervention, comparative group, outcome and design. PICOT should be followed. So there are other formats also. So we are familiar with the PICO formats. There are more than around 25 other question frameworks are there. So like PEO format is there, Spider format is there, SPICE format is there, and Eclipse format is also there for framing the research question. Most commonly we are finding is it depends upon the type of studies. So most commonly we are finding it with the PICO session. PICO will be followed for framing the criteria. Then developing the search strategy. So based on the, we have some keywords. By using the keywords only you have to search. The search strategy will be taken by somebody else in the afternoon. So I am just going through that search strategy. So developing the search strategy is also very important. So based on the keywords or what we are using in the search strategy only, we are going to get the studies. Our aim is to get a high quality study. So you have to have a proper search strategies to be developed, and this search should be conducted by 2 independent reviewers who know the search methodology also. So you can check for different bibliographic databases. Even you can check the clinical trial registries for studies, and you can go for gray literature and all. So it should be this literature, from the literature which is cited in a particular study itself can be used for, or the references which is given in a particular study can be also used for taking up a different or getting different studies. So most commonly we have to follow minimum 2 or 3 databases for a for conducting a good systematic review. So you can have any sites like ProQuest, PubMed, Embase, CINAHL is there. So any of these, according to your scope of the review or a subject, you can take any of the 2 or 3 databases for conducting the systematic review. So that is also making the search strategy is very important in conducting a systematic review. So you can use the Boolean operators also, while you are searching this thing by using and, not, or like that. It can be used for the searching of a particular papers in the review. Then once what you have to do is, you may be searching in PubMed or maybe in some of the Embase like that. What you can do is you can register in that particular site itself. There is a sign-in option, that same like how you are signing in a Google or signing in Facebook or whatever it is. You can sign in that particular database site, and you can retrieve or you can register the what all searches you have done there. So if you are not registering, you may not be able to go back and search for your searches. So what you have to do is you have to sign in that particular site, like it may be a PubMed or something, and you can save your searches there in that particular site. So what you have to do is you can use some managing references to searches what you have, the studies you have done. So like the searches can be saved there, and later on you can that references what you are getting, maybe you are searching for 10 years of studies, maybe you are searching only studies who are published in English, or based upon your search strategy you can save the searches there, and later on all the references you can be downloaded in EndNote, Zotero, like that. You can use some reference managing softwares for saving these particular references also. So this will be useful when you are doing the screening of the articles. So you may be getting sometimes 1,000, 10,000 or maybe 20,000 of articles during the initial phase, or even more than that. So we may not be able to include all the studies. So what all references we are getting, we have to use it with the reference management software, and later on we can do the initial screening and full text screening and all. So this one is after the search you can download the searches, or you can save, and by using the softwares you can download your references also. Then screening of the articles is the next stage. One is, first we have to see the abstract or title screening of the articles. So in all these steps, 2 people should independently do the screening. So two people should have been there for the research, and this title screening also should be done independently by the two researchers. So if you have any conflict while you are screening the title or something like that, what you have to do is you have to find out a third person for resolving your conflict among the two people also. Then initially by abstract or title screening, you may be getting some of the articles. When you are reading the abstract itself, you will be identifying that whether the study will be suitable for our review or not. So you can again save that. And some of the, I will tell you some of the softwares which are helpful in title screening, full text screening and all. So initially itself, after doing the abstract screening, next step we have to do the which all articles we are getting from that the full text review, the content review also you can do with the some of the softwares. So these are some of the softwares which will be helping you for. So it may be difficult for you to read 20,000 articles for titles and all. So there are some softwares which are helping you for doing the title screening and all. One of that one is a Covidence software. So it is not free, of course, but you can use the trial version. So Covidence is there, Ryan software is there, Epi Reviewer software is there, Cadma and Disler are. So these are some of the softwares which will help you to do the title and abstract screening of the articles. So you need not to sit down and read the whole thing and all, but still this article will try to avoid the duplicate. Maybe you are getting articles through Procost. The same study you may be getting through if you are in your Embase search also. So each this database will be having some of the articles. So it may be replicated sometimes. In Procost will be having one article, the same article you may get it from Embase or like that. So it should not be duplicated. It is the same study you are getting. So the same study, it should not be duplicated. For that also this Covidence software will be usually that will be also helping you for doing the abstract and our title screening and even full text screening also. So these are some of the softwares. Then again, this is the Covidence software. Once I have used this Covidence software for removal of duplicates as well as for title and abstract screening and all. So this is another one. Ryan software is this one which can be used for this title abstract. Then again, any issue is there?
No, ma'am.
Hello?
No, ma'am. No issues, ma'am. You can continue the presentation, ma'am.
Hello?
Ma'am, no issues, ma'am. You can continue the presentation, ma'am. You can continue the presentation, ma'am.
Ma'am, did you hear me? Hello? Ma'am?
Hello, madam. Are you? No problem, no. Because suddenly some verification has come. That's why I had a doubt that whether I will be able to continue or not. I can proceed. No. Okay.
Hello.
Okay, thank you so much. So Ryan is another software which we can use for this title and abstract screening. One is Covidence and one is Ryan. Then another one is Distiller R. This is also will help you for us literature review, which can be used for this literature review search. There's this abstract and title screening and all. So I have told three major one. One is Covidence. It will be also helpful in duplicate removal also. Then Ryan is there and Distiller R is also there. Then data extraction. So when you have got enough articles, you have retrieved some full text articles and all, what you have to do is you have to extract the data from that particular researchers. So describe how the data can be extracted and what kind of information we want to extract from that particular study. So if you are planning for a meta-analysis also, we have to have that thing in your mind. So what are things we have to take from the particular studies. So how usually this is the format. So each one will be having a separated data extraction form. If you are following a Cochrane review, means Cochrane has got a separate data extraction form. Even if you are following a JBA like that, you can have a JBA data extraction form also. So the common things which can be included in the data extraction form is name of the author, year of publication, which country the study is being done, aim and purpose of the study, what was the population and sample size of the study, what was the methodology used, intervention type or comparator details, and duration. If intervention is given, how long the intervention has been done, and what are the outcomes which are measured, and what are the key findings of the study. So these things should be normally included in a data extraction form. So this is an example of a JBA data extraction form. JBA has got its own data extraction form. So you can refer it in the JBA site, Jonah Briggs Institute site. You will be getting this data extraction form if you are following a JBA method. Then this is that method which is followed by the JBA. Then this is one which is followed by the Cochrane. Cochrane has 81 items has to be filled in that data extraction form. So it is a little bit bigger form. It is including much more details to be included in the Cochrane data extraction form. So it is a country in which study has started, then eligibility criteria of the particular study. So like that it has got a different data. So this one is I have in when I did the tool systematic review, I have followed my own form which is adaptable to my search. So this is like how we are preparing a data extraction table. This data extraction table for the study characteristics has to be included in your publication. So be careful that when you are preparing the data extraction table. Then how we will be checking the quality or the risk of bias in the particular studies. So commonly we have to assess the risk of bias involved in the studies which we have taken. So the bias assessment include ROBE 2 for randomized control trials and ROBINS 1 for non-randomized or observational studies, ROBINS E for non-randomized observational studies or studies of exposure which involve exposure other than the intervention, and ROBVIS tool is mainly used for a systematic review. So for if we are doing overview of systematic reviews, so if we are doing some our studies should, if we are including studies like systematic reviews, we have to use this ROBVIS tool. Then these are the different commonly, these all are the Cochrane suggested commonly used risk of bias tools. One is ROBE 2 for randomized control trial, ROBINS 1 for non-interventional observational studies, and ROBES E for non-randomized observational studies, or it can be for studies which include exposure also. So these are different risk of bias tools we can use. Then again there are other quality checks available like Newcastle Ottawa scale, QUADAS2 scale, AXIS scale, mixed method appraisal. So if you are doing a systematic review of mixed method research, you can use a MMAT form. Then JBA has their own critical appraisal to Institute of Health Economics, which is following the case series studies. They will have their own kind of this quality check assessment tools will be there. So you have to determine which tool you are going to do for the risk of bias assessment. Then again, how we will be synthesizing the data. So at last, what all things we are getting, we have to synthesize the data, that is inclusion of the studies. So what is the final count of the original articles what you have got. So what you have to do is you have to follow a PRISMA flow chart. PRISMA flow chart should be followed while you are doing preparing a systematic review for publication, and at last how many studies has been included, how many has been excluded, what may be the reason of the study and all. You have to tell, you have to follow a PRISMA flow chart. So inclusion of the studies, we have to have a final count of how many studies has been included after the screening process. This flow chart should be shown. As a flow chart, usually that PRISMA flow diagram should be followed in the particular your study. Then study description also should be given. So I told characteristics of each study should be prepared in a table format. So usually in the main body of the manuscript when you are synthesizing the data. Then again, the result, if you are going to do a meta-analysis, it should also include the magnitude of effect, how much you have got the effect in a particular study, then consistency of the effect across the studies and strength of evidence what you have got and all. Then we have to check the reporting bias. Usually there are 7 items are included in the risk of bias assessment as per Cochrane. So there are 7 sessions or 7 items are included in the risk of bias assessment, which is in the Cochrane review. And usually we have to report the risk of bias or in a study also. Then results should be also verified. So somebody, if your team may be including 4 or 5 members or something like that, so you have to verify the result for its accuracy and consistency. This risk of bias assessment should be also done by 2 independent reviewers. So same like that, the search also should be done by 2 people. Then screening and title and abstract and full text screening should be also done by 2 independent reviewers. And the risk of bias assessment also should be done by 2 independent people. Then finally, based on the type of data we are getting in the study, we have to go for whether it need a descriptive synthesis, or if the study has got some methodological heterogeneity, or if the population has got any heterogeneity and all. No, we cannot go for sometimes a meta-analysis. So in case if you are not going for a meta-analysis, we have to give a descriptive synthesis of the study. So that also should be carefully written. That descriptive synthesis also should be carefully written. Then when we are publishing a systematic review, so keep the bibliometric database. So you may have done the review 1 year before, but you should update the review so that we know that a lot of publications are coming per minute. So if you are doing a system, if you have done a systematic review some 6 months or 12 months before, you have to always save the searches. So it may be useful again. So you have your search strategy should be saved, so that we have to update when we are going and upgrading the review also, or updating the review also. We need to have that initial search what we have done. So in order to capture newly published articles, we need to keep the old this database search strategy also. So then only we have to do. So maybe you have done 2 years back, or because of some or other reason you may not be able to publish an article. Still you have to update the review, and then only you can publish. Then when you are when you are publishing also, you have to follow PRISMA or MOOS guidelines also. It depends upon this systematic review and meta-analysis. We are following this PRISMA guidelines usually. Previously, the one I told is PRISMA P protocol. Then this PRISMA checklist has to be followed while you are doing and publishing a systematic review. So most of the journals will be asking you that a PRISMA checklist that has to be uploaded when you are going to publish a review. PRISMA or MOOS checklist, it depends upon the studies you are doing. So you have to have a PRISMA or a MOOS checklist to be written. Then the submission procedures should have also this PRISMA flowchart also should be included. Your manuscript should include PRISMA flowchart also. Then before going to submit, you have to have a subject expert to go through your manuscript. The manuscript should be again reviewed by a subject expert. So it will be better than before. He can also contribute some of the points before going for a publication. So you have to give your article to be given to a subject expert for a review. It is better always. Then we have to when publishing a review, the last review of the result of publication is suggested. So we need to enhance the publication. We have to have a last review. So maybe in your team itself you will be asking some people to review all those things. Then the last interpretation should be proper. So you have to give it to an expert. Then again you have to see that whether all the in a normal case you will be putting the IMRD format for writing the things. So similarly, your introduction or background, why the study is needed, why the systematic review is needed should be there, what methodology you are using. So all the systematic review methodology, the results including the risk of bias assessment, this inclusion study characteristics and discussion part, everything that should be followed by a concluding section also. So same like that, how you are publishing an article, you have to include in this session like that. Then the manuscript should follow the Wisma provided and we have to forward it to the first investigator. So usually before doing that we have to have a first investigator what he has prepared the protocol and everything accordingly whether it has followed that people have to forward it as the review and feedback. Then we have to choose the appropriate journal. Selection of the journal is also important. If you have given the protocol for publication in a particular journal, maybe the same journal will access the full systematic review what you have done also. So you see that what is there in the protocol, what you have written in the protocol, that should be exactly followed for doing the review also. Then when you are publishing the paper, you have to go through the author guidelines also, which journal you are going to publish, your author guidelines is also matters. You have to prepare the particular the publication of manuscript up to the author guidelines in that particular journal. Then what is different in a normal systematic review step and Cochrane systematic review is, Cochrane review is more, it is a systematic way of search of healthcare and health policy, which is Cochrane database of systematic reviews. You can go to the Cochrane site and see that what all things are there. So you have to just, you can go and see that there are different items will be there. So open and see that what all things are there in the Cochrane review. So usually this is also a systematic review which attempt to identify, appraise and synthesize the evidence which meet the pre-specified eligibility criteria to answer the research question. So only thing is this Cochrane review has its own systematic review methodology, which is strictly followed. So usually a Cochrane review will take around 18 to 24 months to complete. So you cannot just simply go and do a systematic review within 2 months or 1 month, or if you don't think that you alone can do a systematic review also. If you want to publish it in a journal or if you want to do a systematic review, you can follow any of the method, but still you see that the Cochrane review is a more rigorous review of the studies. It is following its own methods like this has got a separate forms, a data extraction form and all. So that you have to see Cochrane review. So the type of reviews which is used by the Cochrane is, one is intervention review, then diagnostic test accuracy reviews they are doing, prognostic reviews doing, qualitative evidence synthesis investigations are there in under Cochrane, then methodology reviews are there, overview of reviews, that means review of systematic reviews, then rapid reviews will be there, automated reviews will be there. So all these things are coming under the Cochrane reviews. So these are the type of reviews which is being done in the Cochrane. And then the Cochrane review methods also will be a little bit vigorous, so that identification of the relevant number of different studies. You cannot just simply go and search 1 to 10 or 15 or like that. And so this methodology follows that very rigorous method, and you have to number of studies should be included, including the unpublished also. So you have to find out, and a selection of studies should be for inclusion and evaluation of the strength and limitation and biases. So in these studies you have a very clear or eligibility criteria, then this should follow a systematic collection of data and appropriate synthesis of data. This is very rigorous methodology which is used by the Cochrane. Then Cochrane reviews. So usually you can see the Cochrane reviews. Cochrane protocols are available. So different groups are there. Cochrane review groups are there. They will have Cochrane protocols. So Cochrane central register of controller types are also available from that particular Cochrane site. You can have this Cochrane protocol, Cochrane central register of controller types and all is available in the Cochrane site itself. So this is the Cochrane site of library. You can search here. Then training is also available in Cochrane. So sometimes we have the signing, and if you are part of some Cochrane methodology, you will get the free of course all the training, Cochrane training and all. And you can search that sometimes some institutions, so those who are a part of Cochrane or public activities, they will be conducting training in Cochrane methodology. So you can go on the website, especially in Manipur and CMC review, and they are conducting Cochrane methodology workshop. So if anybody wants to learn the Cochrane methodology, you can attend that kind of guidance workshop is there, you can go and attend. So once you open this Cochrane library itself, you will be able to see which are the guides which are registered, all those things will be seen there in the Cochrane library. So you can explore it.
this is a Cochrane handbook is available. From the Cochrane handbook, you can go and read. So this is also some the latest version may not be free, but you can download it from the Google. It is showing that how this Cochrane methodology is followed. So it is given chapter wise each Cochrane methodology how it will be done. That means even in chapters you can just go and search 2021 version is there review. So you can go and see the Cochrane handbook how it will be done followed in the Cochrane systematic review, how that Cochrane methodology will be followed there. So that also you can go and see. So only thing is Cochrane is following its own methodology like data extraction form, preparing the protocol is a data is a methodology. Even though the steps of systematic review are same, but each of the forms which is used, the risk of bias, the quality of evidence taken, all those things and also that will be particularly Cochrane has a separate methodology. And even Geodatics Institute also, so which is based in Australia, Geodatics Institute also having their own methodology, and they are also conducting sometimes of e-training. So you can go and attend that e-training, and if they are asking them, recently I got an opportunity. One of the writing of an asking, there are some foreign universities which has got ABA center in outside countries like US and some they have, you can go to the site, they will be conducting free online training program. If anybody is interested in that, you can go and attend, and some of the institutions are giving free training also. So I have got an opportunity. I will be undergoing a JPA systematic review training from next month July, in the month of July. It is free of cost. Only thing is the classes will be taken at night because the US timing and our timing will be entirely different. So you can undergo, if you are really planning for systematic review, if you are going for a Cochrane methodology, you can undergo the Cochrane training which is conducted at many of the institutions in India itself, and you can plan to do the JD review. JD has also got some collaborative centers in India. So like Amada in Kerala, then Pushpagiri associated with Pushpagiri Hospital in Kerala, and some one in Gujarat also. So there are some JD centers that you can go and enjoy from there when we are conducting this systematic review training. So you can undergo from there, or you can go and directly ask the JD center, or they will be instructing you that such and such courses are being conducted. And if you are really going and attending that amount will be around 1,37,000. We don't pay that much of amount of money, you can undergo a free training program. So if you go and ask, the trainer's name and all will be described there. You can ask them that if any free training is available, I am interested like that. Actually, I thought of coming over that, madam, but I was not able to attend in person. So I think that if I was coming, it would be more beneficial for the participants. Thank you so much, ma'am. Any queries, ma'am? Any queries are there? Dear delegates, if you have any queries, you can ask. No queries. Any queries are there, ma'am? No queries, ma'am. No queries, Okay. Thank you. Shall I close and move? Thank you so much for the opportunity. Actually, I am having exam, practical exam is going on, so immediately I take for the session. Sorry, I could take it very fastly. Thank you so much, ma'am. Okay, thank you. I will share some of the articles you can give it to the participants. I will share the Maheshwari madam's site or Shanta madam's WhatsApp number. You can share with the participants. Definitely. Okay, thank you.
We are moving to the next presentation. Great leader talks about to be a leader. It's about to be a difference. It is never about the role, but it is about the goal. It's an absolute honor and privilege to welcome a true goal setter, Dr. S.J. Nalini, Professor and Principal Head, University of nursing research, Srivathi Kannan, whose profound contribution to nursing education and research have left an indelible mark on the field. Please join me in giving a warm welcome to Dr. S.J. Nalini, who was the chair of invaluable insight and expertise today. We welcome you now.
Holding a mic at 1:15 is the most difficult task. I know you're all hungry, waiting to break up. I'm not going to take much of your time. Let me be very crisp. I'll stick on. Say 20 to 25 minutes, not more than that. I promise. What do you all understand about this systematic review? So many sessions right from morning. Any sort of understanding you have, what it is, what is that I'm supposed to do? I can see young ones here, faculty members over there. What is your understanding? Anyone? What is supposed to do? At least one or two sentences or one or two words that you learned from morning. I'm just going to go for this young lady. Yes. I don't think I got it. You didn't hear anything? Somebody. Very good. Give a big round of applause. This is correct.
Next slide.
Okay, that's absolutely a wonderful answer. Filter. Simply know that word filter. So many studies are there to filter. Only thing I want to add to what he said is, you have a specific topic. Okay? So many of us do research. So many of us do research normally on a similar topic. Sit down. A topic is done in say in Chennai. Another topic, similar topic is done in say in Mumbai. Somebody does in Italy. Somebody does in the US. Yes. Almost the similar topic. So many topics. So many studies coming with one topic in mind, you add to what is there in literature. It is like something like that. So many bricks together. Today morning when Madam Maheshwari, I think Dr. Maheshwari, what's her name? HD Madam. Mahalakshmi Madam. She told very clearly, information overload is there. One topic, so many studies coming out, you land up with information overload. You are not getting time to read each and everything. So, if you are working in the clinical area, if you want to take decision, what should be done? The best thing is go find out with that question in your mind, see for a systematic review or a meta-analysis. You will get an answer whether whatever intervention or procedure, what you are trying to get an answer is giving perfect result or not. Is that clear? That's a simple understanding about systematic review. So there are lots of studies that is coming out on one topic. How are you going to choose those studies which you are going to take for systematic review is the question. Now in the evening, an expert will be there talking to you on how to search for research articles in so many databases. An umpteen number of databases are there, and at least see to that when you are doing a systematic review, it's mandated that we should go for 3 databases search From there, you get the articles and then go for literature search. And this is going to be the overview. Now, once you do the search in your computer system or manually looking in the journals, you collect the articles. Once you get, you have a definite number of articles in your hand. Say, for example, I search the literature in PubMed when I search on one topic. The topic in the sense, we have done a research study on probiotics and how is it useful for women with gestational diabetes. You know what probiotics are, right? So we did a study whether utilization of probiotics for women who are having gestational diabetes doesn't reduce their sugar levels. Does the HbA1c reduce? Does the fasting blood sugar reduce for the women? So this was the question. So when we did a literature search, we have got a number of studies. Now, when I am trying to have a specific question in my mind, I have to get those articles which are going to specifically answer my research questions. So when I did a PubMed search, I got so many articles. Now I am going to go step by step in choosing which article I am going to include in the systematic review. Say for example, there are about 1,000 articles that you get. Is it possible to scan through every page? My time period for systematic review will get over. So what you do is first is go through the title. So sit and search. Thousands titles has to be coming up in your screen and you have to scrutinize them. Again, when you scrutinize, it should be 2 people who do that scrutinization. It cannot be 1, 2 people individually do the scrutinization. And look out which is fitting to your specific question on top. Again, once the title is done, then you go for abstract. So when you try to do the title search, you will minimize the number of studies. The 1,000 becomes lesser. Okay? Then you have the next setting where you search the abstract. Look into abstract and check whether those studies are fitting for your specific question. So based on the abstract, again 2 people do that. Next you go for full text. So again you can see that one simple word. The gentleman told us filter. So as you filter from the title, you filter and come to the abstract, and from abstract you come to the full text. So ultimately when you go to the full text, you will have lesser number of studies in you. Now when 2 people do, it is not always consensus that come. There are a lot of disagreements that can turn up. What you can do when there are disagreements, not only what you do when you have disagreements between friends, sit and talk. Sit and have a talk and come to a consensus. But here it is fruitful scientific decisions that you take. Sit together and come to a conclusion. In case you are not able to come to a conclusion, you call a third person to review and look for the inclusion of the article or not. Again, if you want to study or research on which articles to take inside, what is more important is you need to have good knowledge about research methodology. So you should know what are all the studies to be included for that. The study designs should be in your steps. Unless and until we are thorough about the type of studies, we cannot choose the best of studies. Is apple and orange the same? Are they different? Apple and orange? Are they different or same? Different. So every study design is different. Right? You have to combine apple with an apple and orange with another orange. You cannot combine apple and orange together. Yes? So that is what you are trying to do. There are different sorts of study designs that are available. So when you are trying to do a systematic review, combine those studies which has the similar study design. That we should take into consideration. Again. Now I know that in nursing we study a little bit of research in undergraduate program, a bit more in your master's program, and when you go to higher level of PhD you study about research study designs. Sit down. If you feel that you are still not having good expertise on study designs, better get access to NEPTEL programs where you have basic study designs which you can get to online education and learn a lot more about that. Okay? So learning about study designs is very, very essential. So this is what the title screening I said. Now just because it is a bit difficult for many of us to get access to do all this searches and elimination using a software, most of us do it manually. Is it not? Every time you do that, every time you get a search result coming up in your PubMed page, the first thing you are supposed to do is take a screenshot and then paste it in a Word document or a notepad. So every time you add and every time you do a search in different databases, take a screenshot. So at the level of abstract, you have to have one screenshot. At the level of your title, another screenshot. Like that, you paste your screenshot. Even those articles, citation should be marked in a separate notepad. So ultimately, first time when I had 1,000 articles, I have a screenshot of the page as well as the listed citations of the 1,000 articles. So this will help me to proceed with the next step. So this you can see is a screenshot which I have taken from a PubMed article for my search on probiotics and gestational diabetes. There's about 194 results that has come. So I just take this as a screenshot and then I have saved each of the citation in a notepad or in a Word document. Fine. This is the manual way we are supposed to do. Once done, I give it to two reviewers. One reviewer is doing it independently for the with search. First I should start with titles, right? So you first check with the title. So you have the articles given to the person who is doing the research. Checking the titles. You can see that the articles are very clearly notified there, which are those articles that is included for the next level of abstract search. Okay? What are those things that you are excluding? What are those things that are kept in doubt? So this is reviewer 1. The next thing is done by reviewer 2, the same way the second reviewer does. Okay? So you have reviewer 1 completed, reviewer 2 completed, then you sit and do the consensus. Okay? Now when you come to a consensus, there is a clarity that is coming out of 457 articles, how many of them have been excluded? 236 has been out, and how many you have included at the level of title is 221 articles. So if there is some difference of opinion, you can call a third person also here. Now next you move on to the abstract. You can see that again similar thing is done in abstract. Two people are doing research and you come to a conclusion which are all the studies that you have to include for your full text screen. Again you can see it is only numbers that is notified. So I have in the notepad which are all the numbers I have jotted down. The same numbers are being utilized here. So this is what you do in case of your manual search. Now you can see the second reviewer coming up for abstract screening. There is a consensus that came up now. Out of 14 articles, how many has been included for the systematic review? It is 7. Okay? So 7 now goes for the final selection, final filtration into the full text. Now when it comes to full text, now every time you do, don't forget to take a screenshot and paste it in your Word document or your notepad. Now what is more important, when you do a full text screening, here the reason why the full text has been excluded from being added into the systematic review. Clear? You need to give a clear directions what is the reason you are excluding that particular article, and if in case it is included, it is in. Again, this is done by two reviewers. You can see two of them very clearly giving their reasons why they have excluded that particular study. Again, you have the arbitration that is coming up. In case a third person is required, they can come inside. In the final search, finally, there are two people who are reviewing. They come to a conclusion. We will add this 4 articles for this final systematic review. And we're moving in a different mode. Back. This one. Okay, so you can see that you need to have the screenshot so that you are able to identify the numbers very clearly, because you are going to formulate a Prisma chart, which I will show you next. What is more important is you need to document what is the syntax. Probably the last speaker will tell you with his expertise how you should take the syntax search which you are using your Boolean operators and or not. So that will be coming up. And then you have to have the screenshot folders as well as your Prisma chart that is coming up next. Now this is the flow diagram, which is very, very important to tell what is the number of articles you have included in each level of search and how many you have excluded, and you also give a reason for what is the reason you excluded that particular style. So this is the recent Prisma chart. Now there are systematic reviews like Cochrane. You keep updating the Cochrane reviews, like every say 5 years or 4 years, depending upon how fast the changes have come. There is chance for changes that is coming up in the reviews. In that case, you don't need to sit and do once again from the first. You can add the additional articles. So this is a flow diagram that tells you very conclusively the new articles that is being added and how it is going to change the concept of review that was there before. So that is how the new Prisma guidelines are coming into fact. Now I told you about manual searches. This is not using manually. It's not easy. Today you are all in a quick world. You want to do everything in touch of a button. So there are a lot of softwares that has come which makes your job very easy. So you can see that you have reference managers like Mendeley, Entro and Zotero. These are all EndNote and Zotero which are available, which you can definitely use, which makes your life easy, because every time you have references getting added from each of the databases, there are lots of chances that one or two databases will have citations which is being done in so many authors. Like one title, it will come up in PubMed. It can be there, is getting repeated in your references. So you need to remove the duplications. So these duplications can be very easily removed using your reference softwares or the other things which I mentioned. Now apart from this reference software, if you have certain softwares like your IAM or co-evidence, like these or Distiller, Cadmium, these are different softwares that are available, where you can use them not only for reference management but also for extracting the abstract and taking these reviews at different levels so that you can easily do it. Now what is more important is, very recently, I think last year, this co-evidence was free of cost, but now it has become paid software. So only software that is now available free of cost is Cadmium, which is now Cadima, which is available now. Now this is something, a co-evidence software where you can see the articles are coming up and all the entries are added as you go through each of the database. You just add the articles. The more the articles you add, you come to a level of how many articles you are doing, and then you do the abstract screening. And at the touch of the button, you can also do the title. Abstract screening is done, which is very easily done using your software. Now this is the full article that comes up. So here you can see an author sitting, an individual independent author or a researcher who is sitting there. She can just view the abstract and press the button of whether to include or to exclude. Okay, so this level gets over very easily. Now then you enter the full text. The full text comes up. Now the use of the software, why I am telling you it is very easy, is the full text comes up as you read. You can also take the data. You can extract the data from each article. So there are two parts that are available. One is data extraction form, the other one is a quality assessment form. Both are available. As you do this, you can also type or cut and paste the important data that you want to extract. Now this is the quality check. Once you complete for one article, the data extraction, you can go to the next form of quality assessment, which everything is done in a software. So it is all very easy for you to do. So this is how life becomes easy if you are going to use a software. Then you can see that in documentation, when you are extracting the data, you need to have a complete documentation as I told you, as it goes step by step. And you also have to have a data extraction form. Again, the data extraction form, it's not specific. You can have, based on your needs, your ideal requirements, you can redo your data extraction form. There are some standard forms that are also available. Like Cochrane has a standard form that is available. It all depends upon what are all those things that you want to add. You can make it further extensively. Simple thing like an Excel sheet can also be used for data extraction. It is not that the software is required. You can do also with your simple Excel form. So just keep track, which I told you. Now these are all the things that you, most important mandatory points when you are extracting data from each article, like the author's name, the patient demographics, the interventions, the outcomes, all these things has to be noted down. So this is the data collection form which you can easily access in the Cochrane. It is available in the Cochrane. So this is one you can use. Okay. Now what is more important, final thing is quality. Not all the articles you are going to include in the study. You have to be very, very careful about the quality. Why is that quality is important? Why the quality is important? Sometimes the studies you include may have a lot of bias, wrong justification. Simple, I just tell you. An intervention which is not effective, okay, it is not effective, it is being projected to have good effect. What will happen? If a clinician or a nurse is going to use that intervention, it is going to be harmful for the patient. So you have to be very clear which are those studies you are including inside the systematic review has to be judged for quality. So before judging the quality, don't include them for your systematic review to be added in the review search as such. So you have to be very, very clear in order to check the quality. Now how are you going to check the quality is also a second thought that comes up. Now there is normally a question, a research question that is put. When a research question is being set, the study, whether the study is asking the appropriate research question is what we call it as external validity. Whether the answers given for that research question is perfect or not is checked by your internal validity. Fine. So by your external validity, you are able to say this particular study is something, the question is very clear. Whereas whether it is being answered properly is checked by your internal validity. For that you need to check the methodological aspects. So that is why I told you, you have to be very clear about the research design and the research methodology. Because when you are checking for internal validity, you look for how the study was conducted, what is the methodology of the study. So this you have to keep in mind, and the results. What is the study results? How much is the strength of the study results? What is the direction of the results? Whether it is positive or negative effect it is having. So all this has to be checked in your study quality. Now how do you check the study quality? Again, you have to check what is the type of study, whether it is a what design, whether it's an RCT design or an observational design or it's a cross-sectional design, that you have to take care. The second thing, there are so many tools and checklists that are available using which you can judge the quality of the study. Like today, whenever a person is trying to review, even for a simple review of an article, when you submit your article for publications, it is mandatory. A reviewer who is reviewing the article has to use these guidelines to check the quality of the article. So these are certain things. I think Shijila ma'am also told you that you have to go to a place called as Equator. A database called as Equator, to which you access, which are all the different types of articles or checklists that are available, which you can utilize in order to check the quality of the particular article. Again, bias, risk of bias. There is also going to be one more person who is going to talk about risk of bias. I am not going to touch on that because of the lack of time we have. So always look for any errors. The quality of the article is judged based on the less amount of errors it has. Look for risk of bias and how precise is the article in order to bring out the results. So the precision depends upon the sample size of the study that is being considered. Then what is the direction and magnitude, whether it is giving a positive result or a negative result. Like whether the probiotics is good enough to reduce the sugar levels or not. Those things, the consistency has to be maintained, and most important, whether the article is trying to give you direct outcomes or indirect outcomes. Like when I said probiotics, directly I am telling you whether it has an effect on HbA1c or FBS or PPPs. It can be also about the complications also. So that becomes an indirect outcome, whereas my FBS and PPPs becomes a direct outcome. Again, you also have to check whether the study has a relevance for application to the future. So all these are being considered on the quality of the studies. So these are all the tools which you can use in order to study the quality, and lots of tools that are available for you to access. So many institutions here, like Jonabricks Institution, there are so many tools that you can use for each type of design of study. So this is the Equator database which you can access in order to look for so many different varieties of study types based on which you can choose the checklist accordingly. So this is an example where they have used Jonabricks Institute checklist in order to assess the quality of the study. So this is a risk of bias graph, colored in different colors. It says that the green color indicates low risk of bias, whereas the yellow one tells you risk is, you are in the middle of the wall, you don't know which side to jump. So there is an unclear bias, and final red one tells you it's a high risk of bias. So you are going to learn about this risk of bias in the next session very clearly, where you are going to see about the different bias, whether the patients have been selected perfectly for the study or you have chosen based on your convenience, whether the patients are blinded for the study. All this will be considered in your risk of bias graph. So these are some of the publications that we have done related to the systematic review. You can even publish a protocol, or you can publish your systematic review. So with this, I'm just going to tell you, whenever you do a data abstraction, two things has to be very, very clear. You have to continuously document each and every step. You need to have records of all your steps, what you have done. Now, if it's not possible for you to understand what we are telling you, please go and read the Cochrane book, or the most simple book which has been released by ICMR. ICMR has given for beginners a book on systematic review, a very simple book which each of us can learn. It's very easy compared to Cochrane. Cochrane has been difficult to understand, whereas this ICMR book for beginners is very, very easy to understand. And go have a look on Equator to judge what are all the study types. Even when you are trying to publish an article, go check the Equator guidelines whether your article is meeting the criteria that has been set. So, happy systematic review from now on. So please try to do simple review. Start with a simple review, then you can go for systematic review. Thanks for the opportunity, Dr. Shata.
Thank you, ma'am. Thank you for your strong presentation. Now I request Dr. Shata Ramesh ma'am to present Mamando to Dr. S. Sami.
I think I stood with my time limits, right? Thank you. Yeah, you're done. It's time for lunch. Please ensure you return within 30 minutes.
Hello. Test. Hey, volume come. Hello. Testing. Hello. 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 Testing. Hello. 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 Testing. ஹலோ ஹலோ கேட்குதுங்களா? Hello. 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 Hello, testing. Hello. 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 Testing. Check. Hello. 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 Hello? 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 ஹலோ மொபைல் எங்க? ஹலோ? ஹலோ? டெஸ்டிங். ஹலோ? 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 டெஸ்டிங். சாப்பிட்டீங்களா? ஹலோ 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 டெஸ்டிங். நான் இந்த லிங்க்கை வந்து நான் உங்களுக்கு ஷேர் பண்ணி பார்க்குறேன். ஹலோ
హలో 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 టెస్టింగ్.
ஹலோ
கேக்குதா? மியூட் பண்ணு வந்துட்டேன்.
ஹலோ டெஸ்டிங். ஹலோ Hello? Hello?
Good afternoon, one and all. Welcome back after the lunch. We are moving ahead. If your actions inspire others to dream more, learn more, do more, and become more, you are a great leader. It's time to know about the significant leader, Dr. Sai Lakshmi Gandhi, currently holding a position of professor and former head Department of Nursing, Nursing Consultant, and Psychiatric Rehabilitation Services, and Adult Psychiatry Unit. Dr. Sai Lakshmi Gandhi completed PhD Nursing and serving in our nursing profession for around 4 decades. She has been the principal investigator and co-investigator for multiple training projects, non-funded and funded projects by ICMR, WHO, Government of Bihar, etc. She has published 136 research articles in reputed national and international journals. She is an author of 15 books and contributed chapters for 32 books and 28 monographs. Dr. Sai Lakshmi served as a resource person for a number of international and national conferences, workshops and seminars. She has also organized and presented over 250 scientific papers in international and national conferences, workshops and seminars. She has introduced nursing faculty as a nursing consultant in psychiatric units. She has initiated MSc Neuroscience nursing course and PhD nursing under Institute Stipend. Dr. Sai Lakshmi Gandhi is a member of various proportional organization and institutional committees. Madam has received many prestigious awards such as Best Outgoing Student, Best Nursing Tutor, Best Field-Based Research Article Award, Dr. Radhakrishnan Gold Medal Award, Best Nurse Educated, multiple Best Posters and Best Paper Awards, and she has received the prestigious President's Medal in Nursing, the esteemed Florence Nightingale Award from the President and whatnot. We welcome you, ma'am, for your expertise. We welcome you, ma'am.
I'm mute कर दूँगा.
Is it audible, ma'am? Can you hear us, ma'am?
Am I audible?
Yes, ma'am. Yes, you are audible, ma'am.
Okay. Yeah, thank you for saying kind words about me. And my slide is
Yes, ma'am. It is visible, ma'am.
So, good afternoon, everybody. I think you have had a lot of information in the morning about systematic reviews,
and also briefly about meta-analysis. So what I'm going to talk about is the fixed and random effect model, and this is more to do with the statistical part of it, and I hope I'm able to do justice to it. I'm not a statistician, but I will do my best to try to help you all understand it. So the outcome of this session is expected that you all will be able to understand and verbalize about fixed and random effect models in meta-analysis. And I will be talking about the meaning of meta-analysis, these two models, and selection of model. So meta-analysis is a statistical method that combines the quantitative results of available primary studies addressing the same question to generate a pooled estimate and confidence interval. So actually, basically, you do systematic reviews on a certain variable of interest. So it could be intervention that you are interested in, the effectiveness of a particular intervention, and now you try to review the available literature based on certain inclusion-exclusion criteria. You will review different articles which focus on this particular variable. So that is systematic review, but meta-analysis is trying to analyze whether that intervention has got a high significance and whether it can be applied in your own setting. So it's basically a statistical procedure combining data from multiple studies. While the systematic review synthesizes evidence, like I told you, addressing a particular specific structured clinical question, and you use systematic methods to search, identify, screen based on your criteria, and then critically appraise, you extract and analyze data from relevant studies. So, one of the questions which a systematic review asks would be to assess the effectiveness of a particular intervention or a therapy. And a systematic review has to be done before meta-analysis. So essentially, in a systematic review of effectiveness, there are two synthesis options. One is meta-analysis and the other is narrative summary or synthesis. Meta-analysis is done for quantitative research, while narrative summary or synthesis is done for qualitative research. So you might do systematic review focusing only on qualitative studies. In that case, you will be doing a narrative summary. But if you do it on quantitative research, more like RCTs, then you will be taking the standard deviation of these different studies and you will be doing the meta-analysis. So like I said, it represents the statistical synthesis of quantitative results from two or more studies. The objectives of meta-analysis generally are to improve statistical power to detect a treatment effect, provide the closest estimate of an unknown real effect, to identify subsets of studies, subgroups associated with an effect which is beneficial, and also to explore if there are any differences in the direction of the treatment effect associated with that specific variable. So reviewers should actually consider and state the objectives of meta-analysis for their review. So next, you have maybe another question. Can you do both systematic review and meta-analysis? So remember what I had said earlier, that systematic review is a step which comes before meta-analysis, but not all systematic reviews lead to meta-analysis because of various reasons. Maybe the variables are different, the interventions are different, the tools are different, and so on. But ultimately, meta-analysis is done when you want to find out the effectiveness of some therapy or some intervention. And it gives very valuable information for clinicians, for researchers, for policy makers, especially more so when you look at drug studies. How frequently is meta-analysis conducted? Now, this is a graph from a very recent journal article, and it shows the number of PubMed articles published over time with meta-analysis in the title. So you will see that over the past 1 decade, the number of studies focusing on meta-analysis has really increased a lot. Now taking back to the quality of research, the levels of evidence, you will see that the highest level of evidence, systematic review of randomized trials, and after this comes the meta-analysis.
Excuse me, ma'am. I'm extremely sorry for interrupting you. Ma'am, your slides are not getting changed.
Okay. What to do? I don't know. I'm moving it here. And I hear a lot of echo also on your end. Should I stop sharing and try it again?
Yes, ma'am. Try again.
Yeah. Is it visible?
Yes, ma'am.
Okay. Will it move now?
Yes, ma'am. It's getting moved.
Where did it stop moving? At which slide? Did you see this slide?
No, ma'am. From back. It was an introduction slide only. First title card. No. Previously the slides were not getting moved, ma'am. It was in the title card only. So we haven't even seen this slide.
Clearly understand what you're trying to tell me. Should I present again?
Kindly continue with the presentation, ma'am. Okay.
Yeah, so objectives of meta-analysis and this question, is it always possible to do both systematic review and meta-analysis? So generally a systematic review leads to a meta-analysis, but not all systematic reviews end up in meta-analysis because of various reasons. Now when you look at, is it visible? My slides are they moving?
Yes, ma'am.
Shall I put it on slideshow? Okay. Is it visible now?
Yes, ma'am.
Okay. So when you look at the frequency of articles published about meta-analysis, you find that over the past 1 decade it has increased. This is from the PubMed journals. And when you look at levels of evidence, did the slide change now?
No, ma'am, it is not changing.
Okay, so maybe I will not go to slideshow. Just 1 second. Is it fine if I don't do the slideshow and just next slide? Because I think there's some problem with slideshow. Now is it visible?
Yeah, ma'am, it is visible now.
So levels of evidence, when you see the highest level in the evidence is systematic review, after which you have the meta-analysis. Will you move to the slide?
Now slides are moving, ma'am.
So I want to go on slideshow and just present it. Is it visible to everyone?
Yes, ma'am, it is visible to everyone.
Okay, thank you for clarifying. So when you look at steps in meta-analysis, you start with framing the question, forming a search strategy, and then trying to search various literature databases. Select the articles based on your exclusion-inclusion criteria, extract the data, and then you will have to examine the quality of the articles and test for heterogeneity. And this is where our presentation is. The estimation of summary effect, that is, whether to use either the fixed effect or the random effects model. And this step is followed by evaluation of sources of heterogeneity, assessment of publication bias, and finally presentation of results. So this part, which is in green, is what I am going to present today. The common terms, there are some terms which I am not sure about the audience, and if there are some students, maybe it would be nice if you all understood the meaning of certain terms. Like effect sizes. So effect size refers to quantitative indicator of the direction and magnitude of the effect of an intervention on the outcome. So generally the test statistic which is used is Cohen's d. So this is between the groups for difference in size, and Pearson's R when it is between variables to assess the strength of the relationship. You also have other terms like common effect sizes reported are the OR, that is a odds ratio, the RR which is the risk ratio, and the RP which is the risk difference. So what is risk in this context? It is a probability that an event will occur. While RR, the risk ratio, is a ratio of risk in one group, that is intervention group, divided by the risk in the other group, which is the control group. Risk difference is the difference between the risk in one group and the risk in the other group. And odds are nothing but the ratio of the probabilities of two possible states of one binary variable. So odds ratio is a ratio of the odds for a binary variable in two groups of patients. For example, if you have an RR of 0.5, it indicates that the risk, that is the probability, is reduced by half in the intervention group. The risk difference assists to put the RR in the context. So an RR of 0.5 might mean that the risk has reduced from 80% in the control group to 40% in the experimental group. So the RP or the risk difference would be 80 minus 40, and that is 40%. So if reviewers choose to use the RR, ideally they should also report the absolute RP effect size. So odds ratio is a preferred effect size for computation phase of the meta-analysis of binary data. The other term which we should know is confidence interval or CI. You will find this abbreviation only denoted when it is the statistics is presented, CI. So a confidence interval displays a probability that a parameter will fall between a pair of values around the mean. So if the confidence interval of CI is very large, it means that the sample does not provide a precise representation of the population mean. Whereas if the confidence interval is narrow or small, it means that there is a higher degree of precision. Like you can see here the bell-shaped curve. The wider this confidence interval, the less the precision. And the narrower it is, the higher the precision. Meta-analysis of continuous data, when you do that, you also need to know some terms. WMD is the weighted mean difference, which is used in all the studies which you have included in the meta-analysis, measure the same outcome using the same instrument. So we all know that you may find many research studies looking at evaluating the effectiveness of a particular intervention and looking at the outcome variable. But sometimes the instrument that we use may be different. So WMD is used when the instruments are same in all the research studies and the outcome is also same. So for meta-analysis computation, the difference in mean from each included study is used. And these results are expressed in the clinical units, which is used for the measurement instrument. For example, the weighted mean difference in all studies included in the meta-analysis measure blood pressure, as we all know, it's measured in millimeters mercury. So in that case, the result will be expressed in millimeters mercury. So another example, looking at studies which measure intensity of pain on a same scale of measurement from 0 to 100. So here again, you need to mention the minimum score and the maximum score. So maybe the minimum is 0 and the maximum is 100, and you should interpret it as 0 may be interpreted as absence of pain, while 100 as unbearable pain. So we also know about positive scores, negative scores. So positive scores, for example, a person is highly compliant to medication, that becomes a positive score. A person who is not compliant to medication score, it becomes a negative score. So you have to mention also how to interpret this when you mention the values. So you have another term, SMV. What we spoke about earlier was WMD, the weighted mean difference, and this is a standardized mean difference. And this is used in meta-analysis of continuous data when the studies included measure the same outcome, but the measurement instruments are different. They are not the same. In this case, the results are expressed in units of standard deviation, but still it can be converted to clinical units with a certain formula. So ideally the results are expressed as ST, standard deviation, and it, like I said, it can be converted to a clinical unit also. So moving on to the models which one has to select when you do a meta-analysis, you have to models the fixed effect model. You have to note that it is singular, fixed effect, it's not effects, this fixed effect because there's only one effect here. It's also known as common effect model. And you have the random effects model. So here you have plural, you have many effects. We will see more about that later. One should understand the difference between these two models. The difference is based on three different parameters, that is conceptual considerations, statistical consideration and practical consideration. So here, when you look at the conceptual consideration, the fixed effect model estimates the effect in a sample of studies, whereas random effect model estimates effect in a population of studies. That is many studies, from which the available studies are a random sample. And fixed effect model assumes that effects are same in all the studies, in all that sample of studies, whereas random effect model assumes that the effects differ across the studies, and the pooled estimate across all these studies becomes the mean effect. So when you look at the parameter of statistical consideration, variance is derived from only within the study variance, whereas in random effect model, the variance is derived from both within the study and between study variance. When you look at practical considerations, the CI, the confidence interval, is narrow, fixed effect model. That means the precision is high. Whereas in random effects model it is wider, so the precision is lower. And large studies have more weight than small studies in fixed effect model. In random effects model, large studies also have more weight, just like the fixed effect model. But it is, the small studies also are given better weightage than the fixed effect model. So that is about the difference between these two models. Also, there are other differences. So here are some data. I don't know how visible it is to you there. Random versus fixed model. If you see, you can see that this one is the random model, the random effects model, and you can see the values, the weights. They are all pretty, well balanced, closer to each other. Whereas here, if you see in the fixed effect model, you can see single digit and you can see double digit higher from 8 to 38. So you will notice that the random effects weights are much more better balanced. So next difference, if you see the confidence interval, like I was telling you earlier, the fixed interval, the confidence interval is very small. You can see this line here, it shows the confidence interval. The first line is the fixed effect model, and the confidence interval is very narrow. Whereas in the random effects model, you can see that the confidence interval is much more broader. It's much more wider. So when you look at the impact of large studies, here you can see some studies and you can see the sample size. So here's a study by Donald, 400. Sample size is 400. This is the largest sample size in these 6 studies which are presented here. And the smallest sample size is by Stewart, 95. When you look at these 2 studies, you look at the fixed effect model, you find that the impact of the large study effect is relative weight is 38 and the small study is 9.6. But the random effects model, you find that the relative weight of the
larger sample size study is 23.16 and the smaller sample study that is biased for is 13.85. So you can see that the impact of the larger study here in the random effects model is less, whereas the fixed effect model, the larger study has got a higher impact. Also, the smaller study has got a higher impact compared to the fixed effect. That means the big random effects model takes into consideration even smaller studies. So like I told you, the small study has more impact on the random effects model. Now, the effective model choice on precision. The next slide is going to show figures, three figures, A, B and C. We have to note that in fixed effect model, the only source of error would be the random error within the study. Whereas in random effects model, there are two sources of error. These are assumptions. That is, one is within the studies and second is between the studies. And that is why this varies wider in random effects model. So, what we need to understand from this is that the random effects model generally produces a more conservative assessment of the precision of the summary estimate than the fixed effect model. So, you look at this figure here, this is 1A and this is a fixed model. These are the studies, different studies. Fixed model and the random model, they yield identical results when there is very little less variability between the studies. Whereas the effective model choice on precision, you will find here larger CL compared to the fixed model. So that means less precision. Again, on the point estimate and precision, you will find a difference. So let's see what that difference is. On the point estimate, a meta-analysis presents a summary estimate usually. By weighing each study according to the amount of information each of these studies contributes. So the weights are calculated based on the variance of each study, which is closely related to the sample size. Generally, larger study with smaller variance or more precise results will receive larger weight than smaller ones that have larger variance and less precise results. But in the random effects model, while it gives large studies greater weight than smaller studies, the difference in weight between the large and small studies is comparatively smaller when you compare it to the fixed effect model, like I had shown in this. You can see in these figure also that the difference is not that much. The effect of model choice on the point estimate, the weights assigned in the random effects model are more balanced, like I had told earlier, between large and small studies when compared with the fixed effect model. And that is why the summary estimates are closer to the smaller study results than the fixed effect model. So the point estimate of the random effect model is closer to small studies and that of fixed effect model. So it's actually beneficial if you have small studies. That is, by small studies I mean studies with small sample size. Now let's look at the assumptions which the fixed effect model, each of these models has. So the fixed effect model assumptions are that there is only one real effect underpinning all the studies and research, and whatever variations are there in the observed results are due to sampling error. It's only due to one error. And the conditions that the researcher should keep in mind. One is that the researcher should be very confident that all the studies that they have selected to apply this model are very much similar. There is not much difference. And the researcher should also know whether it is appropriate to synthesize data from all these studies. And that is why you should have a strong clinical knowledge also. So the fixed effect model to sum up is that all variables that affect the effect size are the same across all studies. Therefore, the true effect size is the same across all studies. While the pooled or summary effect in the fixed effect meta-analysis is going to give you this typical true effect size. And the calculated size is applicable only to this meta-analysis population. So we have to keep that also in mind. Now, moving on to the random effects model assumptions. Here, the assumptions are that each sample has a different underlying effect. So the researcher, for example, you have to have a minimum of at least 2 studies, so maybe 3, 4, 5 studies, RCTs, and you will find that each sample has a different effect. So this difference is a random source of variation. The true effects are normally distributed or they differ from study to study. These are the assumptions. The limitations are that when the number of studies are small, the CI for the mean effect based on the random effects model can be too large for valid interpretations because the precision also reduces. So you really can't have a valid interpretation. And when you compare the weighted means, larger studies tend to lose influence and smaller studies tend to gain influence. So actually we all look at studies with huge sample size, when you want to generalize your whatever results you have got. But here what happens is they tend to lose influence and the smaller studies tend to gain more influence. Looking at the null hypothesis in both these models, like I told, the fixed effect model, the only source of error is within the study variance. And here the null hypothesis states that the typical true effect size is unrelated to the covariant of interest. So contrastingly, in the random effects model, the sources of error are both within the study and between the study variances. And the null hypothesis states here that the mean, because you have different effect sizes, the mean of the true effect size is unrelated to the covariant of interest. So this is the difference. Now, I don't know, you've all just come back from your lunch, so maybe feeling sleepy too. Not sure how much of this sunk in, because it's all to do with mathematics and statistics. But which is the best model to apply? So, what should we consider? There are certain factors to consider. So, Goldstein 2021 states that select the model that matches the distribution of effect sizes and also takes into account the appropriate sources of error. So, depending on the type of study conducted and the nature of the researcher's goals, you have to select the model. And a fixed effect model can be applied only if you are very sure that the studies involved are identical for all intents and purposes. So, we all know that in the real world, this is practically impossible. Even to get 2 studies which are truly identical is very, very difficult. Whereas a random effects model appears to be sufficient and efficient in most meta-analysis. So, I am going to wind up now with these summary points. Winding up, we find that the fixed effect model or the common effect model is based on an assumption that all the studies which the researcher has taken to do the meta-analysis, they have one common true effect size. So by contrast, the random effects model assumes that the true effect size will vary from study to study. And under the fixed effect model, the summary effect is an estimate of the effect which is common to all the studies. Whereas in the random effect model, the summary effect is an estimate of the mean true effects because they vary across the studies. So you have to take the mean value. And the study rates are more uniform, almost similar to one another in the random effects model. And that is why the larger studies and the smaller studies become quite more uniform when you compare the fixed effect model, which actually gives more weightage to the larger studies. The standard error of the summary effect and therefore the CI, the confidence interval, is much wider in the random effects model. So that means the precision is less when you compare with the fixed effect model. So under the fixed effect model, the only source of variation is the within study estimation error. However, how to reduce this error? So we all know that when you increase sample size, you can reduce this error and the common effect size will be estimated precisely. So under the random effects model, this is getting emphasized several times so that you can understand better. There are 2 sources of variation within study and between study. So with a large enough sample size, the first source that is within the study, variation will reduce. However, the between study variance will not, is still huge, and the only way to obtain a better precision is to increase the number of studies. For this, people should have done research. Scientists should have conducted If you don't get, then that is a limitation, you know. So if you increase the sample size in a few studies, you may know the effect size in these studies very precisely, but still you will not have a precise estimate of the mean across all the studies. So the selection of the model should be based solely on the question of which model fits the distribution of effect sizes and thus takes into account the relevant source of error. When studies are gathered from the published literature, usually they find that the random effects model is generally a better model to select. The strategy of starting with some researchers try to do this. Start with fixed effect model and they see if the heterogeneity is significant, and then they try to go on random effects model. But this statisticians say it should be strongly discouraged. Well, the random effects is it's Okay. While the random effects model is often will be the model, there are cases where it cannot be implemented properly because there are few studies that I told you to obtain an accurate estimate of the between studies variance. So with this I will be concluding, and if there are any questions.
Dear delegates, is there any queries? Questions? No, ma'am. There is no any queries.
Okay, so thank you very much, and I thank the organizers for inviting me to present this. Thank you very much.
Thank you, ma'am.
Best wishes to all the audience for the rest of the day. Thank you.
Thank you, ma'am. Thank you for your presentation. Statistical thinking will one day be as necessary for efficient solutions as the ability to read and write. Here I give news about a person who strives for statistical excellence in health sciences, Dr. K.T. Harichandra Kumar, who has 23 years of experience in medical research. Sir was honored with Professor Orange Srivastava National Award for being a young researcher in biostatistics by Indian Society of Medical Statistics. He has delivered more than 150 invited talks, various topics in research, and published more than 100 scientific papers. We welcome you, sir, for your presentation.
Very good afternoon. Hope you are not sleepy. So, are you sleepy? So, mostly are postgraduate students, right? Mostly postgraduate students and faculty members are also there, right? How many of you did a systematic review in your life? Narrative review. Have you done? Review of literature, have you done? Part 4? Just for pulling your guides, no? That's what you do. You are talking about your post-graduation, right? During your post-graduation or your undergraduate, you might have done some review of literature. It is just to pull your guide. Copy pasting, right? See, this is one of a very important area in clinical decision making. Okay, this is called as evidence synthesis. Right? Now we are living in the era of evidence-based medicine, evidence-based research. If you want to take any policy, what is required? If you want to take any decision, what is required? What is required? Evidence is required. Fine? So from where you get the evidence? From where you get it? Evidence will be getting different sources. So what is important? Evidence is there. Plenty of evidences are there. How we are collecting it, how you are collating it, how you are compiling it, how you are analyzing it, and how you are making out information about it. That is what you are doing, right? See, when you are talking about a randomized control trial or any observational designs, what is the evidence? Evidence is the data, right? The data is collected from where? Data is collected from the respondents. So no, we will be going and asking, and we will be collecting data from the respondents. But so you have to go going back. You can just changing it, right? See, you are collecting data from where? Respondent. And that is the evidence, right? That is the evidence. Based on that evidence, we will analyze. Based on that data, we will analyze it. It will come out what the results, right? So, that's what you did. But when it comes to systematic review and meta-analysis, what is happening? Are you collecting data from the subjects? No. You are not collecting the data from the subjects. From where you are extracting the data? You are extracting data from the published literature. So what is the sample in systematic review and meta-analysis? In your study, in your observation study or randomized controlled trial, your sample is nothing but the subjects, respondent or patients, right? From there you are collecting data. That's the sample. You are estimating the sample size, right? How many subjects should be included in the study? How many patients should be included in the study? From there you are collecting data. Yes or no? That is a sample. Sample is a patient, sample is a respondent, sample is the subjects on whom you are going to conduct a study. But in systematic review and meta-analysis, what is the sample? Studies. So no. In systematic review and meta-analysis, sample is nothing but the studies. From that study, you are extracting the data, right? Data is extracted from that. For that, what you should do? You should do a systematic review. Not a narrative review. Reviews of two types. One is called as a narrative review, and second one is called as a systematic review. Fine. What is the broad difference between these two? After this workshop, if somebody is asking, what is the difference between narrative and a systematic review, means that what is the point in this workshop, right? What is the difference between these two? Narrative reviews are exploratory in nature. Exploratory in nature. Anything you can review, right? But when it comes to systematic review is conducted based on what? Based on a research question. That is at morning time, Vishnu Bhatt sir might have told you how to formulate a question, right? How to formulate a research question. Based on that question, you are just reviewing. Question-based, research question-based review is called a systematic review. But narrative review, what is called? It's a very exploratory nature. Fine. So we'll be reviewing it. That's what Madam told. you'll be extracting data, then finally you'll be coming out the result, right? It is an analysis of analysis. That is called as meta-analysis. Okay, already analyzed results are right. Analyzed results are that is what will be published. What you are going to do, that result you are taking and you are going to analyze it again. Analysis on analysis. That is why it is called as meta-analysis. Okay, so it is not a simple job. Systematic review and meta-analysis conduct, it takes a lot of time, and individually nobody can do a systematic review and meta-analysis. It is an effort of team. It is a teamwork. Okay, only one advantage is that it is not necessary that all the investigators should be under one roof. It can be across any corner of the world. See, one investigator can be from here and another investigator can be from different origins. Because what is required? Efforts are required. It should be conducted in a network form. It consists of a combination of people, including a subject expert, clinicians, methodologists. Yes, it's a combination. Individually, nobody can do a systematic review and methods because loads of efforts are required. It's a lot of time you have to devote it. It is not a simply no. It is no. This is not a systematic review and meta-analysis. Because systematic review and meta-analysis talk on the evidence. That's what Madam just told, right? Systematic review and meta-analysis talk on evidence. So you have to do it very carefully in the systematic review and meta-analysis. You cannot take it a very casual approach towards it. Okay? So now I hypothesize that you are aware about systematic review and meta-analysis. I am going to the next level, second level of analysis. That is called as network meta-analysis and multivariate meta-analysis. Okay, so whatever so far we discussed, it is a univariate meta-analysis. I will tell you, simplified. You want a lot of mathematical problems, mathematical formulas, or problem-based learning. Which one you prefer to have? Can I make a presentation with a lot of mathematics, or you want a problem-based learning? Without mathematical formula, the concept should be thrown. Which way you want? Problem-based, right? No mathematics, right? So then I'll just see that is what I have different things. I'll just do the problem-based. I'll simplify it. Right. See this question, simple question. Just read it. How much is the difference in time? How much difference in time for attaining 100 kilometer speed? Okay? From the start, between Desire car and Honda City. Question is simple, no? See, I'm starting the car and I have to reach 100 kilometers per hour. How much time is required? You got it? Immediately starting itself 100 kilometers per hour, right? Gradually, right? How much from the start to attain 100 kilometers speed, how much time is required? Between Desire car and Honda City. Question is simple. Through this I'll come to the medical example. Question is simple. For example, now I have a Desire car with me. Group of Desire car I am just doing it. So what is my sample here? Cars. Group. I have second group. Honda City cars. Group of cars. What I will do? See, I will do an experiment. With 100 Desire car and 100 Honda City, and I'll compare it, right? This is what you are doing in observation designs or what is it called RCDs, right? So now, then what I will do? I will come out with an effect measure. What is an effect measure? What is the difference in the average time? How much time it took to achieve 100 kilometers by Desire? How much time it took to attain 100 kilometers in Honda City? Then like the average time here, I'll compare. That is called as an effect measure. Mean difference. Fine? So, now, there is one study conducted here in Pondicherry. Like this. Another study conducted, so there is an effect measure. Another study conducted in the other place. They compared it. Fine? So, similarly, many studies are conducted in this side. What I want to do? So this is an individual study, maybe conducted by C. Let us suppose this is conducted by Dr. Lakshmi and Co. Lakshmi is a good friend of me. She was from same institute. Fine. So another study is conducted by somewhere else. These are the individual studies, right? All individual studies having its own effects measure. What is an effect measure here? Mean difference. How much mean difference they are reported in study 1, how much mean difference they are reported in group 2, study 2, and how much difference they are reported in study 3. Similar number of studies are there. Fine. What I will do? I will pull all these things. Say, I will pull all these measures and come out with an effect, come out with a measure that is called as a pooled estimate. Okay, so I have not done a study. I have not done study. What I did, I collected the data, I collected the article which is already been published in this slide. Fine? Then I am pulling all these things, I am coming out with the one figure which says whether the design is better than what is called a Honda MS or Honda City, or Honda City is better than this one. By pooling different studies published on same day. Is it clear now? Now, I will convert this into a video example. See, this is a question. What is the efficacy of olanzapine? Okay, on anorexia, among the patients with hepatocellular carcinoma or industrial carcinoma undergoing chemotherapy. How much olanzapine is efficacious in reducing anorexia among the patients with hepatocellular carcinoma or industrial carcinoma undergoing chemotherapy? For getting an answer for this, what I will do? If I am an individual investigator, I will conduct a RCT, right? I will conduct a randomized control trial. One group will get olanzapine and another group will get what's it called? Placebo. Then I will compare and I will come up with an effect size. That is what we are doing. Now, see, many studies are conducted in this slide. Fine, many studies is okay. So this is one study conducted in Jipur. So we have conducted this study. Okay. And let us suppose another study is conducted in somewhere, what's the word, in European population. Another study is conducted in American population. Everybody has come out with their own effect size, right? So what is the effect on anorexia in my population? What is the effect of this, what's the olanzapine on anorexia in American population? So many studies are done across the country. Maybe conflicting evidence, maybe on agreement. We don't know, right? It is not necessary all studies will be same result, will produce same results, right? So it has its own tool. It has its own research. I am getting one result, so the second study is getting another result, and third studies are getting another result. It may be on agreement or it may be on disagreement. Then what I will do? I will pull all these things. Okay, I will put all these things, I will come out with an estimate that is called as pooled estimate. How to make it? That is what is your systematic review and meta-analysis. So I reviewed it and brought it, and after that I am going to analyze the data extraction from the what's called review of the systematic review. Fine? So this is called as a meta-analysis. This is what is sort of been told, right? Analysis of analysis. Fine. Now the question, now see here, this is called the traditional meta-analysis. Traditional meta-analysis. Fine. In traditional meta-analysis, what you are going to do first? We are identifying the studies which is conducted for same comparison, right? See, identify the studies with the same groups of comparison. Olanzapine and placebo across different populations. I will extract it. That's what the keyword, mesh terminology, or Boolean algebra, Boolean operator, and that's a search criteria. By using search criteria, I taken it and I pulled it. And I'll see, I'll come out with that pooled estimate. This is in nutshell systematic review and meta-analysis. Talking is very simple, but doing is no. It is a Herculean task. Okay, fine. Now, what is a network meta-analysis? This is what I am going to do this. It is a little more advanced meta-analysis. Okay, so it's an advanced meta-analysis. So, Madam has told just before, fixed effect model and random effect model, right? Because that's the statistical methods. So here, what are the different types of meta-analysis? What is traditional? This is network meta-analysis. What's the concept of it? Concept is very simple. This is the concept. It is a combination. Combination of what? Combination of two things. One is called as a direct estimate, and second one is called as an indirect estimate. So we are combining these two. Whereas in traditional meta-analysis, only direct estimates are there. No indirect estimates. Fine? So only direct estimate is in traditional meta-analysis, but when it comes to network meta-analysis, it is a combination of direct estimate and what's called indirect estimates. What is this direct and what is indirect? I will tell you. So, as I told you, network meta-analysis combines direct and indirect estimates across a network. It's a network. Across a network of interventions in a single analysis. We'll take a direct estimate, indirect estimate, put it together and come out with that one research. Okay? So that is one. So why it is important? Network meta-analysis can provide information for comparison between the pairs of interventions that have never been evaluated. We can compare the pair that have never been evaluated in a randomized controlled trial. There is no randomized controlled trial is conducted for that pair. Even if there is no randomized controlled trial was not conducted for that pair, still you can make use of that trial for making an indirect estimate. Fine? More precisely, I'll just come this later. Let us suppose I have 3 drugs. I want to compare the 3 drugs, A, B and C. I want to find out which one is more efficacious. Okay? So I want to know which drug is more efficacious. For that I have drug A, B and C. What I should do? I should have the studies, right? I should search the studies for comparing these two, right? For that, just see here, I have study 1. One study is it is compared between A and B. There is one study which is compared drug A versus B. Fine. I have taken another study which compared drug A and C. One is A and B, and the one is A and C. But what is not there? One combination is not there. B versus C. That study is not available. That is, just see, I have treatment A, treatment B, and treatment C. 3 treatment, right? So there is a study conducted between A and B. That I call the study 1. And there is a study conducted. It's available. This comparison is available. You go to the literature. The study was conducted. And there is another study, A and C. This study is also available. But this study is not available. But still, we want to make use of it. We want to know A versus B, A versus C, and B versus C. Which one is more efficacious? Fine. For that, fine. So, this study is not available. What to do? Fine. So here, direct estimates available. Here also direct estimates available. But here, no direct estimates. Why direct estimates are not available? Because that study was not conducted. So in this case, what to do? Here only, we will be going with an indirect estimate. Okay, we are just going to make an indirect estimate in network meta-analysis. So whether you combine this direct estimate and indirect estimates together and come out with one figure, that is called as network meta-analysis. Fine? Just see here, I have B, C, D, 4. I have 4 studies. Okay, 4 drugs. See, there is a study available. 2-arm study. Study already literature is available. And another study is available. Again, 2-arm study. Here also 2-arm study is available. Here also 2-arm study is available. But there is no study between A and C, right? Is there any study between A and C? No. Is there any study between D and B? No. But there is one study like this also. 3-arm study. A, B and C. But in all this case, what will be available? Direct estimates will be available, right? But if I am to make a comparison between these two, no direct estimates. In this case, what you will do? We will go with an indirect estimates. Okay. In traditional network, traditional analysis, meta-analysis, we are always going with what? Direct estimates. So direct estimates we are pulling together and coming out with a full measure. That is what meta-analysis do. But if we want to incorporate any pair which is not been studied directly, so if we want to incorporate, we have to make an estimate which is indirect in nature. So here you see direct estimate here, indirect estimate. Fine. So what is indirect estimate? Indirect estimates or indirect comparison allows us what? To estimate the relative effects of two interventions that have not been compared directly within a trial. If there is no study conducted and if there is no estimate is derived in an RCT or in a control trial, that we can make it through network meta-analysis. Okay, so that is the advantage of what is network meta-analysis. Just here for example. Say simple example I can show. See how much is the difference in time, the same example between Desire, Honda City and CS. 3 drugs, that is 3 drugs. Well, previously direct estimates, right? Now one more is there. What is about Honda City and Zias and Desire? I want to compare. So there is a study. This is one, this is second one, third one. Fine. So there is a study. Direct estimates are available. And let us suppose it's 5 seconds. Fine. There is a difference is 5 seconds. That's a mean difference. Mean difference between these 5 seconds. So there is a study between what about CS and Maruti also. So Desire. That says mean is 10 seconds. But there is no study compared between these two. Simple example, the simplest example in network analysis. Can we estimate this one? Can we estimate the mean difference between these two? Directly not possible. It is an how? Fine. Indirect estimate of this. Fine. Just see how it can be done. Now another example is clinical example. So there is a dietary, dietitian advice on weight reduction. Let us suppose a doctor's advice on weight reduction, and so let us suppose nurse's intervention. 3 types of intervention: doctor, dietitian, and nurse for weight reduction. Fine. So there is a study conducted between these two. Who is more efficacious? We don't know. So fine. Now there is a study between these two also, but there is no study between these two. Fine. So can we make it out? Can we make it out? How? Indirect. So direct estimates are the direct, so indirect estimates. So this is called as indirect estimate. See, I'll give the same thing. I'll give an example. Let's see that. Let us suppose this is a difference of 5. This is a difference of 10. And what is the mean difference between these two? Fine. This is called as an indirect estimate. How to calculate? So indirect estimate that mean difference of B versus C, it is equal to direct estimate between A and C minus direct estimate between A and C. You are subtracting. You are making use of the direct estimate for indirect estimate. Fine. You don't need of anything. But we are generating it. We are estimating through the direct estimate. Fine. So whenever you are talking about systematic review analysis, what are the 2 things important? One is the mean, or what is about the effects measure along with its standard error, right? Variance is required. She was telling the variance of standard, no? So how the variance can be estimated? Indirect variance. Indirect variance is nothing but variance between A and C plus variance between A and B. You combine these 2 variances, you will get a variance there. Fine. We are not studying. We are not got any literature, but we will estimate it from the available direct estimate. Fine. So this is what is called as systematic review. This is what the direct estimate and indirect estimate. Fine. Just see here. Which is more precise? Which is more precise? Direct estimate. So, and indirect estimate is less precise. Why? It is estimate on estimate, right? We are estimating from estimate. Therefore, it is less precise. Okay, that we accept it. Okay, something is better than nothing. Something is better than nothing or no? Yes or no? Yes. Sure? Always? Or nothing is better than nonsense? Now it's finished. Huh? If you are very hungry, hypoglycemic, one chocolate will do, right? Something is better than nothing? Fine. If some patient has come to you with a fever, okay, I am an extreme fever, 1 or 2, I gave to you. Because his one drawer, only this olanzapine is there. You have to know. Olanzapine drug is there. Are you going to give me? Something is better than nothing? In that case, nothing is better than? Which one decides? Which one is true? We cannot generalize it, right? Nothing is universally true other than mathematics. Isn't it? Nothing is true universally other than mathematics. If I am adding 2 plus 3, I will get 5. And anyone is across the world at any point of time, you will get the same answer, right? Fine. So, situation will tell you which one is right. Isn't it? Situation will tell you something is better than nothing or nothing is better than nonsense. In this case, what you are going to do? Something is better than nothing. Why? Because we are not able to conduct a study like that. Therefore, if you are able to make an estimate based on the available, that will be good. Anyway, you cannot conduct the study, right? So, we are going to make use of the data and you are going to get a rough estimate on it. Fine? Now, this is, no, whatever I have so far I told, it's the simplest example, right? 3. I am going to generalize it. So, this is what is called a systematic network meta-analysis. You are able to make it out? Because all this, so these are called nodes. See, these are called the nodes. Okay? All nodes talks about the intervention. And the line connecting between the nodes is called as an edge. Edges. Okay. Therefore, systematic network meta-analysis is a combination of nodes and edges. What this nodes gives? Each node gives the drug. And color gives the what's called a class of drugs. And edges, and see size, no? Different sizes are there, no? What different sizes? Different sizes talks about the what? The studies, extent of studies. So extent of studies. Okay. The diameter shows extent of the studies, extent of the sample size. Larger studies will have the larger circle, smaller will have a smaller. Fine. And what is talked about the edges, width of edges? Width of edges is, width of the edges is proportional to the number of what's called samples. So whenever this type of things you will see that how many drugs are there, and size, it talks about the maximum comparison, and width of the what's called the edges shows the what's called the number of patients. Just see here, this is another meta-analysis, network meta-analysis. Not about simple, I would say that it's a lot of efforts are required. See in this case, you see another example. See, biggest and largest common comparator. Okay, whenever I see them, you will be able to catch it. And you see the width of the edges. See here, this is the largest width. No, therefore it's the highest rank with 1,551 patients in the study. Okay, so this is about what called a network meta-analysis. But there are some assumptions. One is called as you should have a network connectivity, and you should have transitivity, and you should have consistency. So these 3 properties should be there, then only we will be able to make a what's called a network meta-analysis. Fine? Now see, this is the transitivity. Can we make use of this data? Now see, A versus B. A versus C, there is a comparison. But what are the patients? Stage 3 malignancy. But there is a study that A versus B, but stage 1. Similarly, B versus C, stage 1. Can we compare this study? We cannot because patients' characteristics are different, right? A versus B is conducted among stage 3 patients. That cannot be combined with a study with a stage 1 comparison. So this is one of the important properties of this has to be satisfied, right? The other one is what is the consistency. What's the consistency? Consistency means this. Consistency means this. If you are making a direct estimate and indirect estimates on the same thing, that should be same. If you are coming out with an estimate by using direct estimate and if you are coming out with indirect estimates, both should be same. Then only we can go with what's called a network meta-analysis. That is called as a consistency. Okay? And the third one, it is a, sorry, the third one is not fine. Third one is the homogeneity. The study should have the homogeneity. Homogeneity with regards to what's called a population, patient characteristics, drug use, dosage of drug, a type of administration, what's called a mode of administration, everything. The study should have the homogeneity. Homogeneous study can be combined. If the homogeneity is not there, then that cannot be combined. So this is about what's called a network meta-analysis. Then the last one, what's a multivariate meta-analysis? See, please remember, this is the one word largely being used by especially what's called the people who are working in the nursing research. He got confused. Okay, you are extensively used this word multivariate. What's the concept of multivariate? Please remember, multivariate means you have more than one independent variable, not independent, more than one dependent variable. If you have more than one independent variable, you are using the word called as multivariate. No, that's a multiple regression or multiple logistic regression. That is not a multivariate. So multivariate is nothing but it is more than one dependent variable. One example that I will show. See this example. Efficacy and safety of calcimimetics therapy in ESRD patients with a secondary hyperparathyroidism. This is a study. So what is my outcome variable? I have three outcome variables, PTH and serum phosphate and calcium. Three outcome variables. What do you do? If traditional means we will have meta-analysis, one meta-analysis for PTH. We will know what is this? Forest plot, right? And we will be coming to the another meta-analysis. We will put another forest plot and a third one, another one. You have three meta-analysis you have to perform for getting a one answer whether this calcimimetics is efficacious or not. So this is not right. You should not do it because there is a relationship between these three variables. PTH, serum phosphatase and calcium, there is a relationship. If there is a relationship between these two, we cannot that relationship and do an individual meta-analysis. Therefore, what you have to do, you will combine these together and make it as a vector. We will treat it as a one. This is called as a vector algebra. Matrix theory, you will learn the matrix theory. It's a vector algebra. So we will treat it as a vector and this vector will be a one. This is a one variable. One variable is a combination of these three. So we will make a matrix. Okay? And what we will do, we will make a meta-analysis based on this. Not individually. Fine? Why individually is not possible? Because there is a relationship between these. Fine? So this is what is called a multivariate meta-analysis. More than one dependent variable they are combining together. Fine? That is what you will do? One meta-analysis. Based on what? Based on multiple correlated outcomes. Any number. Okay, everything will put as a vector. Okay? So for multiple correlated outcomes, we will combine together and one meta-analysis. This is the variable. And we will come out with a one forest plot. Fine? So this is called as multivariate meta-analysis. So when you will be using multivariate meta-analysis, if we have more than one outcome variable and these outcome variables are related. Okay, then we cannot do in isolation. Fine? So this is about the systematic network meta-analysis. It's just a concept, please remember, this is a high end. Okay, so whatever you are telling me is that one is also a little higher side on top of this. Okay, it is not easy because it is a highly, what is it called, a lot of efforts are required to do that multivariate concept. Okay? Fine? Okay, thank you so much.
No doubts? Now
I request Dr. Sharada Krishna to be informed on Archana Kumar. person attracts great people and knows how to hold them together. Now it's about the great personality. Dr. Riley Porter currently holds the position of Associate Professor Department of OPG Nursing College, AIIMS, Bhopal. She has 21 years of experience that include various cadres of nursing service, education and research. She is spreading her knowledge to the younger generation of nursing as a master trainer of IMCI, IAT, ICMOC and also for several SWAYAM and NPTEL courses. She played a pivotal role in capacity building of midwifery faculty by Indian Nursing Council and Midwifery Leadership Program 2021 by Ministry of Health and Family Welfare in collaboration with World Health Organization India. Dr. Lilly has received numerous prestigious awards, namely the President of India's Gold Medal, the Best Nurse Teacher Award, the Best Nurse Educator Award, Researcher Award, the Best Nurse Educationist Award. She is a trained advocate inspector for Indian Nursing Council, New Delhi, trained peer team assessor for NAC, Government of India. Madam has published 44 research articles in national and international journals, published 2 books, reviewed 3 books and chapter contribution for 2 books. Her citation in Google Scholar is 122, HNX is 5 and ITEL index is 4 and reads is 60,000. Dr. Lilly has been invited as a resource person for numerous national and international level conferences and participated in around 115 conferences. Now, I extend a congenial welcome to Dr. Lilly Porter for presentation. We welcome you, ma'am.
Thank you. Thank you. Am I audible?
Yes, you are audible, Lily. This is Dr. Shada here from me and from our team. How are you?
Yes, thank you so much. I'm really very delighted to see Shada ma'am. Your smile, your amazing personality. Really, I miss everything. First of all, I would like to congratulate the organizer for arranging such a nice conference. It really gives a very positive vibe on me because I know that the leadership of Shada ma'am has been perfect in getting everything done by her team of faculty members. So, really ma'am, it is very nice to be here and be invited and share this platform of eminent speakers and bringing my thoughts to the participants. Yes, even I could extend that the participants are very energetic and enthusiastic. I could see their response, their loudness in the voice, their positiveness, and I'm very happy to be part of this. And I want to see the participants once. Can you please turn the camera to them? Hello everyone. Say hello to Ma. Yeah, very nice to see you all. As I share my slides, I want you all to be connected with me. I know the participants are UG students, PG students, nursing officers, faculty members. I will just try to connect through my slides, be with you, and you please be with me. Okay? So I'll now share my slide. I'll not be able to see you all now. Yes, ma'am. Share the screen. Shall I?
Yes, ma'am.
You please enable me to share my screen. It is showing disabled. Oh, I can see so many smiling faces, beautiful faces. Is it done? Enabling is done?
No, ma'am. Please
For
wait,
me
ma'am.
to share.
We are making, ma'am.
Okay. Okay. The participants, I think you are now overloaded with information, right? Since morning, listening so many big terminology, big talks, big thoughts, isn't it? Overloaded? Yes or no? Say something. No? I can't hear you.
Ma'am, we made you as co-host, ma'am. Now you can share the...
Okay. Okay. Now is it visible?
Yes, ma'am, it is visible, ma'am.
No, if I do the, now this is slideshow, you can see?
Yes, ma'am, we can see, ma'am.
Yes, and I can see the participants also a bit. Thank you so much. So I can see their reactions while going. Okay, so my topic is grading of recommendations, assessment, development, and evaluation. Very, very comprehensive thing, what we are discussing since morning. Now I would like to ask the participants, you tell me, in the previous class, sir was asking you what is the difference between a narrative review and a systematic review. Just a very funny example. If you, let's go for shopping and you want to buy a regular dress for daily wear, and if you want to buy a very, very expensive dress for party or for your wedding. Is there any difference between these two shopping process? Yes or no? I can't hear you. Are you all answering?
Please answer,
Can
ma'am.
you? Is there any difference between these two process of shopping? You are trying to get a very, very expensive things, or you are going to buy a very regular thing for your daily purpose. Is there any difference? Yes. Yes, of course there is a difference. And that's what, when we see the level of evidence pyramid, what we have seen, the randomized controlled trials are on a very high level of evidence, and above that randomized controlled trials, we have systematic review and meta-analysis. That means if we want to really create something very qualitative, we have to get the things also in a very qualitative way. So whenever we do something, the quality does matter. And during your inaugural key address also, madam has emphasized that quality, best possible quality care is our motto. Best possible quality patient care is our motto for the nursing care. Hence, we should always consider the quality. So the grade is something like something other than, not like something other than the quality assessment. Now in my slide, we can see, if I think what is the best complementary method to recommend and teach my students for managing labor pain. There are so many complementary therapies available, but I want to teach the best one to my students, and also I want to recommend for my patients whom I am caring for. What I will do, I'll start browsing what are the things available in the all the possible sources. So what I can see here, there are so many things available, and also I have mentioned the number of studies available, what I could found during my browsing or the searching. I could see acupressure is there, I could see massage is there, I could see meditation is there, I could see physical therapy is there, and I could also see hot and cold therapy is there. And depending on the number of quality studies or the good, like experimental studies, qualitative studies, quasi-experimental studies, observational studies, depending on those, what I can see, okay, the highest number of experimental studies are done in the case of acupressure, and I also think, I'm sure 60% that it is the best complementary method to reduce the labor pain. I have thought of. Now what? Now think, is it high time now to recommend and implement a strategy to reduce the labor pain? To get these ideas, let us review the available systematic reviews. Now, in that acupressure, we have seen there are many experimental studies available, but where those all studies were qualitative, and their data, whatever the outcome data they have given, is it really valid? Is it really worth to get me these idea that yes, acupressure is the best one to recommend. Recommend means it has to be brought into the clinical care practice, so that it creates some benefits to the patients. Okay. So when we want to recommend something, what I need to do? I need strong evidence. How can I be so sure and trust the findings in the review, especially when many systematic reviews on the same topics are available? Okay, so since morning we are seeing systematic review means you have to go something very systematically. You have to search all possible resources, even the unpublished, not only online, even offline, the grey literature also you have to search. All possible researches you have to get together under one roof and then try to find out what is the best evidence out of those, and from those best evidence you have to generate some better evidence. Okay, so why do we bother about grading the evidence? Why it is needed? Because the people will draw conclusion based on what? The quality and the strength of recommendations. If somebody said me that, okay, you want to buy a party wear, maybe the out of this Myntra and Flipkart and Amazon and so on, they said the recommendations, yes, Myntra is good. Okay, this is one recommendation. And the quality of evidence, that means when I try to buy something for Myntra, I have to see the quality of the material, the price, the comfortness, everything, the color, what suits me. All right. So quality of those material, what I am taking, and the strength of recommendations, with what confidence I am saying, yes, you can take this article, the subject. Okay. So it is a systematic and explicit approach which facilitates the critical appraisal of the studies. Okay, so we have to follow a very, very systematic approach that we, without any bias, see everything. You give your interpretations, you give your consideration, and then draw your conclusion. So facilitates a very, very critical appraisal without any bias and protect against error. Okay, so if we go systematic way, if we follow all the steps in a very proper way, we will not do the error. The chances of happening error is very less. Resolve disagreements. And that also we have listened that we need many reviewer to see a article. So one or two reviewer will study, the author will study, there will be some agreement, disagreement, then the third reviewer or third author will come, and then those all disagreements will be resolved. And then communicate information. Yes, of course, we will communicate the information to the people, to the policy maker, to the clinician. Yes, this is our observation. Now you can build up your recommendation. Okay, so that is why the grade is. The flow of discussion would be like today: introduction, advantages and purpose, how to assess the quality, and how to develop the strength of recommendations. So grading is nothing. I have already said that it is a systematic and explicit approach to make judgment of quality of evidence and the strength of recommendation. What I am making a judgment of the quality, but I am confident that yes, I have done something right. Okay, so the grade approach considered all factors to determine how confident we are in the result. That means when I said quality of evidence, nobody could question me because I was so explicit, I was so systematic, I was so transparent. There is no question I have done right or wrong. Yes, I am 100% confident. The evidence for each outcome in the review separately and the magnitude also effect also can be determined. The grade approach also ensured the systematic process, transparency. I have already said. And then why we need this? Because it helps to specify the healthcare questions. It choose and rate the outcome, and it helps in making recommendations. It also guides the practice and the policy that I have already discussed. Okay. Now this graph, I hope it is visible to the last row. This is a very systematic view of the grade approach for synthesizing evidence and developing recommendations. Here we can see there are two boxes, the upper and the lower boxes, right? And the panel, you can see they are sitting in the lower boxes, right? So when we start doing the systematic review, see first the PICO. You can see the PICO, P-I-C-O, and the left end where we have to formulate the questions, what we want to search. what is our population, what is our intervention, what is our control, and what is our outcome. So everything has to be decided. As sir said previously, that means when you do something systematically, your questions also has to be very, very clear. This is the PICO format. Okay. And apart from this PICO, nowadays the T and S is also added. T means the timing and S means the setting. Though it does not have that significant impression on that, but still people may do this T and S. Okay. So apart from after this PICO, what we have to determine the outcome, select. Okay. Outcome, everywhere you have to choose the outcome. Then we have to rate the importance of the outcome. Is it having a critical implications on the patients, or it is a important implications for the patient, or it is not important implications for the patient. If it is not very important for the patients, we can delete those, and whatever is very, very critical to understand for the patient care and what is very important for the patient care, we will choose those outcome criteria. Based on those outcome criteria, I will now search the evidences available. Okay. See, the next you can see 1, 2, 3, 4 researches or the articles, that is outcomes across the studies. So those outcomes, whatever, for example, 2, 3 outcomes I had in my hand, and those 2, 3 outcomes in wherever articles are there, I am searching. Now after that, I think Madam Sajila has told you about, you have to prepare a general characteristics of the table. On all those articles, what are the salient features, the essential characteristics? Like she has mentioned that Cochrane has got 85 items to select from those articles. JBI has got maybe 18-20. You can create, apart from all those, you can create your own general characteristics for a better understanding. Okay, now Grade Pro I have written here. So this is a software where if you incorporate everything, the studies has been put in software. They prepare the table, general characteristics of all the reviews or the articles available or the evidences. They will create the table and give you. Okay, so depending on those general characteristics, we have to grade each article. Is it of high quality? Is it of low quality or very low quality? So here we can see there are 4 quality: high, moderate, low and very low. Now this high, moderate, low and very low depends on the methodological or the study design of the study. Okay, study design. That means the RCT is on the top level, and the observational studies, cohort, case control and etc., they are on the lower level. So I can understand when the studies are RCTs, they are obviously high level or moderate level depending on the bias or etc., and the observational studies are at the low level. After that, what we have to again critically appraise and think that the high study also can be lowered down depending on the risk or something, and the observational studies also can be graded up depending on their effect. So I have written here, see, randomization raises the initial quality, that is RCT is high and observational are low, but grade can be down and grade can be up. So grade can be down, why? If there is risk of bias, inconsistency, indirectness, imprecision, publication bias. Or when the grade can be up because of the large effect and dose response and opposing bias, confounder variable. Matlab, you do not have much confounding variables in the study. Okay. Now, this is all about the systematic review authors. They have done so many things and they have given this evidence to the panel of experts. Okay. Now, these panel of experts will sit together for making a recommendation to the clinician, to the patients, to the general public, to the policy maker, to the decision maker. Now, they will think, again review all this system, what we have undergone, is it correct or wrong, and they will draw their some critical thinking and everything, and they will grade the recommendations. Okay, that means whatever evidence I have generated through the systematic review, now this panel of experts will translate these evidences into recommendations for the people. So these recommendations could be against, could be for, or something. They will put their own discussions and they will develop the guidelines, and the recommendations will be available for the general public. I hope this is I made it clear to all the group, the participants. I hope. I think you are saying yes. Okay. So now, what do we understand the quality of evidence? For authors like systematic review, you are attending this workshop because I think we are expecting our next systematic review would be generated from your group. Okay, so this, you are now the author of systematic review, prospective author of systematic review. So for you it is, the quality of evidence reflects the extent to which I am confident, the author is confident that an estimate of the effect is correct. Okay, and for the guideline or the panel of members, the quality of evidence reflects the extent which our confidence in an estimate of the effect is adequate to support a particular recommendations. Okay, so quality of evidence for author of systematic review is the confidence of the about the effect. Now for the panel member, it is also the confidence for the recommendation. We have said about the confidence regarding the evidence. They are saying confidence about the recommendation. So now how do we rate the quality of evidence? There are 4 grades already I discussed: high, moderate, low, very low. High means we are very confident, there is no problem, everything is perfect, I am highly confident, this study available or this study available by your Maheshwari ma'am is perfect, there everything, the best evidence. Okay. Now the moderate. Moderately confident means I am okay, maybe 80 or 85% or 95% maybe I am confident, but there is something, but possibility to be substantially different. So I will put some moderate, and low, and then very low, the same way the explanation is. Okay. So already I said, if the study design is RCTs, it is always come under the high and moderate level, and when it comes the observational studies and the case report and expert opinion modeling, they come in the low and the very low category. Okay. Now this high and moderate level, the way the RCTs are being graded in the high and moderate level, the lower, we can lower the quality if there is risk of bias. See, it is mentioned in the red that if there is a risk of bias, if there is inconsistency, indirectness, imprecision and publication bias. If there is nothing, it is of high quality. The observational studies, who is rated as low and very low, they also may be shifted to the higher quality depending on the, see the last column, if the effect is very large, if there is dose response, or if there is direction of the residual confounding variable and the bias. So these are my determinants of the quality of evidence in RCTs. Okay, first of all, we will see the risk of bias. Risk of bias again have 5 components. Okay, see, RCTs, general perception is what? The study is done in a randomized way. The subjects are chosen on a randomized way, following some randomized table, computerized sequence, sealed envelope, etc. There are so many methods available. Okay, and the participants are also allocated to the exposure and non-exposure group also in a randomized way. But we are here, we have to read everything very carefully and see if there is any lack of allocation concealment. That means it is lowering the quality of that RCT. Now, lack of blinding. Blinding means neither the researcher, neither the participant, neither the data collector, neither the data analyzer know about who are the participant in which group, who are receiving what intervention, nothing. That is blinding. But if there is any lack of blinding in the RCT, that means it is also lowering the quality of the RCT. Next is what? Incomplete accounting of the patients and outcome events, the attrition. Okay, that means we have enrolled 100 patients in the RCT, but the number of participants and the number of events are not matched. That means 100 people are not followed up exactly for the adequate number of events. Maybe we are left up with only 60 patients. No, this is also lowering the quality. Up to 5 to 20% it is okay. At least 80% participants should have that adequate number of events. All right. So attrition rate also should be very less. If we see that attrition rate is very high, again we have to lowering the quality. Now selective outcome reporting, that means the publication bias. If we have some negative report or something, we don't want to publish our article. And other limitations like stopping the trial early. I have to give the drug for 5 days, but I have given for 3 days and then concluded. No. Okay. And then use of an unvalidated outcome measure. Unvalidated means what? When the data collection tool or the variables are subjective. No. We have to always depend on a empirical data, measurable data, so that it gives some like if we say something, patient's perception is very subjective. Nurse perception, it is very subjective. We cannot draw a very big conclusion depending on our subjective data. And then carryover effect in a crossover trial. Crossover means I am exposed to drug A also, I am exposed to drug B also. So I may have effect of drug A and drug B all together. So I have some carryover effect. So I cannot decide appropriately which drug is more effective. And then recruitment bias in the cluster trials. This is already we have discussed about this. Okay. If you see the risk of bias graph, it shows like this. Okay. Here you can see one left side graph and the right side graph. In the left side graph, you can see there are various studies is been listed. Okay, like 2014 study, 2017 study, 2013. This is the individual studies are being listed. And on the top of that, the selection bias, the blinding by performance bias, and the publication bias, the attrition bias, and the other bias. Okay, so depending on that table, the general characteristics table, we have to read so thoroughly and decide. See there you can see some yellow color query and then red color negative and green color plus. Okay, so green already I think in the last class or the previous classes it has been discussed. If it is green, that means low risk of bias. If it is unclear, I cannot decide. It is undetermined. I can't say no. I can't say yes, but undetermined. And if there is red, that means it is high risk of bias. Okay, so each individual studies are being read thoroughly and then decided, and it has been presented in this format. In the right side, we can see it is the cumulative of all the study and presented in this way, and the percentage is also mentioned in the lowest horizontal line. Okay, so this is the overall systematic reviews risk of bias depending on the each individual studies I have included in the systematic review. Now let's take an example. See, acupressure and acupuncture for pain management during labor. We have seen these 3 studies. Okay, and after reading these 3 studies, every study is been marked in red, yellow, green, everything. Okay, now take the first example. Okay, so we have marked green color in the first 2 things. And the study also mentioned that women in labor who requested pain relief were asked to take part. That means the consent has been taken. If they consented, they were randomized to receive acupuncture, transcutaneous in electronic nerve stimulation and traditional analgesics. Ratio उन्होंने क्या किया? 2:1:1. That means they have made some block. Okay, by a computer controlled voice response system. That means the randomization is so perfect that computer controlled voice response system has said where you will go and what you will receive. Researcher does not have anything to do here. Okay, now 3 and 4, blinding. Here the study was performed as a randomized control study without blinding. Okay, so they have mentioned that blinding was not done. Now for the 5th number, data were missing from 8% with the proper reason stated, and we know that 5 to 20% is considerable. So it is okay, no problem. We have given also low risk of bias. Now number 7, the study protocol is not available, but the study reports the expected outcome. This has also been discussed in the previous classes. Sometimes we have, not every time we have to register it is in Prospero, but sometimes what happened, no, we have not registered, but we have conducted a systematic review, acceptable. Okay, so this is undetermined. And the seventh, the other bias. After reading the whole thing, this is the author or the reviewer recommendations or the considerations that this study appears free from the other biases. So that also we have given the positive remark, low risk of bias. Okay. So now from the risk of bias to grade. Okay. It can be downgraded also, or it can be downgraded by 1 level, downgraded by 2 level. If there is lack of blinding, incomplete outcome data or selective reporting, we can downgrade by 1 level. Or when there is very serious risk of bias, such as multiple significant flaw in the study design, strong suspicion of the selective reporting outcome, severe inconsistency in the result across the study, then we will downgrade by 2. Now, in the same example, we have seen selection was appropriate, but the blinding was not done. Selection allocation was appropriate, but the blinding was not done. So, would you downgrade the risk of bias? The answer should be yes, because there are serious limitations downgrade by 1 as there were no blinding. Okay. Now, risk of bias for the observational studies. Okay, so these risk of bias, whatever we are discussing, that is for the criteria, what we have said, 5 criteria, that was for the RCTs. Now we would like to see the risk of bias for the observational studies. When column 1, you can see the failure to develop and apply appropriate eligibility criteria for the control and for the experimental group. The eligibility, I mean the exclusion criteria and the inclusion criteria has to be very, very perfect, and we have to be very, very crucial in understanding. Okay, so because after, if we do not choose appropriately, the criteria are not laid down appropriately, we may have a chance for underestimating or the overestimating. Okay. Second, we can see flawed measurement of both exposure and the outcome. The difference in the measurement in the experimental group and in the control group. Now, failure to adequately control confounding. The confounding variables are not appropriately controlled. Like for experimental group, maybe all the young generation people are being taken in the experimental group, and control, all the old age people are taken in the control group. So how can the age is not, confounding variable is age here, which is not been adequately distributed in the control and experimental group. So we can have again the bias and incomplete or inadequate short follow-up. That already we have said. Now, the second point is inconsistency of the result. Inconsistent. From the term itself, we can understand the result. If somebody has said acupressure is good, whatever, wherever the study is being done, they also should be, the result should be consistent with the other result. Wherever it is conducted, however it is conducted, the result should be consistent with each other. They should be coherent with each other. Okay. And consistency, imprecision, everything we have to understand from the forest plot, right? Forest plot, it is already discussed. We'll just briefly review. In the forest plot, we have one vertical line. This is the line of null effect. We have the horizontal line. The left side is towards the favoring the experiment, and right side it is favors the control. Exposure, non-exposure. Left side is exposure, right side is non-exposure. Okay, and the the horizontal line we can see here with a box square in between. This horizontal line delineates the confidence interval. Okay, the box, the square, it is the study's point estimate and the size. How much the bigger the sample size, then bigger the box. Okay, and then any study line which crosses the line of null effect does not illustrate a statistically significant result. I said already that the vertical line is the line of null effect. So all the study who is having some significant result, they should fall in the left side of the line. If it is crossing the line or coming to the right side of the line, that means it is favoring the control. It is not favoring the intervention. Okay. Now see here, the individual lines, it is there are 1, 2, 3, 4, 5 lines, and there is one down the diamond. Okay. So individual studies are combined together and averaged in the form of this diamond. The horizontal points of the diamond are the limits of the horizontal. The diamond has got 4 corners, horizontal 2 corners, and the vertical 2 corners. Okay. So the horizontal points are the confidence interval. If it is broader, that means the confidence interval between the studies were very broad. They are not heterogeneous, they are not homogeneous. That is why they are different from each other. And the vertical points are the size of the sample. Okay. So this is the first, this is the way the forest plot is depicted. In the left side, we have all the study listed, maybe 10, maybe 20, maybe 30, whatever the study you have got of good quality you have written here. Okay. And then you see we have treatment column, we have control column. In treatment, yes, the effect is yes and no. Total sample size is 109, and out of that 109, the effect is got on 4 samples. Okay. And the same way, the total sample size was 128 and effect was seen in 11 samples. Okay. So like that it has been distributed, and all the studies are been rated, that confidence interval and the effect size, it is all there. And below we have the graph, I mean the diamond. It is already I have told. Below that you see there is one I-square. Okay. I-square is 92 point. You see the heterogeneity, chi-square equal to 0.31 and I-square equal to 92.22%. This I-square determines the heterogeneity of the across the studies. Okay, this is one statistical test. So I'll show you the, yes, here. So inconsistency refers to the unexplained heterogeneity, right? The criteria vary, large variation in the effect, confidence interval do not overlap, and statistical test for heterogeneity is P always has to be less than 0.05. I is very large. That means what? The heterogeneity is very high. Okay. So low up to 40%, it is accepted. Very low, moderate is 40 to 60%, and high is more than 60%. So here we can see 2 examples. Okay. In first example, we see the I-square is 0. And see the forest plot. See the forest plot. The all studies are correlating at the same line, the line of no effect. Confidence interval is overlapping. They are overlapping to each other. The horizontal lines are overlapping to each other. P is more than 0.05. So effect size is on the left. The diamond is on the left to the effect line of null effect. Okay. But whereas you see the second example, the I-square is 90%. Confidence interval is not overlapping. Okay. All the lines are separate from each other. Somebody is on the line, somebody is right to the line, somebody is left to the line. Okay. And P is less than 0.05. Effect size is on both the sides. Clear? So example second has inconsistency in the result and heterogeneity is present. So we will downgrade this evidence. Okay. So how to downgrade inconsistency? Downgrade by 1 level if there is substantial variability, or downgrade by 2 level if there is very high variability. Third point is indirectness. Indirectness means it may happen, I have said, that if the population is not chosen properly. The sample, my target population is something different, and the samples I have chosen is something different. So that is one in the differences in the population. Applicability is not there. Difference in the intervention. I have given something to this group, I have given something to the other group. The intervention is not appropriate to all the groups. Now, difference in the outcome measure, that means the surrogate outcome. Surrogate outcome means it is the substitute outcome. Okay. Like example, for diabetes mellitus, the very, very crucial outcomes are what? Like we can say the end point of diabetes mellitus symptoms. how the symptoms are controlled, the hospital admission status, and the complications, how much complications the patient has arrived. But apart from everything, these are very crucial information, but we are only assessing what? The blood sugar or the HbA1c. So these are the surrogate outcome. All right. Now, indirect comparison. Yes, the comparison are not appropriate between the two groups. So, indirectness in the evidence, it depends on the patient's like cystic fibrosis versus end-stage cystic fibrosis. Okay, because the two groups are completely different. Interventions. CRC screening, that is flex significance versus colonoscopy. This is also different. Comparator, there are difference in the dose it is administered to the both the groups, and outcome also not properly been chosen. So indirectness is evaluated using the PICO format. What I have decided in the first level, I have to be consistent with that. Now again, you can downgrade depending on this seriousness of the indirectness. If it is very important difference, serious indirectness, and very large or impossible to determine the differences, then very serious. So accordingly, we have to downgrade it. Next is the imprecision. This term also, I think it has been discussed several times. Imprecision. We are not precise. Okay. So 95% confidence interval. It the lower range, the lower range and the upper limit, the lower limit and the upper limit. We should not be very far away from the lower and the upper limit. Okay. So if we are very far, that means we are not precise. So imprecision, the results are imprecise when studies include relatively few patients and few events. The sample size is less and the number of events we are giving to them are also very less. Thus have a wide confidence interval around the estimate of the effect. Okay, so in this case, one may judge the quality of the evidence lower than it otherwise would be considered because of the resulting uncertainty about the result. Okay, now while assessing the imprecision, we should take two things in the mind. Number of people analyzed. Something we know is called as optimum information size. That is why now the UG and PG students are been always told that you have to select the sample using some criteria. Okay, we do power analysis, we do various things available, okay, in the software, so that we can choose the appropriate sample size, that is the optimum information size, to detect the precise estimate of the effect. You have to choose the sample size very precise way. Now confidence interval around the effect estimate. Does the confidence interval, that is the range of the values that affect the estimate, might take place. Last is the publication bias. Publication bias, that means these are the various publication bias. Preliminary and pilot studies we have published because the sample size was very less. The studies may not be so effective, but we have published. Okay. Then report completion. Report completion means we have not, whatever the exact report we have got, we are not completely giving to the publisher. Journal selection. If I got any negative result of my study, I will not publish it in a high index journal. I'll publish in peer reviewed and the local journal in not other than the English language. Then it is not visible to everyone. Editorial consideration and the peer review. Sometimes the editorial board of the journal also see the negative impressions, the negative result, and they think, okay, it does not going to have any effect, so let not get peer reviewed. Some peer review also may think it is having negative impact, so it is reject for the publication. Okay. Now the author revision and the resubmission. Sometimes the peer review or the editorial board submit some revision or the revision. They give some revision and then they ask us to resubmission. But we think, okay, no problem. Let's keep for some more time and then we will see later on sometimes. Okay. And then report publication. So the flannel pots where we can see the symmetrical public, that means there is no publication bias. The flannel pot is inverted funnel in the left side and the right side it is not inverted. So there is this asymmetrical flannel plot. So there is a publication bias or it is a query. So reasons to upgrade the evidence. Now, till now, we have discussed about reasons to lower the grade of evidence. Okay, there were 5 reasons: risk of bias, indirectness, imprecision, inconsistency, and the publication bias. Now, the last column, what I have shown you previously, there were 3 reasons to upgrade the label. Okay, the upgrade the label, first one, the effect size. If the effect size is very high, the magnitude of the effect, okay, the effect is very rapid, the effect is consistent across the population or across the studies, the previous trajectory of the disease is reversed. If these things are being identified, that means we can upgrade the label of the observational studies. Now, the dose response. Dose response means the presence of a dose response gradient, means the relationship between the dose given and the response obtained. So from that also we can find something, we can consider this to upgrade the label of the observational studies. And effect of all plausible confounding factor. Okay, because it reduced the effect seen and it increased the effect if no effect was observed. Because if we are not appropriately eliminating or not appropriately controlling all the confounding variables, it may overestimate or it may lowering the estimate of the effect. So this is a tabular representation. We can see the risk of bias. We have to think about across the studies, and then we have to draw the interpretation, and then we have to consider and ultimately define the downgrade or upgrade. Okay. So if the risk of bias is low, then what happened across the studies? Most informations are consistent and free from risk of bias. Okay, no problem. Interpretation, what? Possible bias unlikely to seriously alter the result. So our consideration is no apparent limitations. No limitations means do not downgrade. It is of the high quality. If it is unclear risk of bias, then we have to think twice. Okay. Most information is from the studies at low or unclear risk of bias. So plausible bias that raises some doubt within us. And if this doubt, there is potential limitations are unlikely to lower the confidence. If this some doubt is very high in my mind, that means it will very low the confidence. Or if it is some doubt, okay, then it is not very lowering my confidence. So depending on that seriousness, no serious limitations, do not downgrade, or it is very serious limitations, then downgrade by 1 level. And when the risk of bias is very high, again depending on the proportion of the information from the studies of high risk of bias is sufficient to affect the interpretation of the result. On those depending, again downgrade 1 level and downgrade 2 level. See, this is the same graphical representation. We can see randomized control trial are high and lower if risk of bias -1 very serious, -2 -1 serious, -2 very serious, inconsistency -1 serious, -2 very serious, like this way. Okay, and higher if the effect is very large, those response is present and all confounding variables are controlled, then 1+ and like this way. Okay. So depending on this, see the last quality of the body of the evidence, high if it is 4+, moderate if it is 3+, low if it is 2+, very low if it is 1+. I hope I am getting clear to the participants and I am not getting them bored, right? This is the same things is presented in a tabular format. Even all the studies have been mentioned, RCT, RCT, RCT. And we have seen the limitations, inconsistency, indirectness, and depending on the quality, the last column is the quality is been determined. Okay. Now, quality of evidence is determined. Now, what I have to do, I have to, from the evidences, we have to translate these evidences into the recommendations. Okay, so going from grade to the recommendations. The strength of recommendation. The strength of recommendation reflects the extent to which we can, across the range of patients from whom the recommendations are intended, be confident that desirable effects of a management strategy outweigh the undesirable effects. Okay, so whatever the evidences is generated, for whom I have generated, for example, pediatric population, and evidence I have got that, okay, this is very, very effective for the pediatric population. Then that means the desirable effect is very high than the undesirable effect, and I am confident now in recommending this drug for the pediatric population. These are the determinants again, that quality of the evidence already we have discussed, balance between the desirable and the undesirable effect, the outcome we have to see. The outcome I have said already, critical outcome, important outcome, no outcome. So how critical it is, how much it is favoring benefit, how much it is harm. We have to keep a balance between these two. And then values and preferences, what the people want. The people's preferences, the doctor's preferences. Okay, so we have to also visualize those things. And then cost also, resource allocation. So out of when we are recommending, when the policy maker, the panelists are deciding about the recommendation, they have to think about all these aspects. Okay, this is again one pictorial representation. See, in the left side we can see problem identified, PICO, questions formulated, search for evidence, and then they have all given the evidence. It is all represented, and then they have recommended. After these recommendations, the format, the clinical guidelines is been published, and it has been made general to the public. So implications of a strong or category A recommendation. If the panelists say, yes, I am strongly recommending this evidence. So it is what it meant for the patients, what it meant for the clinician, what it meant for the policymaker. The patients, that means the most people in this situation would want to recommend the course of action, and only a very small proportion would not prefer this. Clinician, most patients should receive this recommended course. Policymaker, the recommendation can be adapted as a policy in the most situation. Adapt and adopt. These are two things. Okay. Category A means they should adapt it, they should accept it. Okay. Now, category B recommendation means the majority of the people in this situation would want to be recommended the course of action, but many would not. Clinician, be more prepared to help patients to make a decision that is consistent with their own values, their own age, and shared decision making. You may take, you may not take. Policymaker, there is a need for substantial debate and involvement of the stakeholder. We need some more information to make into the recommendation. This is adopting. They're adopting something very good. Okay. So these are the key benefits of the grade in systematic review for the healthcare professionals or the consumers. It relies on the standardized quality of evidence, better understand the effect measure, likely to increase the SR value, that means the systematic review value and use, better information improves shared decision making. For the guideline, authors utilize full grade evidence profile, and for the policymaker, it informs the process of determining net benefit, which may include resource use considerations, value, and the preferences. What I have seen in the first slide, what are the steps? Okay, you have to identify studies, you have to identify outcome, then generate the estimated effect, and then rate the quality of evidence, rate the overall grade, and decide on the direction of your strength of recommendations, strong recommendations, weak recommendations, or I am discrete, I cannot decide. So I have to do something more. We have to get some more information about this. So this is the way. Okay, so there are various software that help in the quality assessment. Grade Pro, I have already told you, and Cochrane Risk of Bias tool, ROB2, this has also been discussed in the previous classes, and the REBMAN for writing the review. Okay, so systematic reviews enhanced by the grade framework provide a transparent and structured approach to evaluating evidence, ensuring that clinical recommendations are both trustworthy and actionable. So after all, the ultimate goal of all research is not objectivity but truth. Thank you so much everyone for your patience listening. Thank you.
Thank you, ma'am, for your magnificent presentation.
Thank you. Any inputs from the participants or any inputs from the faculty member who are present? Anything to be added? Any suggestions?
Dear delegates, is there any queries or suggestions? No queries.
If you doesn't have any query, at least say something. We would like to hear you. Say something. Did you understand something of this topic? The quality of checking the quality of evidence.
Yes, ma'am.
Yes.
Yes, ma'am.
Okay. Thank you so much.
Thank you, ma'am.
I can now stop sharing.
Yes, ma'am, you can.
Yeah.
Now we are moving to the next session. Due to some medical emergency, Dr. Sarman Singh sir could not join with us today.
Oh.
So sir has shared his PPT, and I request Mrs. Maheshwari, Assistant Professor, Vinaya Mission College of Nursing, to present on risk of bias assessment and publications bias.
Okay. So shall I leave now?
Yes, ma'am, you can leave. Thank you, ma'am.
Okay, thank you so much. And again, I pay my regards to Sharda ma'am, even Professor Sarman Singh, because he was our director when we joined AIMS Bhopal, and to all the entire team of organizers, and all the best. And participants, there is no end for learning. Please keep learning day by day from everywhere, for anyone. From anyone and everywhere you can just learn. Take the things, and then we have to develop the competence and take our nursing profession to the higher level. Thank you so much.
Thank you.
Bye. Bye bye.
Bye, ma'am.
Very good afternoon. On behalf of Dr. Sharman Singh sir, Director of Medical Research, AFMCH, I'm going to present his slide. So sir's content is about risk of bias assessment and publication bias. In that, what is bias? So it is a systematic error. It is a deviation from the truth in results as well as in the inference. Maybe it may be of trivial or substantial. This can lead to underestimation of effect or overestimation of effect. So next is about a significance of assessing bias in systematic review. So here, differences in risk of bias are related to variation in the results of studies included in a systematic review. All results may be consistent among themselves, but all studies could be flawed due to bias. So what are the sources of bias? Here the selection bias, performance bias, attrition bias, detection and reporting bias. First about selection bias. It is a systematic difference in baseline characteristic between two groups. For example, selection of participants with differential age characteristic. Next is about the performance bias. This is about a systematic difference in attention and treatment which is given to both the intervention as well as non-intervention group. For example, the participants who are aware that they are not receiving any treatment and any forms of care. So this is about the performance bias. This leads with our intervention strategy. Next is the attrition bias. So this is about a systematic difference in loss to follow-up. So some patients will get withdrawn from the treatment which has been given to the patient, and by this the bias will take place. That is the attrition bias. This will take place between two groups. Next is the detection bias. It is a systematic difference in between two groups, how the outcomes are determined. For example, the researcher is aware of intervention or the research which has been carried out, the outcomes may be assessed with the bias. So this is about a detection bias. The last one is about the reporting bias. So this is about the reported and unreported findings of the systematic findings what we used to get. For example, only the publishing favorable outcomes leaving readers with incomplete and skewed understanding of the result. So this is about a reporting bias. Next, about how to assess the risk of bias. We have around 3 categories to assess it. One is domain-based assessment, and this has been done, which has been taught to you in previous classes. Another one is impossible to know the true risk of bias. The third one is involved subjectivity. For example, lack of binding of participants may get affected here. So these are the 3 ways in assessing the risk of bias. Next is domains for assessing a risk of bias. We have certain domains. One is the random sequence generation. Other one is allocation concealment. Next is about blinding of participants and personnel, and outcome assessment, incomplete outcome data, selective outcome reporting, and other source of bias. So this is all about the flowchart which has been used in all the criteria of domains, that is selection, performance, detection, attrition, and reporting. How to assess the risk of bias? One is by reviewing the author's judgment in the article, other way by researching for clues to the bias, and last is by looking for missing information. Throughout the study, we have to see for any of the information which is getting missed, and that should be carried out while doing the intervention. Next, random sequence generation. The random assignment of people into the intervention and control group. This avoids the selection bias as well as the confounders, both the known and unknown group. Next is about the fundamental questions which have been asked was the allocation sequence adequately generated or not? Whether the methods used to generate the allocation sequence were taught to them or not. This is the commonest fundamental questions to be asked to rule out the random sequence generation. So next is about the judgment. Here we have to see for the low risk of bias if allocation done by referring to the random number table using a computer random numbers generator used, or coin tossing, shuffling cards or envelopes, or throwing the dice. By this we can able to have a low risk of bias in allocation. Next, what is the high risk of bias in the sense? It is a sequence generated by odd or even date of birth, date of visit, etc. Allocation by judgment of clinician and participant, and allocation based on results of laboratory test. By this we can able to have a high risk of bias. Then allocation of concealment. So concealing allocation sequence from those assigning participants to intervention group until the moment of assignment. This ensures the patient to envelop into a study without knowing which group they will be assigned to, and if the researchers know the next participants will be allocated to the intervention, he or she may try to help a certain patients whom he thinks will benefit from one intervention. So allocation concealments, the fundamental questions, so these are the questions will be asked. And next is about the low risk of bias and high risk as well as then. So this is about the incomplete outcome data. So unavailability of questions outcome data from review, that is attribution and exclusion. This can lead to attribution bias. High proportion of missing outcomes or a large difference in proportion between two groups is the main cause for concern over bias. Next is selective outcome reporting. So this statistically significant result more likely to be reported as a planned and in detail one. This can lead to reporting bias that is difficult to assess possible ways. One is by comparing method to result to look out for. Other one is referring to study protocol or trial register. So next is about tool for assessment. Here the risk for bias table, which categories of certain domains, that is a low risk, high risk and the unclear one. And support for judgment, that is a direct quotes from articles. Additional comments with the rationale should be given, and one for each study should be reviewed. And overall conclusion, so the bias can lead to overestimation or underestimation of the result, and bias can be assessed for 7 domains, and judgment should be based for assessing risk by searching for clues and reviewing author's discussion, and caution should be applied in judgment. So this is about bias and its selection.
Thank you, Mrs. Maheshwari, for presenting on behalf of Dr. Sarman Singh. Now, let's move for the last presentation of today's seminar. Nursing is not for everyone. It takes a very strong, intelligent and compassionate person to maintain the health and well-being of the planet. Here is a gist of a person who is a stalwart in nursing. Dr. Jasneet Kaur obtained her BSc Nursing from Baba Farid University of Health Sciences, Punjab, PGDHA and MSc Nursing from Rajiv Gandhi University of Health Sciences, Bangalore, and completed PhD in Bharati Vidyapeeth University. In addition to this, Dr. Kaur accomplished official trainer capacity building program from Indian Nursing Council, certified in epidemiological tools and techniques from Johns Hopkins University, certified in nursing informatics from University of Minnesota, and trained on Schedule Y clinical guideline practice and bioethics by Aurum Ethical Research and Neonatal Resuscitation by Indian Academy of Pediatrics. Dr. Jasneet has around 21 years of experience in nursing profession in different cadre. In her career, she got a patent for community health nursing care bag and published 43 papers indexed in Scopus and Web of Science. Her H-index is 2 and I-10 index is 1. Dr. Kaur contributed her expertise for publishing many books. She is a recipient of minor research grant from Symbiosis International University. Madam has received various prestigious awards for excellence in nursing profession, namely International Best Leading Professor Award by World Research Council 2019 and Best Faculty Award in 2014 at Symbiosis College of Nursing. Now we welcome you, ma'am, for your presentation. welcome you, ma'am. Ma'am, your voice is not audible, ma'am.
Hello, am I audible to you?
Yes, ma'am. Now you're audible, ma'am.
I was actually giving the thanks to Dr. Sharda Ramesh ma'am, who has given this opportunity to be on this platform. So I'm sharing my PPT. Can you give the rights to me for the sharing?
Yes, ma'am. We are giving. Ma'am, we have made you as co-host, ma'am. Now you can share, ma'am. Screen is visible, ma'am.
Yes. So we will be discussing about the literature search and screening the articles. So as far as systematic reviews are concerned, the literature search is the backbone of that whole systematic review. What exactly the systematic review literature search is? Actually, giving a brief scenario, it is a well-organized search. In generally, when we are looking after the literature search, we can go randomly, but in case of systematic review, it has to be very well organized. It has to be very crisp, and you should know what you are going to search. So, what to look for this? What to look for exactly when you are doing a systematic review? You should be very well aware that what methodology you are going to use and how you are going to use and what you are going to use. So what we are looking forward in the literature search in case of systematic review, we need to know about the methodology of the literature, what we are searching. We need to know about the population, what we are looking after, and we need to know the sampling methods. We need to know the concept and techniques. Why we are looking at, so that we should know that what others have done and what we should do. Even they are helping in determining the extraneous variables affecting the outcome and identifying the faults or lacunae that could be avoided in future. So what is the exactly difference between literature search in systematic review or literature search in general? In case of literature search, usually it is answering a broad and descriptive research question. Wherever in systematic review, it is very much comprehensive, and we are seeking a specific answer of a specific scientific question. We are not going here and there. We are not going into the broad areas. Rather, we are just sticking to our research question. Literature search is usually less complicated and requires a lower degree of planning. But in case of systematic review, it is very much robust. It is planned. It is systematized planning. And we are looking after the eligibility of the literature search, that whether the literature, what we are opting, is it actually in sync with the protocols which we have defined or not. In literature search, we are usually identifying the gaps in the literature. Whereas in systematic review, we are answering the specific question by looking at the literature. So this is a broad difference between the literature search and a systematic review. So what is required in systematic review when we are looking after a literature in a systematic review? What we need to see? Before moving on to the literature search, we have to be very much confident what we are looking for. So 4 criteria are there that in short we are calling it as a PICO framework. We should be very well aware what population we are going to search, what intervention we are going to search, which control groups or what comparison groups we are going to see, and what are the outcomes we are looking for. I will tell you everything with examples. Nowadays, if at all you are adding certain timelines, then it is called peak code, or you are adding certain designs. For example, you want to just see only RCTs or only experimental designs or only cross-sectional design, then you can add S also. So peak codes, it will be peak codes. But basically 4 concepts you should be very well aware. One is population, intervention, control, and outcome. So before moving to the literature search, you should know which population you are searching, what is your intervention for the literature search which you are searching for, what is the control, and what is the outcome. So just take an example like effectiveness of NRT. NRT stands for nicotine replacement therapy in smoking cessation in Indian adolescents. So I am just looking for this certain literature for this particular statement.
So what is my population? It is adolescent smokers. Intervention, nicotine replacement therapy. So I want to see the effect of this intervention. Now control can be anything, or comparison, it can be counseling. Outcome, I want the smoking cessation or risk of continued nicotine dependency. I want to see the outcome. So I have these 4 parameters now ready for me. So when I will going to look for the literature search, I will use only these parameters. No other parameter will be considered for the literature search in case of systematic review. Now, one thing we keep in mind when we are looking for the literature search in various databases, every database is having n number of papers with them. So if I am writing, you are writing, our views will be always, at the disagreement level. So if I'm saying that adolescent smokers, for you it might be teenage, for you it might be youth. So there are many synonyms available for particular words. So when you are doing a systematic review literature search, you always use maximum synonyms which are actually available. Every database has their own terminology. So here I am giving you one example. For example, we have taken adolescent smokers as a population. So what can be the possible terms? It can be adolescents, it can be teenagers, it can be juveniles, it can be youth, it can be young adults, it can be young adult smokers, right? So similarly, intervention. We are looking forward for the intervention like nicotine replacement therapy. Now it can be NRT, maybe some studies have used short forms, maybe some studies have used specific drugs which are used in nicotine replacement therapy. So all possible synonyms you have to use, you have to search. It is not only that you will, usually students, what they are doing, they are putting in the Google about this particular statement, and whatever the searches are coming, they will take it. But this is not the right method. Whenever you are going to do the search, always use specific databases which are relevant for that particular study, and then use possible terms which are synonyms available for that, right? So using these databases to identify the control vocabulary term. Now, what is control vocabulary term? I will tell you later. First, only just you have to see that abbreviations or acronyms, then synonyms, antonyms, all things, everything you have to taken into consideration when you are looking for the study. You have to avoid outdated names, for example, handicap or for disability. Now we are telling disabled person. We are not using the word handicap. So you might not get certain papers if you are working on some concept of handicap. Similarly, certain procedures or certain diseases which are outdated, avoid those terms when you are searching for the papers. Also try not to use non-English alternatives. It should always be English alternatives. Okay. So, so what is controlled vocabulary? Now, controlled vocabulary means every database has defined their own vocabulary for particular terms, which we are calling it mesh in Medline. If you are using the Medline database, mesh terminology is there. If you are using CINAHL headings are there. So every database is having their own terminology. Just for example, you want to search cancer, right? So now if you will open a Scopus database, it might pick up the word cancer. If you want to go to another database, they might use it as malignancy. If you want to go to some third database, they might be using the word tumor or neoplasm. So every terminology is different, but the meaning is almost same. So that is why it is always advisable to use the different terms which are synonym to that particular term. Now, these are certain databases which are available where you can use the search. These are search databases. Now, which database is meant for which kind of, area, that I will let you know. PubMed, it is basically for the biomedical and medical sciences. Scopus, it is the biggest and the largest database which is covering 240 disciplines. You can, if you want to search regarding education, psychology, science, IT, engineering, agriculture, and all kind of disciplines it is covering. Then MBase, basically it is for biomedical research. CINAHL, that is appropriate for the nursing health sciences research. PsycInfo, that is for psychological kind of literature if you want to see. Global Index, that is for biomedical and public health literature, and Global Health, that is for public health literature. Now, these all databases are available. Some students, you might not have heard these words. You must have commonly heard PubMed, Scopus, but there are many databases which are available. Only the thing is that you have to log in, you have to create your user IDs and passwords, and then you have to do a login. Then you can go for the search. Now, nesting the similar things. Suppose you want to, you are searching for something related to influenza vaccine, and you have a research question: does influenza vaccine reduce the future risk of pneumonia? Okay, now in your terminology, you will use many Boolean operators: influenza vaccine, influenza vaccines, or flu vaccine, or flu vaccines, or flu shots, or flu shot, or influenza virus, so on. Like that, multiple synonyms we can use, and we have to put in one nest. That is called nesting of the verbs, nesting of the terms. That actually, while writing the systematic review, you have to tell, you have to write about the, under the search strategy, that what all terms you have clubbed together. Okay. So one single word have many synonyms which you have to nest together as per mesh category. Now, what are Boolean operators? Boolean operators are certain trigger factors which are available in every database, where you have to enter and or not. Now, going back, for example, we are using influenza vaccine, or influenza vaccines, or flu shot. These are or, means you want to see either or. Anything which is related to influenza vaccine, it has to come. But now you want to search the paper on pneumonia also parallelly, which is having certain impacts. Influenza vaccine is having certain impacts on pneumonia. So you will write influenza vaccine, or influenza vaccines, or flu shots and pneumonia, or the chest infection, like that. So it will combine the searches. Okay, these Boolean operators are used to combine the different concepts. This is a typical example. Now, if you are writing influenza vaccine, or adults, or pneumonia, then what will happen? The search will give you 3 types of papers. Few papers will be on influenza vaccine, few papers will be on older adults, and few papers will be on pneumonia, right? So you may not get all together standard results. It will be mixing up of the papers on these 3 topics. On the other side, if you are writing influenza vaccine and older adults and pneumonia, that will give you a papers which is having combination of these 3 concepts all together. So this search strategy has to be, you have to perform very, very crucially, where you have to write or, where you have to write and. So in this case, if you will write and, you will get a mix of results, right? Now, combining the search, that will give you all together the papers, and it may lead up to lakhs of papers which are available on these databases. Okay. Now, there are many databases which, when searching the multiple data, you need to search slightly to retrieve the comparable results. There are many available. I'm not going to be in detail in this, but however, just read the names. There are Polyglot Search, which is a tool to translate a PubMed or Ovid search to other databases, because sometimes few papers are available in one databases which are sometimes available in other database also. So there might be duplications, there might be transitions. So to avoid those things, there are certain tools which are available, which you can perform. And this, if going in detail about these concept, it will take another FDP. So other searching methods are, one is hand searching. You are doing manual search, which is one of the most popular way of searching the things. You can also search, it is not only always you have to search for the databases, you can also see the paper, see the references, and from references you can go to the particular paper and then you can cite that paper. So there are many areas, manual browsing of, manually also you can browse the journals, hard copies of the journals, everything you can do. It is not always only database you have to search, but however, manual searching also you can do. Now, what are the screening tools? Once your literature search, you have done this, you will get lakhs of paper or maybe thousands of papers. How you have to screen down which are available to you or which are relevant to you. So for that, Prisma guidelines are available. Okay, that is called a screening process. Now, suppose you have got 500 papers with you, but all 500 papers are not relevant to you. Few of them are not related to your outcomes. Few of them are not related to the age group which you want, or might be few of the papers are there where you have not received the full length papers. Many things are there. So how to screen down? So a Prisma, that is called preferred reporting items for systematic review and meta-analysis. These are the guidelines which are available specifically to report the systematic review literature search. It includes a procedural checklist and a flow diagram to illustrate the screening process. So out of 500, maybe 200 papers are there which are duplicate. So you remove that. You can write that 200 papers are removed because of the duplication. Rest 300 papers, then again you will search. Then again you will see that out of those 300 papers, you are not getting, there are again 200 papers which are not related to your results. You remove those papers. So 100 paper left. Out of that 100 papers, again you see that you might not get 50 papers which are absolutely abstract based and there is no full length paper available. You remove that. So rest 50 papers. So like that, it is a screening tool. It is narrowing down your research literature. Okay. So screening process is basically based on your inclusion and exclusion criteria. So that is what I have said. Before search, you have to jot down your PICO. What is your population? What is your intervention? What is your control? What is your output? And what is the inclusion and exclusion criteria? So if those papers are not fitting into your inclusion and exclusion criteria, it has to be removed. Only the papers which are mentioning and which are at par your eligibility criteria will be considered as a papers for your literature review. Okay. So what you have to consider the appropriate study population. It should be matched, appropriate intervention, comparable environment, and language that an article can be sourced and translated language if required. Okay. So these all things are there in the screening process. So when reviewing the full text articles, appropriate methods, sometimes what happens, you want to see only RCTs, randomized control trials, but you are getting 100 papers which are not of RCT, though it is related to your study population, though it is related to your intervention, though it is related to your relevant outcome, but it is not related to the methodology. You are collecting one type of papers, maybe RCT, but these papers are not of RCT. So you have to remove those papers. Sometimes the sample size of sometimes everything is matching, but you see that sample size are too small that it is not giving good results. So you have to remove this paper. So based on that, you have to remove the paper by justifying that these papers are not matching with the criteria. Then bias. Reviewer team, there should be always 2 reviewers when you are doing a literature search, and when you are scrutinizing the paper for your final list, you should have a teams of reviewer who should have a good knowledge of the topic, who should prepare the screening by doing a pilot screen and work independently. Suppose you and me are the 2 reviewers, you work independently, I will work independently. And if we 2 are having disagreement, we can take the 3rd person as a final for the opinion. Okay. So there should not be any bias. So this literature search and screening has to be done by the 2 reviewers, minimum 2 reviewers. Then final is the appraisal of articles. Now suppose you have got 50 papers or maybe 20 papers finally in your list, then you have to appraise these articles against the quality, that what quality they are having, whether these are good quality papers or not, which can be done by CASP checklist, which are available for the systematic reviews. On it is different for the systematic reviews and different for the RCTs. So this is a whole process of literature search, which is very exhaustive in nature. Usually students, what they do, they just go to the Google and they just type the statement and they are getting certain papers which they are writing for the literature. But in case of systematic review, it is not. Systematic review literature search is very, very crucial, very, very specified. And before actual search, you have to be ready with the criteria and norms. That's all. Only the final thing which I want to tell you, how it helps you for the systematic review. Maybe your other sessions are already covered this. Are the results are valid? What are the results? Will the results help locally? Is the study methodologically sound? So these all parameters you have to see. Thank you very much for this. So if you want to have any question, you can ask.
Thank you so much, ma'am. Dear delegates, if you have any questions, you can ask. No? No queries from delegates, ma'am.
Thank you.
Thank you so much, ma'am, for your insightful presentation. Thank you, ma'am. Dear all, we are now commencing the valedictory session of our event. I request the dignitaries to occupy the seats on the dais. Brother, இத மேலே ஏத்துங்க. Yes, ma'am. Yes, ma'am. We now request our Mrs. Maheshwari, Assistant Professor VM Con, to give the summarization of today's national seminar. We welcome you, ma'am.
So very good evening to one and all. So I'm here to present the overall report of a national seminar on systematic review and meta-analysis, nursing perspective. So we have started with our first session by our principal madam regarding an introduction to systematic review and meta-analysis. Our next session by Vishnu Bhatt sir, advisor medical research, professor of pediatric and neonatology, AVMCH, Puducherry. Sir has dealt about formulating review questions, and we have after her session we have gone with an inauguration session. Here we have eminent personalities with us, Dr. Nalini madam and Dr. Dean HP madam, Dr. Mahalakshmi ma'am and Vishnu Bhatt sir, vice principal and principal madam and our research coordinator in the inauguration session. After tea break, we have started our session with Dr. Baby S. Nayak Madam, Professor and Head of Department of Child Nursing and PhD Coordinator, Manipal, College of Nursing, Manipal. Madam have dealt with structuring and writing systematic review and protocol. So next session by Dr. Shijila Madam, Professor, Department of Medical Surgical Nursing, College of Nursing Science, Dayananda Sahar University, Bangalore. Madam dealt with systematic review and the Cochrane review. And next followed by Dr. S. J. Nalini Madam, Professor and Principal Head, Unit of Nursing Research, Sri Ramachandra Faculty of Nursing, Chennai. Madam dealt with data extraction and quality assessment. And we have gone for a lunch. After lunch, we have started with the session by Dr. Sai Lakshmi Gandhi Madam, Professor and former Head, Department of Nursing, Nursing Consultant in Psychiatric Rehabilitation Service and Adult Psychiatric NIMANS. Madam dealt with meta-analysis, fixed and random effect models. And followed by Sir have presented his presentation, Dr. K.T. Harichandra Kumar Sir, Department of Biochemistry, Biostatistics, Jawaharlal Nehru Institute of Postgraduate and Medical Education. Sir dealt with networking meta-analysis and multivariate approaches in meta-analysis. So followed by Dr. Lily Podur Madam, Associate Professor, Department of Obstetrical and Gynecologic Nursing, Nursing College, AIMS, Bhopal. Madam dealt with grading of recommendation, assessment and development and evaluation. And other session by Dr. Sharman Singh Sir. As Sir was not well, Sir got hospitalized, so we have gone for a medical emergency. I have presented Sir's slide. So here Sir have dealt with risk of bias assessment and publication bias. Followed the last session taken over by Dr. Jasnit Kaur, Associate Professor, Symbiosis International University, Pune, Maharashtra. Madam dealt with literature search and screening of articles. So this is all about our presentation statistics. And next is we have around 12 papers were presented by the delegates from different colleges, and also we have around 3 poster presentation which has been presented by our delegates from different colleges. And by this poster and paper presentation we have selected first 3 prizes, and prizes will be shortly will be going to announce the prize winners of both the paper and poster presentation. And next is about the participant number. Total number of delegates which have participated in the national seminar is around 141. In that nursing fraternity is around 71. Faculty from SHS, that is Allied Health Sciences, it is around 20. And UG and PG students from various colleges is around 50. So this is about the statistics of participants. And we have conducted pre-test and post-test, and this is all about the comparison about the pre-test and post-test wearing. And next about the feedback which has been given by the delegates for us, which means the objectives which is achieved by the seminar is around 100%. And about the hospitality, 50.5% have said that strongly agreed with our hospitality. And next is about the time management. 50.5% have given a score for agree, and 40. Next is about the research presentation. Around 48.6% people have given strongly agree with our resource content. So this is all about our overall feedback of our national seminar.
Thank you so much, ma'am. It's time to honor the best paper and best poster. Now, first paper presentation. The first prize goes to Mr. Rajesh, PhD scholar, Vinayaga Missions College of Nursing, Pondicherry. Now, I request the dignitaries to occupy the seats on the dais. The first prize for paper presentation goes to Mr. Rajesh, PhD scholar, Vinayaga Missions College of Nursing. Now I request Dr. Sharda Ramesh, Principal, VM Con, to give away the prizes. And I also request our TNMC observer, Dr. Lakshmi Ramamurthy ma'am, to honor our PhD scholar. Second prize goes to Mrs. Amrita Shanti from College of Nursing, PIMS. I request ma'am to receive the prize and certificate. Mrs. Amrita Shanti from PIMS. Can anyone come and get the certificate on behalf of her, on behalf of madam? place goes to Mrs. Santosh Kumari, College of Nursing, IGMC and RI. I request ma'am to receive the certificate. Now it's time for poster presentation. First place goes to Mr. Sundaramurthy, IGMC College of Nursing. We welcome you, sir, to receive your prize and certificate. First place for best poster, Mr. Sundaramurthy, IGMC College of Nursing. Give him a big round of applause. Second place goes to Mrs. S. Praveena, IGMC College of Nursing. We welcome you, ma'am. Second place for best poster goes to Mrs. S. Praveena, IGMC College of Nursing. Third place goes to Dr. A. Rajarajeshwari, Vinayaga Missions College of Nursing. We welcome you, ma'am. Third place for best poster goes to Dr. A. Rajarajeshwari, Professor cum HOD Department of OBG, Vinayaga Missions College of Nursing. Now I request our TNMC observer Dr. Lakshmi Ramamurthy ma'am to honor our organizing chairperson Dr. Sharda Ramesh ma'am. Thank you so much, madams. Now we kindly request the delegates to give your valuable feedback. Dear delegates, kindly share your valuable insights with us. So you have spent the whole day with us. Anyone would like to say your feedback?
Good evening to all delegates gathered here. I am Santosh Kumari from IGMC College of Nursing. From overall rating I will give you an excellent rating for this seminar because from the morning session you have well planned with all the sessions as well as the team coordination which you are having. Each committee is doing their work so perfectly without any flaws from morning till now. I really want to congratulate all the organizers as well as the principal ma'am of Vinayaga Mission College of Nursing for leading them so successfully for finishing this program so successfully. Thank you.
Thank you so much, ma'am. Anyone would like to share your experience? Now, I request our TNMC observer, Dr. Lakshmi Ramamurthy ma'am, to share her valuable insights.
A very good evening to everyone. Good evening, respected Madam Sharda Ramesh and Vice Principal, and also the Organizing Secretary, Madam Maheshwari and her team for such an organizing wonderful one-day seminar. If you speak about the systematic review and meta-analysis in nursing, this is a gray area. Even you might have gone through the various sessions since morning, almost we had 11 to 12 sessions. I don't know how far it has been comprehended by undergraduate and the postgraduate students. I know the faculties may have some idea about the systematic review and meta-analysis, but at the, because this area is a grain in India, because there are a lot of studies which is coming up in Western setup, but Indian setup, there are now the nursing researchers have started learning about systematic review and meta-analysis. So it is a need of the hour. I can say it is a need of the hour for organizing systematic review and meta-analysis. You know, because the evidence which is being created out of this kind of studies, it's the strongest evidence. Since morning we are learning it. But it has to be, I request ma'am, because one day is not sufficient to learn in detail about this whole process. It is, even I am involved in couple of studies in systematic review. Almost it is 9 months we are doing a data extraction and data reviewing and writing the various bias. We are almost in the defining bias stage only. It is almost 9 months it's over. So I request ma'am to take up in future at least a week workshop or at least a 3 days workshop with a hands-on practice. Because with the hands-on practice with each objective, because each session starting with the ma'am session was the first introduction, followed by the Butsa session was the writing and review question. What kind of the question you can write it and how it should be the format. Though the various speakers have listed the different aspects of systematic review and meta-analysis, but it has to be put on hands-on, then only it will be internalized, it will be comprehended by it would have been more beneficial if you could have had 3 days. But anyway, it is exhausting lectures we had from all the speakers. When I come to the speakers, especially thanks to ma'am for selecting especially the nursing speakers who has really knowledge on the systematic review. I hope many of the speakers we had today, they would have done at least 1 or 2 systematic review, or they would have undergone the systematic review workshop. They would have training, they would have undergone. For excellent speaker selection. Thank you ma'am for organizing such a speaker selection, because sometimes what will happen, giving any topic to any nursing faculty and they will just prepare and come and present. That has not happened today, because the speaker selection, it has gone from many I&I. There was a speaker from AIMS, there was a speaker from Mahe, there was a speaker from Ramchandra. All these people have, I can say I was searching it, they all had a systematic review papers in their PubMed review. They all had a really knowledge on that. In that say, sessions was, everything was going on well, but only thing is little, I understand it would be difficult to connect with the speaker when they are online. Okay, there are some deficiencies because they were not able to join with us here. It could be the problem of when we conduct in hybrid, we have to accept it. Okay, maybe upcoming sessions we may have it with the physical mode. Regarding physical environment, it's excellent. You are backed up with a good auditorium. Okay, the technical team, it's good. You have specifically, the team is specially working for they were able to rule out what was the issues when the slides were not displayed. Everything went on well. Food and participant presence, it's going on, it all went on well. Good. Thank you ma'am. I congratulate once again ma'am and her team for organizing such a wonderful seminar. Because it's not like other research designs. You all, at least now the knowledge which we have gained, I'm attending this is maybe the 4th time. But still I feel it is some kind of knowledge I'm having lacunae. Okay, I too have updated myself in certain areas. When you attend to a couple of times, you may have the little more clear with how to go ahead with the search strategy, how to write a paper. Okay, anyway, all the best for future. At least from the PhD scholars, I expect at least 1 systematic review at least end of your next academic year. If that is being done, ma'am, target is done. At least 1 or few. That's what I was saying, ma'am. If you train 2 or 3 people, faculties and PhD scholars once again with the hands-on practice, they'll be able to write it, they'll be able to come up with at least 1 paper by end of next academic year. Okay, all the best. Thank you.
Thank you so much, ma'am. We take your words and we will work on it, ma'am. Now I request our principal, Dr. Sharda Ramesh, ma'am, to honor our TNMC observer. Thank you, ma'am. Now, I request the dignitaries on and off the dais to raise up for the national anthem.
Janagana mana adhinayaka jaya he, Bharat bhagya vidhata पंजाब सिंध गुजरात मराठा द्राविड उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you one and all. Dear delegates, we have arranged the tea and snacks outside. Please have it.